ये वो पुराने वाला ही है। ये ये कुछ नहीं थोड़े डायरेक्ट नहीं वो हमारे पास ही
नहीं ऐसी नहीं पहले से कुर्सियां पहले लाल होती थी अभी ब्राउन होती है कुर्सियां चेंज हमारे टाइम में लाल हमारे टाइम में गुड मॉर्निंग कैसे हैं आप ये कुर्सियां पहले लाल होती थी हमारे टाइम में बार और सोफा सोफा है डॉक्टर तलवार ने वो डॉक्टर तलवार के टाइम में either probably they have I think only a small part where they see patients on treatment जो सामने जो पहले साइकियाट्री की होती थी नहीं वो हमारे पास and the wards are now on to the only machines are closed. जहाँ पे गेस्ट हाउस होते हैं 1 and 2 गेस्ट हाउस उसके one guest house is now divided and it has been taken up by facing the road. Gara sector they will turn it right. Radiotherapy, ENT, Oncology, मैं तो पहली बार देखा है सॉरी और मैं इधर तक उधर तो बंकर भी बनाया ना उधर बंकर भी बनाया तो ये ट्रॉमा वॉक करते हैं तब भी नहीं आप चाइल्ड actually at one time we had Maya extension. एक्सपेंशन तो होनी है इधर पैसेज ऑफ टाइम इधर तो वर्टिकल में चंडीगढ़ में प्लान है
Good morning, everyone. A warm welcome and heartfelt greetings to all the respected dignitaries, all our beloved faculty members, all our juniors and the dedicated staffs who all have assembled here today. I would like to start today's CME, the topic of which is CME on recent advances in oncology. To inaugurate, I would like to begin by welcoming all the dignitaries on stage. Kindly join us on stage. I'd like to welcome Professor Sushmita Ghoshal for a welcome speech.
Professor Sharma, my teacher, Professor R. Kapoor, my long-term colleague and friend, my teachers and seniors in the audience, my colleagues, students, staff of PGI or the Radiotherapy Department, friends. I welcome you all on behalf of the department and the Society of AROI 2001 to this one-day CME and alumni meet. Honestly speaking, I didn't even think that I would be standing here and talking to, considering the number of predicaments that came one by one. It began with the pandemic. We had planned that because in last year we had completed 50 years of the department in this institute, we had planned some kind of grand function to be held here. However, because of the pandemic, it was not possible. We started doing online, what I called Adda, or that is, we just had some sessions together, and there was this intense urge in all of us that we must meet physically. And that is why we took this desperate decision. Yes, we were in March, we will do this. But unfortunately, the third wave came. And then a series of events happened, which proves the fact that I am the face of Murphy's Law. However, the best thing is that Professor Kapoor and the entire team has organized a very interesting CME consisting of several lectures about the recent advances that are happening in our fields, and I'm sure all of you will feel enriched by that. Of course, we do have an alumni dinner where we are going to let our hair loose and have a lot of fun. I thank all of you for being here this morning. And now I would request Professor S.C. Sharma to say a few words.
Good morning, everyone. Professor Sushmita Ghoshal, Nee Chakravarti, Professor and Head Department of Radiotherapy, Professor Kapoor, and he was also former Director of TMH, New Chandigarh, also known as Mullapur, Professor Ayagiri, my previous colleagues, alumni of this department, as well as the ladies and gentlemen. I welcome you all to this CME program. I feel very happy to be associated with CME program, which is being organized to celebrate the completion of 50 years of this department. And I'm happy to say that I was associated for 40 years of these 50 years with this department. And I think I have the longest association with this department since it was first developed in 1971. This department was started by three stalwarts, Professor B.D. Gupta, Professor T.K. Datta, and both of them, they are no more with us now, and Professor P.S. Negi, the best medical physicist which we have in this country. He could not make it today, though he resides in Chandigarh only because of his ill health. Now, if you see, when I joined the department in 1974, this has a very little equipment in the form of one deep X-ray therapy machine, one old Cobalt 60 machine, which was also came as under Colombo plan, and it was old machine. And third Cobalt machine, to a second Cobalt machine was added in 1973, which was known as Janus. A lot of people may not be knowing about this machine now. At that time, this was considered to be the best equipment, though from today's standard, it was very, very primitive. However, department always tried hard to get the latest possible technology. The first development took place in 1980 when a simulator and the TPS were introduced in the department, first time in the country in any department. And Dr. Ayagari was responsible for bringing those two equipment under a project from Government of India. Later on, we keep on adding the equipment, and over the next 20-25 years, we added almost 4 to 5 linear exciter. We had 3 Cobalt machines and 3 systems of brachytherapy. And therefore, by the time I retired in 2014, I'm happy to say that this department was one of the best equipped in the country, and therefore it was able to provide all types of radiation techniques which were available to our patients. And this development also helped in the better teaching of the students. The second important part of our department is the teaching. MD program of PGI is well known all over India as well as abroad also. This is the most structured program, and our students excelled very nicely doing MD from this institution. Most of them, they went out. Large number of them, they are working in the institution within India, and 20 to 25 of them, they have gone abroad, and most of them, they are doing very well. The third component of our department, research. We were involved in clinical research, and our research in the field of gynecological brachytherapy is well known and is published internationally, and department still keep on doing research in this area. Though we have published data in large number of other areas also, and I think by this time we must have crossed about 1,500 scientific papers which were produced over the last 50 years in this department. The teaching, as I told you, is the most important part. And for teaching, one of the components is to organize the conferences, CME programs, seminars, and workshops. I consider the CME program most important because here you pick up one, what is called the subject or the title, you discussed it extensively, and in this small group of people are involved, therefore interaction is better, the transfer of knowledge from one to another is better, and therefore learning is much better with CME program. So I am quite happy that the CME program, which is organized today on recent advances in radiation oncology and oncology, it will benefit each and every one who are going to attend this program today. With this CME program, we will have alumni meet also today evening. A dinner has been organized where we will share the old memories, both good as well as bad, and we will interact with each other. And I am quite sure that every one of us are going to enjoy this all together. So therefore, with this, I welcome all the delegates and wish for the success of the CME program. And with these words, thank you very much.
I'd like to invite all the dignitaries to do the honors of the inauguration by lighting the lamp. Thank you. It's my pleasure to now invite Professor Rakesh Kapoor for a vote of thanks.
Thank you. Respected Dr. Sharma, Dr. Firoza Patel, Dr. Sushmita Ghoshal, and all my senior PGI alumni, those who have been in the department before me, and those who have come from long distances and they have joined the department after me. I think it is customary to say vote of thanks, but today's event has something special. My first thanks goes to Dr. Sharma. The reason is the impetus is always given by a teacher. And the event which we are seeing today, I think that Sushmita will agree to me, with all the obstacles which are totally unseen, we faced them. And he asked me that we should do it because there were some peculiar dates which we never wanted to overshoot. Sir, I am thankful to you. Again, a teacher gives you an impetus. It is proved even at this age of life. So I sincerely thank you for that, sir. I am thankful to all the other colleagues in the department, including our technological staff, all those people who are here, who have the residents, both senior, junior residents, the people, those who are from the PGI technological departments looking after the audiovisuals, and the administrative staff who has been helping in writing the mails and other things to the people, those who are coming from outside the PGI Chandigarh. My special thanks to Dr. Jalali and Madam Kataria, because I know how they have made it. It was not easy for Dr. Jalali to accept the invitation, and just on my phone call, they accepted to be speaker. And just with the short span of 10 days, I think it is not easy to prepare a lecture also on a topic like research advances, and they accepted. They made it. Dr. Jalali, thank you so much. Madam Kataria, thanks a lot. Despite of such an uneventful happening in the family, still she agreed and she made it to come here. At the end, I like to thank the God Almighty who gave us this strength that we could manage this event, and because of that only and the blessings of the Almighty, we are all together here in this hall. Some of us have come after long years. I am also coming here after almost 2 years. So thank you so much. And with this, I think most of the things have been already conveyed by Dr. Sushmita. We all will have a good dinner, and we all will have all sorts of discussions there which will be related maybe to the topic and maybe to our families. Thank you so much.
I'd request you all to stand up for the national anthem. Thank you, everyone. We'll now be starting with the CME lectures.
Good morning, everyone. To start with today's academic session, I would like to call Dr. Rakesh Kapoor as the first speaker. He'll be talking upon health economics in oncology policy and its role in radiation oncology. I would like to call Dr. S.C. Sharma to chair this session.
Let us start the ball rolling. The first lecture of the CME program will be taken up by Dr. Rakesh Kapoor. I don't think he needs any introduction. He will speaking on the health economics and oncology, policy and its role in radiation oncology, a very important subject. Dr. Rakesh Kapoor, please.
Thank you so much, sir. Hira, can you switch off the lights? Thank you. So with the permission of the chairperson, the topic which I have selected myself, in fact, when we were making the scientific program, I thought let's give something different, a different ball game to radiation oncology with talking about the health economics. We all know that this topic has been now I'll say rolling around in whole of the world because oncology practice is leading to a lot of financial toxicity to the patients. So with that thing in mind, I thought let me dwell on this topic and put up certain nonsenses and both nuances. The two words I have used deliberately because in the slides which I am going to speak, you will try to divest and digest yourself how we are handling the cancer patients, what the world is thinking about it, how the analysis are being done scientifically, and where we have reached, particularly at the end, a few slides about the radiation oncology topic. Why health economics is important? The first thing is healthcare a commodity to be bought and sold for profit? Or is it a basic human right that should be accessible to all citizens? This is the most important question which the scientific strata needs to understand. Economics in the market is basically driven by the commodities. And we all know when we talk to the economists, they always go by the GDP data, they always go by what is procured, what will be the need in the society, and how the things are going to be produced, how much is going to be consumption, and at the end, what will be the profit to the stakeholders. This is most important component. And in health, the next line which I have written, is it a basic human right that should be accessible to all citizens? So should we talk of profit here, taking health as a commodity, or should we think of something else? This is what is important in today's scenario. Why it has evolved? Look at 19th century era of modernization and when the actual medicine started developing in the whole of the world. It was after World War I, World War II, and extensive motion research started, and this is the time when actually the radiation oncology also started coming up. We know the year when the Röntgen was discovered. We know when the Marie Curie started discovering radium. Almost something in the 90s, we all started doing research in the field of radiation oncology also. In 1901, if you look at the expectancy at birth, at UK, which was available at that time in the Indian scenario was not available, but it has dramatically improved in India also. It was 48 years for males, 51.6 for females. And now if you look at after 80s, you can see that it is 71.4 years for males and 77.2 years for females. If we go towards Indian scenario, again, our life expectancy has also increased. For males, it is almost touching now 69.8, and for females, it has crossed 70. So that means somewhere it is realized that it is not important that now health we are achieving, but what is important is focus is shifted to not mere living, but the quality of life concept has come. And I think in radiation oncology, we all knew it. Madam FD Patel brought the concept in palliative care only, what is the quality of life, to our department way back in 80s. So that means at that time also quality of life in cancer patients was already known to us. But the change for guidelines in accepting these various formulations which are coming in healthcare in oncology with the state-of-the-art advancement is something which needs to be balanced. And that is how we need to now think that how economics can be balanced with the healthcare of an individual. What is important is improving outcomes versus increasing costs. Between 2000 to 2017, global health spending grew by 3.9% per year, while the economy only grew by 3%. Initial 2-3 slides, I am sorry, you will have to bear up with me because it is important for the residents to understand what basic economics is, and that is how you will later on correlate it with our technology and other things. So I'm just seeing this. This is something basic in oncology and healthcare. This spending rose dramatically for HIC, MIC, and LIC. MIC is middle income countries, LIC is lower income countries, and HIC are the high income countries. So you can see the rise in the spending, which is rising from almost 3.9% to 7.8% in LIC, and MIC it is 6.3%. This increase of spending, and you look at the disparity in spending. If you look at the LICs, it is only $41 in 2017. 41 to $2,000 means GDP per capita. That means on an individual how much money is spent in LICs. In HICs, $2,937. So this means the gap is too much. Now, if you see this gap, it ranges enormously, 13% to 69%. So this gap is filled by someone. Who is filling it? It is OOPS. That is out of the pocket expenses which a payer or a patient, they are paying for it. The health is being still, our expectancy rate, life expectancy is increased, our cure rates have increased, our quality of life we are trying to improve, but someone is paying for that. So who is paying? This is out of pocket expenses which are more than doubled now, and you can see the difference here which I was talking about. Now, as a policy maker or as a government, it becomes important for us to think of it, because why it is important, it may look The same patient goes to Dr. Jalali, he feels proton should be given. Why not? All of us are right, but there is a information asymmetry to the patient. Patient does not know that which is better for me. But from economy point of view, the cost is hugely varied in all three setups. Dr. Shabab have talked about this because he has the 3D CRT setup in his hospital and there is no other hospital competing with him. It is the best available to him, so there is a monopoly. The person who is sitting in Chennai, he has 15 private sector hospitals who are having everything available. This is known as oligopoly. They have, all hospitals are giving. Dr. Anand is there in Delhi. So if one person goes to him, other person goes to different hospital, it will not be easy for them to convince to that patient because they will show the toxicity rates, the survival rates, how it is important. So there is a asymmetry, what we are telling to the patient. But money-wise, it is not asymmetry. Money-wise, it is the expenditure. That expenditure the patient is ready to pay. There are studies on that also. I'll talk on that, how they are ready to pay for that. But important is the government sector and the policy maker, what they can do. I'll show the discrepancy in our country and the rest of the world. What is the importance of the healthcare now? This is journal I talked about, giving some examples in between so that the things become easier to understand. The concept was introduced in 1960 when the quality of life came into existence, and it concerns basically with the efficiency, effectiveness, value and behavior are two important parameters in this, which cannot be measured by any mathematical way, but now we are doing the analysis of quality of life in that. So if we simply put it together, all financial aspects of healthcare system allow the policy makers to take decisions to acquire resources and do best utilization in promotion of health. That is why in our country now, UHC policy is already being governed. That is universal healthcare policy for the country. So basis is this. We have reached to it now, but it was already done in UK. Nice studies were there. It was already done in US. It was already done in Scandinavian countries. We should have quantification of resources. We should know that what effect or efficiency of these resources is there on the healthcare, and then we should start allocating them according to the area, according to the disease. I'll talk only of oncology, whether medical, surgical, or radiation oncology. The resource has direct costs, it has indirect costs and intangible costs. Direct is, we write something, injection paclitaxel, 10,000 money is paid, this is direct cost. Go and bring gloves, go and bring needles, direct cost. Indirect cost is which is not shown in this area. The patient is basically going, now you have given something, the patient has developed a complication. Neutropenia, now the indirect cost comes. Antibiotics, growth factors, platelet-derived factors, everything is given indirect cost. Some of the areas like, sir will check me out if I'm wrong, in our time, sir, when no ERP, only ERP are available, test was available, we could reduce certain parameters in the patient profile, and sir used to say, just put on this, it will be fine. We never had the prognostic index features at that time to actually correlate to the survival in months or weeks, like the more and more tests which are done at molecular level now. I am not at all saying that it is bad. What I am bringing home is there are indirect costs involved in that. HER2 new one, there are 10 more after that. So all of them are, there is almost a battery of the tests which will be done, and then you will tell to the patient there and then that now if these 3, 4, 5 are there, your parameters are this, you will survive for this. So these are indirect costs. It is not related to the consequences related to the primary cost. The third is the intangible costs. Intangible means the patient is coming, staying, he is eating food, attendant is also staying somewhere, they are spending on that. And then there is a psychological parameter on that. He is not working, he is on sick leave, he is paid from the department for a sick leave. He is also paid in this sick leave because he is a government employee and he has given something during for his pension contribution, so the government is paying for that. So that means from somewhere the policymaker is getting the money. So these costs are important when you do resource allocation. Similarly, in healthcare programs, this is always kept in mind. That is how I'll show the Ayushman Bharat has come in our country. What is the improvement at the end? Again, we are not measuring it with these costs. The improvement parameters which we are measuring is only related to progression-free survival, how many years you have lived more, or time to progression of the disease. The overall survival in few malignancies, definitely. But in most of them, it is progression-free survival, time to progression. So cost versus health improvement parameters, they are not coinciding. That means we are not in an economy market which I was talking of. So what I mean to say is that please don't compare the standard economy with the healthcare economy. Always try to have something different in mind. On the other hand, this is patient-related, health technology. There is an enormous development in the health technology. Sir has just said when the department started, we had only a cobalt from the Colombo plan. We had another cobalt. We brought linear accelerator. Gradually and gradually now we have the state-of-the-art technology in the department. Same happens everywhere. In some sectors, somewhere the private player is spending the money, they are getting it at the upfront only. But in government sector, one by one, step by step, we are getting it. So that means the health technology is already being developed and somebody is paying for that. The machine is not coming free. Somebody has paid for that machine. 3 crore cobalt versus 20 crores linear accelerator, we cannot compare. So that means 20 crore has been spent. Government has spent 21 crores. So this cost is basically important now because healthcare economics is comparative. Here it is not working properly. So healthcare cost, which is causing a lot of, you can say, a comparative analysis failure. So this failure needs that studies should be there. You can compare that with this advanced technology, how much benefit we have got in patient care, and in that patient care, how much it has reflected on the survival without increase in any incidental or intangible costs. Now, what is happening in oncology? Compare all this and we will come to know what I have spoken in the previous 4 or 5 slides. Medical care costs for cancer in US were estimated to be 183 billion in 2015, and as per the projected increase of the cancer incidence, now it is going to be 240 million. You can see by 2030, 240 billion. How many dollars? And then look at healthcare expenditure on cancer care have almost doubled from 52 billion pound to 103 billion pound in UK from 1995 to 2018. Both this is nice study which UK people are doing. They have already now, NHS is directed now. Dr. Jalali will check me out if I'm wrong. There are packages now available. Same our country has adopted in the Ayushman. But we have done studies in our country. If you look at the expenditure wise, so the direct cost in billion which I was talking, cancer drugs and other expenditures, so you can see how much is the cost, and indirect cost, you can see how much is the indirect cost. This all is in euros. Loss of mortality in men, loss of mortality in women, and loss from morbidity. So all these are costing, this is calculated. How much will be the loss if the mortality rate is this in male, female, and how much will be the loss in the morbidity rate because of the morbidity. Now, to evaluate these things, you have some scientific models because nobody is going to accept it otherwise. If there is no scientific model, there is no statistics in today's era, nobody will accept a scientific fact in this in the world. So these models are basically value models. So we have 4 important models which are also known as objectives of health economics. Number 1 is the cost benefit analysis, which in other economies also it is the same. The other is the cost minimization analysis. It is again same somewhere. For example, one company is producing linear accelerator Varian. Let 5 come in the market, so the price will go down. That means we should do cost minimization. For the same treatment, automatically the price will come down. Third is the cost utility analysis. This is the most difficult analysis. It is basically QALY and DALY. Quality adjusted life years and disability adjusted life years. So both has to be correlated. One's gain, others loss. So that is important in healthcare, and we have parameters to do it. There are scientific methods. Public health people are trained on that. I'm sorry, I'll not be in a position to show you in detail, but we have parameters on that. And last is the cost-effective analysis. This analysis is important. Life years gained, improvement in functional status. So it is difficult to compare what I have said at the end. Who is going to tell what is the improvement in functional status? I may lose one finger and whole day I am crying that I have lost a finger, I cannot work, I cannot drive. On the other hand, there may be a second person who has lost a limb because of a surgery for a sarcoma, and still he will say, I am driving from one hand, I am going, I am performing my duty. So functional and psychological impact of cancer cannot be measured in an individual patient. It varies from society to society, person to person, and the availability of resources in that society provided by the government to look after these disabilities. So this is important because last parameter or objective parameter of healthcare analysis is very important. Now coming to the cost-effective models which I have talked, it is very simple. I don't think I need to say something on that, but most important is budget impact models which are wide variety of impacts which are done. Regulate your pharmacy, which is done in Tata Memorial Hospital. The pharmacy is under the hospital. They regulate it. Once you regulate it, automatically you will have lot of checks on the pilferage. Your cost per patient is going to decrease. The financial impact will decrease. So one way of handling will be this, that oncology cost can decrease. In this, there are different methods by which you can further decrease the cost. One very simple method, madam, in palliative care we are implying 7 दिन की morphine देना या 6 दिन की देना, वापस आएगा तो हम देखेंगे और देनी है कि नहीं देनी. Incremental increase and split. That means don't give full medication to the patient. He will spoil it if he doesn't eat it, but your cost has already gone. So that is how minimization can be done. Outcome matrix, you have these various societies which are doing it. One matrix I said related to the money, the other related to the quality of life or the disability, both on one hand. How important it is that whether statistically significant cannot always be clinically meaningful. I have cured the patient is all right, but still the patient is not working at all from cost point of view. So it is not meaningful to him. Still, whole day the patient feels I had cancer, I am of no use to my family, I have lost so many things, so many structures I have lost, my facial disfigurement is there, I will not go into this function, I will not go there, I will not spend, I will not consume. So indirectly the person is contributing to the fall in the country's GDP. But he is getting something for this disability. So that means both outcome metrics cannot be measured together in healthcare sector. So what to do? These inadequacies are there. So I said nonsense, I said nonsense, both the things. What are the nonsenses? The actual clinical treatment, complexity of superior and inferior treatment. I am sitting in PGI, it is a superior treatment. Shabab, you are giving inferior treatment there. Unavailability of data, but it requires something which has to do this study. CA cervix treated by 4-field or 3-field on a linear accelerator 6 MeV and CA cervix treated on VMAT technique, whether there was a quality data to show us after 10 years that there was some difference. How much? If we have, how much? Money-wise I am talking. And then for 10 years the patient has survived. I'll show you a study which we have done in PGI, and I was a co-author to that study, where we did a cost-benefit analysis for this aromatase inhibitors, tamoxifen versus the attack trials, how they were using it. And the money-wise we showed how much will be the benefit, and that was sent to the PMJY, and then the cost of letrozole was decreased. So I'll show you how it has been done. It is not a simple thing. It took 2 to 3 years to complete that. There is a statement which is known as Cheers statement. It is a very important statement, and it is basically related to the clinical evaluation analysis of the research statements. This is followed everywhere. It has almost 33 components, but only 24 are followed. We all are doing it. When you write a project for your research, you follow all these components. This basically has come from Cheers. The only component in the Cheers which in the Indian scenario, except the multinational, some of the drug-related trials, rest of the trials we don't do, that is the last 3 statements. The findings are basically done, title, abstracts, background, objective, what are your parameters, everything is done. But when we come to the incremental cost and outcomes, it is not done. In none of our theses we have done an incremental cost study. We don't do it because of resource constraint, because of time constraint. There is a specific period in which it is to be completed, so that is why it is not done, and it needs lot of I'll say follow-up with the patient who has the ultimate payer or who is the ultimate person who has spent money on that. Now, there are certain initiatives which are taken in some of the areas, some of the countries, and in that the Canadian Agency for Drug Technology, that is CATS, has already taken initiative, UK's Institute of Health and Care Excellence, then we have there are Japanese studies and FDA Modernization Act of 1997, which is already applicable in our country with the NPPA, the Regulatory Authority for Drug Pricing. So same is done in the FDA modernization also. Now, if you look at this paper, onward and upward, this was the economic evolution methods in oncology, particularly to oncology. So in the oncology setup, they try to identify most of the articles which were related to, actually they correlated that how much will be the cost effect. North American 38% studies and Southeast Asia 21% studies, Continental Europe 18%, and the most common cancer studies were lung, colorectal and breast. Why these three have been taken? Because we all know that the survivals are more in them, number one. Most of molecular studies have been done in that which are reflected in the cost parameters in lung, colorectal and breast. That is why these three studies were chosen in most of the country. And then common models, the Markov model and the partition survival model, both I think Shantam is sitting here. The variability and the integrity of different parameters is done in both the models. Markov tells you about the negativity and partition tells you about the positivity effect, like progression-free survival, time to treatment survival. And in the Markov model, you will see how much was the effect. Say for example, patient is given tamoxifen, osteoporosis, thromboembolic events, how much they occurred, even the MI events. So that is the Markov model. All these models are used by the statisticians in the healthcare sector. Similarly, the trends in the oncology management, United States also, they have done a study, and the point they brought home, which we were already doing in our country, but not scientifically, the quantity limits, split fills, and the step edits and pathway et al. That is what Tata model I am talking of. Don't give full medication. Always try to have the quantity limits. Your pharmacist should know that you have prescribed for 5 days. He cannot dispense more than 5 days. Patient goes to the market, 6 capsules are required. He says, I will not cut the strip, you have to pay for 10. It is very common, we all know it. So the out-of-pocket expenses are already risen. Similarly, patient goes to bring in something from the market, for example, THR is done. They will say, take all these multiple nails which are required, size 1 millimeter, 5 millimeter. How much will be required? We don't know, you take it. And they will take it because it is a package. Now, what comes out of the OT and how many has been utilized? Nobody knows. Let us be very frank to each other. So money has been spent, but it is not utilized. So there is no quantification. So where does this money has gone? That means you should have split fills and quantity checks. These checks are difficult to be implemented in many of the hospitals because of, we all know what reasons are there. I don't need to speak on them. There is a value framework, and we know the 5 bigger oncology organizations who have done this value framework in the pharmaceutical industry: ASCO, NCCN, MSKCC, ICER, and ESMO. They had various parameters which are related to what are the targets, the stakeholders, patient and physician, conditions addressed, and the combination therapies which are evaluated. Not only this, they have also done the breadth of evidence, trial sample size, how many things were done. At the end, they came to know that what is important is that the price, means the total price, and the expected total price per month on the course of therapy was analyzed by ASCO. Affordability scale was by the NCCN. Similarly, if you look at here, cost effectiveness, budget impact cost per year by ICR. None of them has actually done this analysis correlating to the budget analysis. The reason is simple. Many of the studies were sponsored. Many of the studies were drug company sponsored because they are all on pharmaceutical. So they could not do it at the end because conflict of interest was there. We did a study in PGI, cost effectiveness of tamoxifen, aromatase inhibitors, and switch therapy, adjuvant endocrine therapy for breast cancer in hormone receptor positive post-menopausal women in India. This is the Markov model which I was talking of. So you can see the events related to the intake of the tamoxifen, one model. The other will be related to the survival. What was important in this study, I think Sir is sitting here, there is still not a pure consensus that in a patient who is peri or postmenopausal earlier, tamoxifen, how many years and for how many years AIs, letrozole. Split initial letrozole or tamoxifen, again for how many years. Split for how long the tamoxifen, for how long the AIs. Out of the AIs, which AIs? Letrozole, Armidex, what you want to get? Again, the price difference. So these type of things are important. We try to, in this study, we try to partition all these parameters one by one, and we took almost 19 parameters related to the progression-free survival events as well as related to the cost analysis in rupees. And mind it, what we found that aromatase inhibitor letrozole was the best cost-wise. And the spend or the GDP expenditure per capita, which I was talking of, it was 12,936 rupees for letrozole, 13,686 rupees for tamoxifen, and 14,900 something for the split course. So this means what is important is the events which were occurring with tamoxifen, we analyzed it, they were lesser with the letrozole, but the price at that time for letrozole was slightly on the higher side because Femara was coming. And now market is flooded with letrozole, the price has come down. The Ayushman Bharat has taken it in the PMJAY, and the prices are now reduced by more than 58% by the government. So that means NEPA is already playing on that. A study was available to them, and that is how the things have come down, and it is available in the country. Look at the comparison again. All the things you can read from here. The recurrence of the management, contralateral breast recurrence, adverse event, and hormone therapy are related to this and related to the money in lakhs. What is the role of radiation oncology? Just 3-4 slides more. The impact of radiotherapy on cancer survival alone or in conjunction with other treatments has been estimated to be at 40% as compared to 49% of patients being cared by surgery and 11% by systemic therapy. This is for my resident friends. I am sorry to say, those who are switching on from after doing MD radiotherapy to DM medical oncology. You can see 11% cures by the systemic treatments, 49% by the surgery, and 40% by radiotherapy. Now look at the cancers where it is the radiotherapy which is important. Skin cancer, prostate cancer, lung cancer, cervix, lymphomas, both Hodgkin's, non-Hodgkin's, low-grade, and head and neck malignancies. Not only this, there are others which are curable with radiation therapy in combination with other modalities, whether surgery or chemotherapy. Alone, they cannot do this much of wonders. Breast, rectal, locally advanced cervix, locally advanced head and neck, locally advanced lung carcinomas, advanced lymphomas, endometrial, CNS, soft tissue sarcoma, pediatric tumors. So this means the clinical argument in this variability of care from the Radiation Oncology Society is there is a dire need for having the radiation facilities in the country because radiotherapy plays such a major role in almost all the cancers. So we on one hand are dependent on only 2 companies to have the linear accelerators in the country. That means the cost is governed by them. We have nothing to play in that. So we are in a serious situation where we know that radiation component is very important, but the cost is definitely related to the quantification done by the companies. A quartz analysis on radiotherapy infrastructure and staffing again was done by the ESTRO HERO project, already published in the Red Journal, and the THROG and TROT project, already published in the Green Journal. They definitely showed that there are major inequalities, number one, from district to district, country to country. If you look at these inequalities, we know that the economic health care on these inequalities cannot be taken care until and unless we don't look at it seriously. If you look at, this is a IAE data, just published in 2021. And the number of linear accelerators, brachytherapy machine and light and 3 machines country-wise and the region-wise already available. So you can see where India falls or the Asia falls. You can see the South Asia, you can see here, I'll show you the Indian continent here, it is 1 to 3. That means 1 to 3 machines per million population. Our population is almost 138 million today. Maybe once I'm talking, it reaches almost, it is going to reach 139 now. Already we are at the end. So 139 million crore is the population, but 1 to 3 target which we have to achieve, which means presently we have 686 or 720 machines in the country, linear accelerators, and we need 1380. You divide it by 1 million, it will come to 1380 if the population is this much. That means 1318 machines we require, but at the other hand, if we install at the pace of at least 40 to 42 machines per year, we are going to pace off in another coming 4 to 5 years. But it is not true. 6 to 7 machines or 8 machines every day are dismantled also. So they are to be taken into consideration. That means 40 installed, 10 are minus, 8 or 10 are minus. So objectively only 30 are left behind, which we are not achieving. Actually, we are achieving a target only of 13 to 15 machines. And that too, the private sector is using that machines, not the public sector, and not the government sector. So they are spending on that. They have to get money for this. Now, how to do something on this? That is where I was talking of the price indexing and the Ayushman Bharat Prime Minister's Jan Arogya Yojana. Manpower wise, you can see where we are falling and you can see the requirement. At least one radiation technologist for 200 to 250 or 250 to 300 patients per month. One medical physicist for 400 to 450 patients per month, and again the same 450 to 500 patients, one radiation oncologist. We are somewhere here. We cannot match. Now what to do? The important is action study which has been done in ASEAN continent, and particularly the countries which were there were Cambodia, Indonesia, Laos, Malaysia. We all know, and I'll be frank in admitting that the Malaysia is having a good healthcare system as compared to India. And in many parameters, they are better on us. And the reason is these parameters are averaged on various factors: overall score, policy planning, care delivery, health system, and governance. And at the end, it was seen, I'll just talk of the preparedness for the cancer. The parameters have been given different numbers. You can see the out of 100 how much. And India stands in the overall score at 51.6, policy planning at 69.6, care delivery at 41.5, health system and governance at 36. So where we are losing our survivals, our care delivery, or policy making. So health system and governance, acknowledging that cancer cannot be defeated by cancer-focused activities alone. It is not that providing machines will cure cancer here, because the reason is different. The reason is most of the patients are coming up at the end stage of cancers. So you cannot, even if you provide the technology, your parameters of the QA and parameters of the DALI, they are not going to improve. Your overall survival parameters are not going to improve, but your intangible costs are definitely going to increase. So what needs to be done? Strong positive association between income levels and performance in overall cancer preparedness. So try to prepare for managing at universal health care, better well-being, improving the SDG, and so that the occurrence of or the incidence or the factors involved are going to be controlled. Already NCD is working on that. Non-communicable diseases control. Not only the cancer will decrease, cardiac diseases, your lung diseases, all the diabetes, they all are going to decrease. So this means we have identified factors and playing on them, regulation for them. Smoking, alcohol, bad diet, everything you know, I'll not speak on that. Stronger association and a political will. Government passes a rule, it is not implemented. You need a person who has an iron hand at the center. He should fix it up and the people should abide by it. No hospital should be allowed to use at my own whims and fantasies. I cannot write a drug if the availability of that drug in our country is there in the PGIMER in the government hospital. It is paid by the government. There is a scheme already. There is an insurance already. So we are paying for that. That drug should be given to him. No substitution should be allowed. Automatically you will have a control on that. And it is done now. I think it is done in many of the government sectors now. Overall performance index, basically let us do something on the screening. Participation can be by, not out of the pocket, by the NGOs, other societies who are ready to pay for it, CSR activities. All has been tried in various sectors and this is being done. And these are the parameters where it is done. For all this, you need a strong, robust, population-based cancer registry. In our country, that is again lacking. It is not strong and it is not robust. We are trying to do something on that. So that is something which is important.
Dr. Kapoor, how much is left?
It is last, sir. And at the end, I'll say, looking at all these things, when you compare them and when you look at them, just think one thing. Human beings have unlimited wants, but limited resources with which to do, you have to meet these demands. That is Pareto optimality. It is a very important sentence. In health sector, this cannot be objectively followed. The reason is Pareto optimality means one should not have something should not be lost by somebody at the expense of benefit to the other person. This is Pareto optimality. But in health sector, it is very difficult. The moment we want to give some superior treatment, the out-of-pocket expenses are going to increase. There is going to be increase in something which is there on the other hand, not the payer. It can be patient, it can be payer, it can be government. So that means this standard cannot be maintained what is there in the normal economics. There it is always like that. Why not to produce more, spend more and get more money? The GDP is going to increase. Decrease the tax cost for some time. RBI directs every day tax liability decreased so that the spending increases. Push some money to the wages so people start spending so the country is going to earn. Can you do for health this thing? Somebody gives me 3 lakh rupees every month and say you will be ill and spend on that. I will not do it. So this is something important. Thank you so much. I am sorry it is slightly elaborative, but thanks a lot for patient hearing.
Thank you, Dr. Kapoor, for a very nice presentation on the subject. This is the hotly discussed subject nowadays by the government, by the hospital, and above all by the patients, because treatment is becoming very costly every day. Even people like us who are in the higher income group will find very difficult to have the cost of the treatment. So therefore, Dr. Kapoor has already given the different problems which are associated with this, different reason for why the cost is going up, and he has also given the solution for them. Though they looks very simple on the slides, but they are very difficult to follow in practical terms. So therefore, this is very, very important. Any questions from the audience or any comment? Yes.
You know, I will tell you the real world situation. What you have said is right. Now, you always say that 70 or 80% of the facilities have to be put by the private sector. Now, private sector will only spend money if the money comes back in 5 years or 6 years. If the money comes back in 10 years, private sector will not put money. Now, I'll tell you one small example. I have 3 centers, Delhi, Indore and Ranchi. Now, everywhere we have paid 23% custom duty, which government does not reduce. In Ranchi, which is running on 90% Ayushman, it is radiotherapy which is supporting surgery and medical oncology, because charges are so atrociously low that if radiotherapy was not there, the hospital would have closed. And believe me, as a company, after paying all expenses and treating about 60 to 70 patients on Ayushman rates, surgery, chemotherapy and radiation, as a company, we are earning just 2 to 3 lakh rupees a month. So it is total charity. Now this charity, till what time we will do? We have spent 8 crores on the establishment. On the other hand, you see Delhi. Delhi, our revenue was many times more. But yes, Delhi, you have to have, Herceptin, which comes the research product, temozolomide research product, because hospital gains 40% out of this. And if they don't get this money, where will the money come from? So it is a very, egg and chicken situation. But real world situation, I am telling you, unless government gives me a concession of duty free, I will give. So, it is a very difficult real world situation. Corporate sectors, when Apollos and things are fine. But Apollo and Fortis and Max will never go to Muradabad or Aligarh or Panipat or Karnal. They will always go to
big city.
And if you have to provide facilities, you have to have a center in Hisar. You have to have a center in Muradabad or Aligarh. So you have to be near the patient. So that is the real world situation, and I don't think in another 10 years we will be able to implement.
Sir, I have already said almost, sir is saying 10 years. The launch pad is thinking on the government side is for more 15 years. So the targets are already set for 15 years. There are few targets, sir, which I think you must be knowing because you are sitting in Delhi. Few have been already achieved. And now the pressure which the Prime Minister is putting, Atmanirbhar Bharat, is related to that. Let's have our own equipments. Linear accelerator is not at the forefront there, sir, because cancer is always at the end. But in many other things, the cardiac stents, they are already prepared. Even if you ask me, in the radiation oncology side also, the iodine sources are now prepared in India only, in the Brit. I hope Vijay must be knowing it. For prostate brachytherapy, now we don't have to get it from outside. It is available in our country. It is already being patented and ARB clearances have been done. So it is available. Sir, see one thing now, we have to see where we need to target, and I think all the stalwarts sitting here, they need to write something on this to the government, and the younger generation is definitely going to take up because there are very few takers for the radiation oncology in the government committees. Sir, please accept it. I may not be in a position to speak everything on this dais, but we need to have some support here. So until and unless our own stalwarts, they give an impetus, they give something in writing, the portals are available, effect is going to occur, sir. I have shown you one study from here. It was north and south. We took 2 centers. The second was in Tamil Nadu because their healthcare system price indexing is excellent. And I am grateful to the people from the public health who were working day and night on this. That is how we could ultimately, with various meetings, it was conceived, and then only the price reduction. We have to show it, sir. People ask. It was not easy to ban the non-smoking things like those filters which are coming in the country, but it was a hard hand. Ultimately, overnight decision was taken in the DGICMR. Otherwise, it would have not done. The pressure was from all tobacco companies in the world, and one man took a decision, and next day it was in the parliament. So somebody has to help us out. That is only the thing we can do it.
I think the government has to take more responsibility and take tough decision, only then it is possible. I agree with Dr. Huku that private sector, they have their own problem because they have to earn money. So they can't do much, but it is ultimately government which has to do, and we have to advise or supplement the government, only then it is possible to reduce the cost of the treatment. Any last question, please?
No questions.
No questions.
I don't go into political overtones in this. My fundamental objective of raising this issue, when these institutes were established, and if you read the way in which the Assembly Act or Parliament Act reads, it's entirely something which states what it ended after 50 years is entirely different. Okay? Somewhere on the way, we've gone astray on this thing. Fundamentally, these institutes were established as referral hospitals. They became general hospitals. Okay? Every patient flocks here. Fundamentally, these institutes were established for teaching and training and research, not for patient care hospital. A patient is required for teaching and training. That is the way these institutes were formulated. Whether it is at undergraduate, postgraduate, super specialty, or only postgraduate level as this institute stands, or only super specialty as Sanjay Gandhi stands. I worked in all three institutions. For example, you compare yourself a public sector hospital, which is on budgets and which is on taxpayers' money, versus a private sector hospital which invests money and wants to recover money. They are in a revenue generating model. You are in a teaching training model. I provide the workforce to private sector hospitals. They don't spend one penny on that workforce. They want to earn out of that workforce. All my students or residents are examples of that. Most of them work in private sector. Okay. Now we forgot that particular thing. We are looking at private sector as a care provider at this moment compared to what government sector does. Because government sector is lacking with facilities or infrastructure. There is a model implemented in Sanjay Gandhi that every patient has to pay, which was not originally there in All India Institute and PGI, okay, except for the OPD card charges. Sanjay Gandhi earns 25% of its budget through patient charges. But the unfortunate part of it is this 25% budget is not given back to the institute as an access to the annual budget. It is cut from the annual budget and adjusted, whatever you earn. So you end up in the same coin. So we are spending taxpayers' money for training workforce, which we provide to private sector. Private sector is utilizing that workforce for earning their revenue. So there is a vast difference between the two models. Patient care is altogether an entirely different topic. Patient care is dependent on the infrastructure you have. Patient care is also dependent on the type of faculty you have in a department and their background and training. And a faculty which exercises independent decisions, not via tumor board or via any of these things, is a difficult problem to control for any head of the department or any institute as concerned. You must understand the basic fallacies of these systems in order to work out. I always used to say that if there is a department, if there are 5 faculty members, I need the 5 faculty members with different strengths in the department. I don't want to duplicate it. Because as a department, my department can provide what is required to be provided to the resident who comes for training. And that is the fresh air in the department. All others is stale air with the assessment promotion scheme implemented in this institute. Because you are inbreeding. Any inbreeding generation will degenerate over time. Let me tell you this very clearly. I am one of the opposers to this assessment promotion scheme. That killed the entire system. Because there is no fresh air coming. I came as a fresher to PGI Chandigarh. I came as a fresher to Sanjay Gandhi Institute. I am not an inbred person. There is a difference in thinking. If you have an exposure from outside institute, you bring new ideas. If you are only in the same institute, you develop a tunnel vision. So your interaction also depends on the people who are there working with you because they are also inbred.
Sir, our country is a very complicated process.
I'm not talking complications. Why? We have done these mistakes.
We have to face those complications. We cannot have ideal things over here.
We have
because of the population which we have.
We have done these things for our own promotion, so we should accept our mistakes. I'm telling that.
Okay, I think we are gone overboard. No, not now. Because there is no time, we have already 1 hour. So therefore, I close down this lecture. Thank you very much, Dr. Kapoor.
Thank you so much.
And thanks the audience also for their patience hearing. Thank you.
There is a slight modification in the program. We'll catch up after having a cup of tea.
आपका लेक्चर मिस हो गया।
यूक्रेन में जब हुआ तब रियलाइज कि क्यों जा रहे हैं, तब हमें पता चला अवॉइड और उधर से इतना कम why we cannot increase our
हाँ जी मैम। रुक जाओ।
वो वैसे टाइम लो और स्पीकर पे भी बढ़ाना, भी चाहिए हमें। आज नहीं काम है, भी बढ़ाना। तो समझ में आ जाएगा।
रुक जाओ, एक मिनट। कोई नहीं। इसको अलग से कर ले। हेलो हेलो हेलो। बराबर है, दोनों साइड से, ठीक है। हाँ ये इसके नीचे रखना है यार, चेयर करेंगे ना यहाँ पे। किधर आ यार पहले। लो थोड़ा इसको, अरे इसको खोल लिया यार, ऊपर लग जाओ, पीछे लगाओ, निकाल दो इसको, पिछला प्लग लगो। हाँ निकाल दो। आराम से आराम से। इसको ये इसको ना ये निकाल दे रहा है, साइड से ले दूसरी भी ऐसे ले, इसका साइड से ले। कोई बात डरना आ जाना ऊपर। देख तो तेरा ये ऊपर जाएगा फिर, हाँ? उस पर रहेगा तो भाई डाउन हो जाएगा। हाँ? इसको उठा दे फिर, हाँ कर ले जो, इसको उठा, इसको ग्लास देना, ग्लास दो। ये तो लेके आने पड़ते हैं यार, ऊपर नीचे हो जाते हैं। करनी है ना, वो अच्छे से नीचे नहीं करना, कर लेकर तो काम ही करना क्या करें। ये अपना पड़ता है टाउन पर करना नहीं पड़ती। चलिए अभी मैं ना ऐसे देना पड़ेगा, वो और तक ना और चक्की अब ये दोनों साइड का कर इसको बराबर ही सही है बटन वैसे तो ठीक ही है लेकिन फिर दोनों जगह सही है मैं बताता हूं ठीक है मतलब ये पता क्या हो जाएगा इसको इधर उधर करेगा ना तो पूरा पूरा ये इधर ज्यादा आएगा तो इस कुर्सी पे कर दो पर इसको ऊपर पौड़ी पे पौड़ी के ऊपर कर दे कर ऊपर कर रहे नहीं था तभी इस साइड को उठा दे बस तब वो इसकी हाइट अच्छी हो जाएगी है इसको डाउन करता हूँ इसको डाउन कर देगा ना फिर सब तू देख ले यार ये ना हो ये वर्ड नीचे नहीं आने चाहिए क्योंकि ये जो फोटो खींचनी है ना बस अपने हिसाब से कर दे बस
Welcome to the next session after having a very nice cup of tea with full of nostalgia of PGI mess. Dr. Jalali is going to talk on the very modern armamentarium which we have now, is a proton therapy. We have not large experience in India, but these are Dr. Jalali is one of them who is having the vast experience in the Indian scenario. Dr. Jalali, please.
Yeah. Thank you very much, Dr. Sim, and it's a great. These are the things to be kept in mind. As I mentioned, Loma Linda was among the first ones in California, then came to Mass General, Uppsala in Sweden, and largely what we used to hear was that this was essentially a very technically demanding and very cost intense, but also resource and human resource intense as well. So the fair amount of technology, physics, clinical oncology, and so on and so forth were used. The first time I saw the Proton Center was in 2006 in the National Institute of Radiological Science, NIRS, as we call in Chiba, Japan. And we were struck as to amount of it was like 3-4 kilometers from the synchrocyclotron to actual gantry. And it was a very, very large facility. I'm sure some of you may have already visited. There was tremendous amount of workshop, additional power, time consuming, because the beam was called a scatter technology, and it was like you had to use, like we used to do pre-MLC era, the seroband blocks. It was almost like that. You use a lot of apertures, collimators, and on each beam. And then, of course, we had also some difficulty in the energy of the beam. So therefore, it is absolutely important to discern between what is a proton and the modern contemporary proton. And the revolution started take place about 99, 2000, about 20 years ago. But the real thrust took place about 10 years ago. 4 or 5 things happened. Number one, the beam came from a large beam, like we say, like a torch, to really a pencil beam, akin to an IMRT kind of a photon technology. So we had a very small spot size. In our center also, the smallest spot size is 3 millimeters. So that became very good. The energy increased from about 50, 60 MeV to 230 to 240 MeV. The one that we have is between 70 to 230. So that became better as well. And the great ability of the pencil beam technology to kind of identify the target and divide it almost like a bread slice, and then put the points. It's almost like an IMRT, what we call spot by spot. Each layer is treated line by line. The maximum energy is treated at the farthest edge of the target, and then you keep on going proximally. And that is how, and the energy will change. It's not like 6 MV, that just 6 MV. Here the energy will range between 230 to 70, depending upon the target, what the OAR is, where the depth is, where the entrance point is. So it's fairly technological demanding. But it is possible to do it now. You'd be amazed to know that 30% of the proton facilities in the world still do not have pencil beam technology. They still use the passive scatter. That is why some of the data in the earlier was not so great. Some of the trials were actually negative. The second thing is 60% of the proton just do not have image guidance. So it is bizarre to think that you put such an investment, 400-500 crore investment, and you do not have image guidance. You still do X-rays. So the modern proton therapy is called image-guided pencil beam, what can generate an intensity modulated proton therapy. So it's called IMPT. Now you also need lots of algorithms. Ray station is one of the finest ones. Traditionally, all our 600-700 patients that we have treated, we have every single patient use Monte Carlo optimization and Monte Carlo calculation. Not only the calculation, of course, you do, but optimization takes time. So some people say, why don't you use a pencil beam optimization? But the type of case mix that we have, very difficult, very CSIs and head and neck and lung and all that. So you do need Monte Carlo. So we are fortunate that we have incorporated that right from the beginning. Now, all of you have seen these classic pictures of craniospinal. What a beautiful dose distribution. Practically no dose whatsoever to the thyroid, to everything, lung, kidney, gonads, bowel, everything can be reduced. But this is very relevant from the OAR point of view, because you can see the late toxicity that you would associate with childhood cancers of stroke, cataract, obesity, ataxia, headache, depression. Everything is literally extremely low. Also doses to the cochlea, doses to the heart. And I'll show you some data on neurocognition also, surprisingly, although you give whole brain, whether photon or proton, but there is some evidence that even cognition is superior. There is absolutely no doubt, and many of the, Dr. Kapoor was mentioning actually, because in the US, many of them are done by insurance. In childhood cancer, they just put up this paper, second cancer significantly reduced, especially with IMPT. In the passive scatter technology, when used to a lot of collimators, there was neutron contamination. So there was some risk. In fact, even in carbon ion. So, carbon, we can have a discussion. We are extremely scared of carbon because carbon, one is the RBE and also produce a lot of neutron contamination still. So, but in proton, you have a slightly better handle on the dose range uncertainty and the RBE. The RBE is about 1.1, 1.2. That's still a little bit of a matter of debate. But the second cancer risk is extremely low, and there's lots of data available, particularly in long-term survivors. So therefore, the ASTRO, again, based on insurance and healthcare assessment policy measures, brought out what is called group policies. And the group one are the cases where there is excellent evidence, fairly robust evidence. And this include the classic intraocular melanoma. Even in 80s and 90s, we used to talk about it, the classic base of skull chordoma chondrosarcoma, and the spine tumors. But some of you may be surprised that hepatocellular carcinoma, wherever you need the need for radiation, whether it is SBRT, I mean, you can talk about it, whether it is slightly superior or there's a bit of debate. But there is a recent trial which shows that the proton is slightly better because simply you reduce the volume of normal liver radiation. But also as a bridge therapy and also the portal vein thrombosis and so on and so forth, hepatocellular carcinoma is also emerging as a group 1 intense. They do get clearance from the insurance. Every single child who needs radiation therapy at any point of time has to have proton. Some of the neurofibromatosis, chronic tissue disorders, we always used to struggle, breast, should we give radiation or not? Somebody from rheumatoid arthritis or chronic inflammatory disorders, they should get proton because you spare a lot of normal tissue. CNS tumors, we'll talk about it. Head and neck cancer, sinuses are the classic indications of the paranasal, nasopharynx, but also other cancers are coming into the picture, retroperitoneal sarcomas, and wherever you need re-radiation. About 20% as the cancer survivorship is increasing, more and more targeted therapy, better surgery, early detection, some of them get recurrence, so you get re-radiation. Again, everyone knows in this room that re-radiation, obviously, the most superior technology should be done, especially slightly potential curative intent, not palliative intent. The group 2 indications are where there is still evidence is not 100%, and these are in the clinical trial basis. These are some of the head and neck cancers, thoracic malignancies, although in the US, lung cancer is now the second commonest cancer to be treated on proton therapy. Abdominal malignancies, pelvic malignancies as well, especially anal canal and rectum, but also traditionally difficult cancers to treat like pancreas and esophagus. Non-metastatic prostate cancer, and I'll talk a little bit about breast cancer as well. Several consensus statement policies published almost every 2 to 3 years have repeatedly emphasized the fact on pediatric cancers, and everyone knows about it. So most of them would switch over from a classic IMRT photon to a proton beam therapy. And at the moment, about 3 to 4% of eligible patients only get proton, and that is partly because of the relative lack of evidence, although the model policies are there, but also the equipment, access, very few machines, insurance, political things also creep in because the photon world doesn't want to lose out the patients, especially in North America. But it has been estimated in the next 10 to 15 years or 20 years or so, 20 to 25% could potentially be eligible for proton beam therapy. So we are, as an Indian, forget about the private or a general, but as an Indian, we are proud that at least we have one center. I would rather request you to look at it that way, because at least now, at least in one country, and Tata Memorial will start in the later this year, hopefully as well. So it takes fair amount of time. Started in 2012. I actually wrote the project for TMH in 2013, and then it takes so many years. The AERB, we had like 3 to 4 years of constant struggle. Everyone in this room knows how very nice ARB is and how cooperative they are. So you can imagine what are the challenges we must have faced. They had absolutely no clue. But fortunately, we got them on board. We lost 2 to 3 years, but it actually proved successful because we had a universal nozzle that time and we changed into an IMPT nozzle in those 2 years. And that was a great thing to do as well. Finally, the Vice President of India launched on 2nd January. We wanted to launch on 1st, but ultimately the auspicious day came on 2nd January 2019. So it's actually just 3 years or so that we have been treating. Initially, of course, we have 2 gantries and 1 fixed room. Initially, how the world is, hopefully some of you will also get into proton. You get only 7 to 8 hours because 16 hours the machine people will take. And we have a contract with IBA, which have 50% of the proton facilities. The maintenance contract is for 24/7 up to 11 years because that's how it was designed. So you can treat only 5 to 6 patients initially. So for 3 to 4 months, you treat only 5 and you get so many referrals. And it's my same story here when you have the waiting times. So it was interesting. But fortunately, in about a year or so, we could get better handle on things. We got more time. Then the pandemic hit. But in spite of that, we have a waiting list. Even at the moment, we are treating 16 hours a day, but we have not compromised on every single thing. They have to have we take about 4 to 5 working days to generate a plan. It has to have a patient-specific QA. We have to do quality assurance CT scans and MRIs in between the treatments. 40% of the head and neck cancers, you need adaptive planning. So you have to keep 2 to 3 plans, and others also like GI and wherever there is gas, and not so much in CNS. But we just did the 50th patient. There was a celebration 2 weeks ago. We did the 50 patients on the couch that day, finished at 11 p.m. And yesterday, when I was coming day before, it was 46 patients. So we are maintaining that schedule for 2 rooms. But now we will start the 3rd room. We got the clearance finally from ARB for the fixed room also, although there will be some challenges in the fixed room. So hopefully we can treat about 60 to 65 patients, 70 patients max to the full capacity for the 3 rooms that we have. Tata Memorial has a better advantage because they have 4 rooms. So hopefully they'll be able to treat more number of patients. But I'm not sure whether 16 hours grueling schedule they'll be able to maintain. But it's not only about the proton. Some of the proton facilities have not done so well in the US because they were standalone proton facilities and they have gone belly up and they have not done because of the investment. And that is a mistake that people have from it. So it's not only a proton center, it's a any modern cancer center attached to it, and I'm very happy and proud that I oversee all, not only the proton but the entire cancer management. Now it was argued that it cannot be done in private, but we have tried to demonstrate in our own humble way that you can have a very nice academic program in a private setup as well. Every single person is site specific, whether it is radiation oncology, medical oncology, surgeons, MCH, they have to choose only one site. If they are site specific, of course, the OPD cluster is based on cancer management teams. There are 8 cancer management team clusters. Every single patient has to be on 8 tumor boards that we do every week. We also run a pan-Apollo multidisciplinary tumor board once a week as well. And Dr. Bhavna Sirohi is our lead medical oncologist. He runs a fantastic on the Friday, what is called pan-Apollo molecular MDT between 4 to 5:30. So it's kind of coming together. I was lucky to get about 30% of the faculty in our center is from big institutes, either TMH, CMC, and one, from all the institution that makes sense. And also we managed to get a clinical research secretariat as well, and I'll briefly touch upon it. Now, obviously, it is the only center at the moment in the entire South Asia up to Australia. So our actually first patient was from Australia, and we have treated from all over the world. Literally, we didn't have any patient from South America, but a meningioma patient eventually turned up in Chile. In fact, yesterday, his interview was taken by the BBC. It's in the press. I got a message on the Twitter. So now it is more or less covering everything. So Tata Memorial will hopefully come this year. Singapore likely to come this year or next year. And Brisbane will be the next one, I think, in 2024. So these are the 3 or 4 centers at the moment, and I hope some other centers come as well. Our first series was done by Dr. Srinivas, my colleague who looks after 2 or 3 CMTs, and it was essentially looking at the children and young adults. It was a relatively small series of 47 patients, but it was basically a kind of a proof of principle, as you would say, in other cohort. And it was basically to make the confidence that we are doing what we are doing is pretty okay. But I'm interested actually more in this, which just got published last month. We have argued very strongly, and it was interesting to see the comments, particularly from Dr. Kapoor's point of view. And we are very diverse, as Dr. Sharma was saying, then you have to have the both. You could argue the same with linear accelerator versus cohort. You could argue with IMRT. I remember how much debate was then when IMRT came into the picture, or any new drug which comes into the picture, immunotherapy, robotics, you name it. So you have to have some technology, at least in some teaching institutions, and of course from the care model as well. So we have argued that in LMICs also, given the emerging data, fought strongly for the particle, especially because in the last 5-7 years we have taken care of the uncertainties and those a better handle on the situation, so the data is likely to be much better as was in the 10 years ago. I just mentioned we are soon going to reach 700 patients. The youngest child we have treated is 10 months. It was a posterior fossa A ependymoma. You know that we cannot hold too long. The 3-year criteria doesn't hold anymore. The maximum is 88 years. He's actually a celebrity. He's a Padma Shri awardee. Fortunately, both the patients are doing very well so far. You can see a good chunk is CNS, but we have treated everyone else. Head and neck is the second chunk, prostate. Unfortunately, you can't see it for some reason on this slide, but basically it was showing the head and neck series was this. The genitourinary, GI, these were capturing all this, and this is the CNS basically. And 48% are CNS, but it is partly because we tend to get more CNS patients and a little bit because I'm there as well. So that, but now it is changing, and 24% are pediatric, which should be the case in a proton facility, although 2 to 3%. And there's not only pediatrics, actually pediatrics and young adults up to 25 years of age. And that is how the proton therapy center should work, at least in the start. I'll briefly talk about CNS, literally all histologies. Classic indication of skull-based chordoma. The only point I want to make is chordoma, surgical disease, but you never can cure. It keeps on coming back. You give 60, 65, sometimes even 70 gray you can give, but still it can come back. The proton therapy with the passive scattering jumped from 50%, about 20% to 50% long-term care, but with the pencil beam technologies from Zurich, and it's about 80%. So it's pretty encouraging. Chondrosarcoma is better, about to 90%. One of the factors what chordoma, however, is, and we have treated quite a few chordomas now, is the OR compression to the brainstem and the optic chiasm. So it's not just a proton. Sometimes, many times we get patients, okay, this is recurrence, cyberknife, radiation, surgery, now for proton. You can't manage because you have so much, those tiers that we have managed, and I'll show you in a minute, that is why so critical to have a very state-of-the-art cancer center attached to it. And this is our series of chordoma chondrosarcoma. We just published one paper earlier and done a fascinating paper from physics looking at the random spot positioning errors in IMRT, and this was essentially on skull-based tumors. But this is an example. This was a case, 36-year-old chordoma, treated with surgery, given gamma knife in limb hands, came to us. There was no way we can achieve the dose distribution because it is impinging on the brainstem. So about 35 to 40% of our skull-based tumors actually undergo re-excision first before we treat them for proton. And that has helped us a great deal. You can see the compression here, but after surgery now there is absolutely nothing. There is just a sliver anteriorly, at least on the side, but the middle of the brainstem is completely free, and you can achieve an optimal dose distribution. You need about 72 gray, and we do a slightly hyperfractionated in the base. I think I have it, and this was again a very proud moment for us. Not easy, all of us know, to get published in PMB, but our physics group, absolutely amazing people from led by Dr. Dayanand. They did a 3D reconstruction from the verification of IMPT. There is not much data on IMPT, tons of data on scatter technology, but not much because relatively new. So we did on skull-based tumor, especially the brain and chordoma, and this is now incorporated in our routine practice. One of the challenges in proton is, of course, the metal, because we don't like any density. Even the cyst or the solid component, when the proton beam traverses, it is coming back to actually pre-VMAT, when we used to do where we keep the field, whether it is image guided or even we used to mark the fields, because that was done with a lot of thought and science, how the beams will end, how the beams will go. Here, then VMAT has completely changed it. Do the target, VMAT, 5 minutes, this plan is ready. Here you go back again because there is no arc. So it's fixed field. So you have to think a lot how the beam will go, whether it is 2 beam, 3 beam, 4 beam, what is the angle, is it coplanar, is it non-coplanar, will it increase my time on the image guidance? Because each gantry you change, each couch you change, you have to again do image guidance. That is the meticulousness, that's why the time is also a little bit higher on each proton. So, but we have algorithms now. Everyone knows about the CMER algorithm. Fortunately, we have a helical tomotherapy also in our team. So we do a MVCT, and that helps us to get the density. We merge in the planning system, and that is why we have overcome so it's not an absolute contraindication. Sometimes in few cases, what we have done, that they needed a metal to sustain the spine. We actually did the surgery. After 6 weeks, we did the proton, and then we put the metal. We asked the neurosurgeon if that is possible, and it is possible in some cases to put the cage for stabilization, because you don't want the metal during proton therapy. Unless it is, of course, absolutely critical, then you have to have it. This is our first series of 42. It is now escalated to 60. This paper is actually under review at the moment. These are the tier doses that we do, 72.6. The EK duty is up to 76 gray. These are the normal organ tolerances. And as I have told you, many of the patients undergo surgery again. And so far the data is pretty good. I mean, I hate to say 100% because just 2 years, nothing doesn't make, I shouldn't even say it, but at least nothing has recurred so far in the 2 years. It needs about 8 to 10 years before you can actually say anything about it. But so far, not too bad. Now, craniospinal, we have actually done more than 50 cases now. This paper is also under review at the moment. You can see both in adults and pediatrics. Pediatric, you still have to treat the whole vertebra because the growth plate is still there. You don't want kyphosis and scoliosis, although there is some emerging evidence that you can possibly spare the vertebra. But in adults, absolutely no need to spare the vertebra. And Vijay is here. He knows when we used to give chemo in adult medulloblastoma, they were not tolerating very well. And for some reason, children tolerated better, adults do not. And here the tolerance is much better because you can spare the vertebra quite well. So everyone is again doing well. We have a robust optimized hybrid plan. These are the doses that you can see. Again, very, very interesting doses. You hardly get these doses in the photon world. And this is our first series, as I mentioned, both in the adult age-wise, more than 14. I just took it from the paper, but we can't show it because it's still not completely accepted. Hopefully it will get accepted soon. Then we can have the CSI paper as well. Intracranial germ cell tumor, again, a very good indication. If it is a germinoma, you need only whole ventricular artery. You can give a very good dose distribution, dose differential, because the beam just stops. So very little dose to the hippocampus and the temporal lobe and the frontal lobe. And you don't need very high doses. Say with non-germinomatous, when you use craniospinal, of course, CSI is the hallmark of proton therapy. So we have published our first paper in the germ cell tumor, but this is just an example. This girl, I mean, they could have done well in photon also, but just an example to show a little bit marketing slide because she did extremely well. She came third in the entire district after being treated with the proton therapy. So did it academically very well and is taller than me, I think. The low-grade gliomas, pencil beam, you can do pilostic astrocytomas. The adult one, of course, there is a randomized trial going on, and Jayant is here. I'm indebted to Jayant to put this paper together from Tata Memorial. It's a neuro-oncology, which is a very prestigious journal to publish in. We were the first ones to get the dose constraint to the world because this is the only series prospectively where baseline before radiation, extensive neurocognitive workup, and then up to 5 years. You have, and then we did a logistic regression analysis. It was actually conceived by Dr. Indranil Malik, who I'm also eternally grateful for that left temporal lobe dose constant. He was instrumental in giving to the world from our side of the world. And then Jayant took it to the next level and put out the hippocampal sparing concept. Craniopharyngioma, naturally our first ever patient was actually a first proton therapy was actually a craniopharyngioma, and I just want to show you how do you avoid the shunt. You cannot put the beam through the shunt. You cannot put the beam through the sinus, or if you put, then you have to be very careful. You cannot through the mastoid air cells, because then it can perturb the dose. So you have to look at these things. The change in cyst volume in photon is also very important in cranios, as we know, because they can enlarge. But in proton, you get nightmares sometimes, because you have to be so careful. In 2 or 3 millimeter change will completely perturb the dose. So those are the things. So we do the weekly. Of course, there is a CBCT every day, but you also do a planning QACT for craniopharyngiomas. And again, so far we have done extremely well. I think 13 patients when the data was analyzed for the PTCOG presentation. This paper is also actually in review in Neuro-Oncology Advance. Some of the technical things are, there are 2 ways that you do. One is called SFO plan, which is called single field optimization. Basically, it is 3D CRT. So each beam will cover the entire target on all the 3 beams. It is safer because you don't have any heterogeneity. Even if there is some change in the density or the change in the target, you are pretty safe because all the beams are covering it. But we are very excited with what is called multi-field optimization, which is called IMPT, where there is a heterogeneous dose distribution on purpose, like you do in IMRT photon, and you have to be careful. So more and more we are doing. Initially when we started, most of our patients were SFO. In the last 2 years now, 80% of our patients are MFO because we got more confidence. We know what the SOPs are, what are the protocols to measure the density changes. And also there is a concept of robust optimization. I still do PTV in CNS, but most of my colleagues, both the other CMT groups, they hardly do PTV. They do all the optimization based on CTV with classic of 3.5% difference in 3 millimeters in either direction. So that is called robust optimization. So wherever it moves, the target is covered, especially in the adaptive process. So that makes big difference, especially in head and neck cancers, thoracic malignancies, and abdominopelvic differences as well. Sometimes I do it in brain as well because there is not too much heterogeneity in the brain. So more and more we do robust optimization. It is not particularly for proton. You can do it in photon too. In other words, the concept of PTV is getting less relevant in the proton world, but also has relevance in the photon world. We are, some of you who know me a little bit, I'm passionate about quality of life because that was my first project in TMH and that gave us some recognition. So every single patient we have treated so far has a prospective, about 8 to 9 prospective studies looking at the quality of life in translated, all this EORTC and the different modules that we use. Dr. Nangia is in charge of head and neck cancers and breast cancer. She's doing an amazing job. There's a fair amount of head and neck cancers. We were thinking initially the nasopharynx and the sinonasal carcinomas, but actually speaking, we got the largest chunk in oral cavity. Oh, I'm glad you can see it. And what we also saw, the salivary gland tumors, not so much in the larynx and hypopharynx because of the movement, but in other sites, oral cavity especially. So remarkable results because there is literally no dose to the other side. So the tolerance is so good because the beam stops in the buccal mucosa or the lateral part of the tongue or even the tonsil. So there is no dose to the other side. So that with concurrent chemotherapy or the cetuximab or biomab, whatever you have to give the mucosal preservation. And this paper is also under review in clinical oncology. Let us see how it goes. But she has been instrumental in providing that data generation. Now, we always thought pediatric population proton, what we learned in the last 3 years, actually it's an excellent modality for geriatric population because of the poor tolerance in these patients. So because you can spare the tissues very well, so in fact, it has a more relevance in geriatric population. So Dr. Nangia has just started 6 months ago a dedicated geriatric clinic, one of the few in the country, apart from TMH, and that is once a week, Wednesdays, where all patients, and now we are launching a study next week, it's going to be called senior study, where every single patient, regardless of the CMT, above 65 years, will be seen by a geriatrician from Apollo and will be enrolled in a prospective clinical trial looking at the quality of life. So head and neck cancers. But one thing which we realized in head and neck cancer, which was not so good, was the skin toxicity was higher, because you use only 2 or 3 fields, so the skin toxicity was slightly higher. And if you by chance have to reoperate on a recurrence, then it is actually like a hard, like old cobalt area we used to see, absolutely like a cardboard, like very hard, like a wood. So that is one thing which we have learned. So traditionally we used to be sent a lot of recurrent cases, 6 months recurrence after radiation, 1 year, we don't take them anymore, because there is no point in spending so much time and money and intense and giving them 30 lakh treatment and the results are not so great. So we choose our cases at least 1.5, 2 years from the DFI, from the previous radiation, performance status and so on and so forth. More and more focus is on the upfront setting rather than in the recurrent setting. And there are other studies also, tube insertion, aspiration from MD Anderson. Many of you may have already seen these studies. So modern proton therapy is slightly better. Now, prostate cancer is a matter of debate. I know Indranil is in the audience. He is passionate against proton, I believe, or maybe not. But in high risk, especially because of the recent trial from Tata Memorial by Dr. Murthy, you have to treat a high risk now, like with the pelvis. And then in pelvis, the differences are the larger the field, better proton. So it's a conceptual change. Sometimes I get patients for a small radiosurgery, they think that small tumors proton will be better. Actually, proton is not better in small tumors. There is a slight extra penumbra there, lateral penumbra. We still treat it with radiosurgery theirs. But whenever the target is slightly larger, which is unfortunately the case in vast majority of our clinical practice, then the proton scores over photon, because you can spare the normal tissues much better. In the early prostate cancer also one could argue, but there are players like robotics, surgery, brachytherapy, SBRT, so more or less same. In younger patients, sexual health, there has been quite a good data that it is better. Now Dr. Srinivas is looking after it. They have this prospective trial, we call it ProCube registry, where all the patients of prospective cancers are captured, but along with Dr. Indranil and Dr. Murthy, they have also combined together, I believe, for that prospective study that you guys are doing and that is for the photon also, but hopefully even in extreme hypofractionation, like 36 to 40 gray in 6 fractions, there is some data emerging for that as well. Now, thorax is always a challenge because there are moving targets, very hard. And esophagus, lymphoma, metastasis, thymoma still better, but lung cancer. But as I mentioned, even we were surprised, and especially the MD Anderson trial was negative, but we know that 70% was with the passive scattering. And if you look at the second cohort, when the pencil beam was saying, then actually there was significant superiority. Nevertheless, there are some cases. So this is an example. This was an elderly gentleman with tons of morbidities, obese, 120 kilos, sleep apnea, diabetes, hypertension, non-small cell lung cancer. Was treated by a very good hospital, was actually generated a plan in a very premier hospital in Mumbai, and was deemed that it cannot be suitable for any radiation. And he came to us, and you can, I don't have to tell this audience how great the distribution looks. I have the data. I'm grateful for Srinivas, because the mean heart dose from 30 grand, don't underestimate heart dose in lung cancer, by the way. It's an extremely important endpoint. But also the dose to the V20, V5, mean lung dose from 20 gray to 12 gray, and we could demonstrate that we can treat it. You will not believe we actually did it in breath hold, and excellent data, and significantly reduced. These are the current pictures, and this is the July 22 pictures, 2 years down the line, still doing well. One case doesn't tell the whole story. We have to prospectively, I don't want to make a drama out of it, but at least one case gave us the confidence that you could do it both in breath hold, but if they cannot do breath hold, you do in free breathing, but you have to do all the rigmarole of motion management. We have a surface guidance also, by the way. We have the surface guidance IRT that helps a little bit as well. GI cancers, I mentioned to you the HCC. This was one of those cases which showed good response. esophageal cancer and pancreatic cancers, also some data is emerging. People are quite fascinated with breast because you could spare significant amount of radiation to all the cardiac structures. Now you look at the data, 3D CRT, VMAT, and we have excellent tomoplanners, by the way, because most of them, we have just 2 machines. So most of the tomoplans, proton plans, and our own clinical experience. So relatively simple. You just need 1 or 2 beams only. You don't need too many fancy beams for the breast. And of course, it has to be prospectively measured. So I think I'm coming to the last. I come to Dr. Kapoor's favorite topic of Marco model. And I'm so happy that he already laid this, so I don't have to discuss too much. But I don't know what you think about it. So there have been a fair amount of data on cost, both the ISAR as well as Monte Carlo and Marco models. And this is a very interesting study which everyone quotes. It was done about 6 years ago now. Many were actually passive scattering, but there is tons of data available for breast cancer, for pediatric cancers, head and neck cancer, non-small cell lung cancer. Eventually, in spite of the initial investment, but the return to the work, generation of the GDP, contribution to the economy, to the society, the disability adjusted and the quality adjusted life years is significantly superior. In children, IQ preservation, reduced hormone and adverse events, although initially most costly, but eventually to the society, actually it is more cost effective. Some people argue that do you need phase 3 randomized trials in proton? And I think we should wherever we can, but as many of you know, we were instrumental in doing this phase 3 randomized trial. It was not on proton, it was in photon versus photon, conventional photon with a high precision photon. But essentially the principle is that if it was 200 patient, 5-year study, very clinical relevant endpoint of neurocognition and neuroendocrine, we could demonstrate that smaller volume of irradiated normal tissue, superior clinical outcomes in a selected population. So you could extrapolate the same to proton. So perhaps there is no need for phase 3 in a selected population. Apart from the endocrine, we also were instrumental in getting the neuroendocrine constraint, and the hypothalamic pituitary axis dose is about 28 to 30 gray if you can achieve. Again, one of the few data in the world on a prospective fashion that what should be the dose you should not exceed for the hypothalamic pituitary axis. Finally, as I mentioned, maybe it is our DNA now, both from PGI and Tata, we cannot help ourselves not doing clinical work, research. So there are about 15 IRB approved investigation clinical trials, although we don't have residents as yet. Hopefully the DNB programs in private is, by the way, a good contribution to, as in addition to Professor, I agree, and what Dr. Kapoor said, there is a need for doctors, so it can contribute too. But as I mentioned, these are the different prospective clinical trials done by many of my colleagues. And hopefully you will see, we have published about 40, 50 papers already, but hopefully you will be able to contribute more. We also have this ritual of practicums. The first annual proton practicum was done, it's always done in May, was last year. 400 participants, I don't know how many you could attend. It was virtual. We had a very good faculty that time. And I'm happy to announce the second practicum. If anyone is interested, it is a hybrid meeting. 2 days of virtual and 1 day of actual practical work is on 20th to 22nd May 2022. And we have again managed to get an absolutely outstanding faculty from every single part of the globe to contribute to this practical. And hopefully some of you could join and learn such that we can do it. And these are some of the things that we do. So I want to end by hopefully giving you some perspective and a little bit about the proton therapy and in general. But as I mentioned, on behalf of every single person, if I take the opportunity and liberty from everyone, from my seniors as well here, to pay our immense gratitude to one and only Professor B.D. Gupta, my teachers, Professor Sharma and Professor Patel, who are still very here. It's a great honor for me to present. Professor Negi, who I was hoping would be there to chair my session, but I know he's there always, his blessings. And we should always be grateful to our teachers, fellow colleagues, senior, junior staff, patients, and eventually these walls of PGI have taught us the teachings, the ethos, the culture of PGI, which will remain for the rest of our lives for both professional as well as personal growth. With that, I thank you very much for your attention.
Thank you, Dr. Jalali. I must congratulate for the beautiful presentation, very informative. Right from the very simple way you have told the residents that how the proton therapy has evolved over the years, and it was beautiful to go through your journey of proton treatment at your center. Any questions, any comments, please, from floor. If you would like to add anything. Dr. Kapoor.
Don't ask me about Marco.
I'm thankful actually. Not for the reason that what all Dr. Jalali has spoken and given us an insight. Right from the residency days when we were sitting in the seminar rooms and sir and madam sitting in front of us, there were occasions when the teaching has been like that only two-way. So my purpose is solved. That is what I wanted, that I should have speakers who should give our own colleagues who should give us the insight, and whatever they are doing outside, the same is not difficult to be practiced in the department right now also. That is one thing. Second is not the Marcos model, sir. I am happy that the two papers which I like that you should send me, they are going to make the case much stronger in the government hierarchy for me, because it is difficult, I said, because we don't have a voice in the health sector. The radiation oncologists, that is what I felt attending few of the meetings in the Delhi. The corridors are difficult to listen to us. I understand with the private sector coming in and chipping in, the things become easier there also. But for a government sector, PGI, AIMS, it is always a fight. So I always like that if such type of data is there, and it is especially from our own people, it becomes easier for us to fight for that. And that is what I am trying now. Rest of whatever time I can work for the country, I'll do that. Thank you so much.
Thank you.
Thank you, Dr. Kapoor. Any other comments, please? Any other question? Thank you, Dr. Jalali. I take this opportunity to thank the organizers for giving me the chance to chair this session of Dr. Jalali on very important topic. Thank you.
Thank you, sir. For the next presentation, I would request Dr. Shantam Chakrabarti. He will be speaking upon SBRT as an alternative to brachytherapy. I request Dr. F.D. Patel to please chair the session. Thank you.
Thank you very much. Shantam needs no introduction. Always happy to hear you.
Thank you,
So you
madam.
can now begin your seminar on stereotactic radiotherapy as an alternative to brachytherapy.
Thank you, madam. So I hope I will stick to time. So to introduce the topic, I was quite surprised. Actually, somebody told me to speak about stereotactic radiotherapy because I really do very little of it. So brachytherapy and stereotactic radiotherapy, as we all know, are high precision radiotherapy techniques, which basically rely on delivering hyperfractionated doses in limited fractions to limited volumes with an intentionally heterogeneous dose distribution. And this is quite opposite to the paradigm that we follow for conventionally fractionated radiotherapy. Both of these techniques hope to achieve sharp dose fall-off to avoid organ at risk toxicity. And they have a shared ablative radiobiology, I should say, which basically relies on the occurrence of vascular damage occurring in doses more than 10 gray, with some evidence that there is programmed necrosis rather than apoptosis and possibilities of immunomodulation. Both of these techniques are resource intensive. While brachytherapy relies on the skill, SBRT relies on technology and quality assurance. Yeah, so let's first come to the first disease site, the prostate cancer. Now this is the site where actually, if you look at it, both SBRT and brachytherapy have got a substantial amount of data. Prostate cancer, as we all know, is something that started with brachytherapy for low risk as well as intermediate risk disease. Brachytherapy is an established treatment modality for almost more than 120 years now. Ultra-low dose permanent prostate implants actually predates retropubic radical prostatectomy. This is very important to understand. At that point, they used to use a suprapubic approach for brachytherapy. They had used various modalities, isotopes, for example, radium capsules, radium gauze. Most importantly, because of these 100 years, there's a humongous amount of clinical experience which has accumulated. Over a period of time, slowly, HDR approaches have come in. And now HDR brachytherapy in prostate is becoming more commonplace. SBRT for prostate cancer started gaining prominence nearly in the early 2000s. And this was, of course, mainly determined by the extent of technological development in computation as well as delivery, which happened over the past 2 decades. Because of the increasing experience that was gained from frameless extracranial stereotaxy, as well as the fact that there was increasing evidence that prostate cancer hypofractionation is something that is probably biologically more rational rather than usual conventional fractionation. And paradoxically, the experience that was gained from HDR brachytherapy actually helped with the adoption of SBRT in prostate cancer. Coming to SBRT monotherapy studies, now these are the 2 studies which I sort of came across, which are randomized controlled trials. These are both done in low risk and intermediate risk disease. These are studies with a substantial number of patients, which have used treatment deliveries in 5 to 7 fractions. And interestingly, while the hypo-RT-PC study has demonstrated that SBRT is associated with similar outcomes as conventionally fractionated radiotherapy, in case of PACE-B study, however, the outcomes have not been reported. One thing noteworthy is the difference in the toxicity profile. If you see grade 2 plus toxicity seems to be slightly higher in SBRT. And this probably is because of the effect of how the dose is optimized with respect to the urethra. Noteworthy is, although brachytherapy was an established treatment modality, it was never compared directly to SBRT in our practice. And this, I think, is something that is a problem with our discipline. We tend to forget what we do. We jump onto new techniques without actually evaluating what benefit that technique brings in. And coming to the topic of cost effectiveness studies, I think the primary reason is that in radiotherapy, the burden of proving cost effectiveness rests on the user, unlike medical oncology, where the burden rests on the vendor. Here what happens is that we acquire the technology, we run the trial, and we prove the results for the vendor. And that is one of the biggest problems that we have currently in radiation oncology. Brachytherapy studies, these are actually randomized controlled trials. And they have shown, again, excellent biochemical relapse-free survival, and nearly similar grade 2 plus toxicity. Now, it is important to remember, because brachytherapy is such an operator-dependent technique, the toxicity profile depends on how it has been done. And if you see the high-dose rate brachytherapy series, which are these series, they basically have toxicity rates ranging between 3.2% to 20%. Now, there is no direct head-to-head comparison with brachytherapy and SBRT, but this group has a sufficiently large series of patients which they have treated in their institute with brachytherapy, SBRT, as well as dose-escalated IMRT. And what they have shown over a period of time is that the outcomes are nearly similar. The question that arises then is, why is brachytherapy being replaced with SBRT in this situation? What is the need? What is the requirement? For high-risk prostate cancer also, interestingly, HDR brachytherapy boost, which is the setting in which it is given, has got pretty good data. If you look at it, Hoskins trial, which utilized HDR brachytherapy, actually demonstrated a humongous difference in biochemical relapse-free survival. Now, this kind of biochemical relapse-free survival for a medical oncology study would mean straight away FDA approval. The Ascend Artist trial, which used LDR, did not show that huge difference, but what happened was, because they were probably using LDR, they did show there was a substantial increase in grade 3 GU toxicity. Unfortunately, what has happened is USA, the country which we are sort of aping as far as our healthcare delivery model is concerned, has slowly seen a decline in the use of brachytherapy. And over a period of 2004 to 2014, brachytherapy utilization rates have fallen from nearly 48% to 27%, while SBRT rate seems to have increased 0.03%, which is, of course, understandable. At that time, the technology was maturing to nearly 10.6%. These figures are in 2014. I'm pretty sure in 2020, these figures have just completely reversed. So coming to the outcomes from this study, which was actually published by Nuke et al. In a JAMA publication, they had a follow-up of 6.7 years. This was an NCDB analysis, National Cancer Database analysis. And they showed that actually brachytherapy was associated with a small increment in OS as compared to dose-escalated IMRT. The data was not there for brachytherapy, but if you look at the hazard ratios, they all favor brachytherapy. Now, anybody who understands statistics will know that p-values being 0.05 or less are primarily an artifact of your sample size rather than the effect size. With a hazard ratio of 0.8 and 0.74, these are actually quite consistent. And because of these consistent hazard ratios, you can postulate patients with HDR brachytherapy can potentially have a 20% reduced risk of a biochemical relapse-free survival. Coming to breast cancer. Okay, so breast cancer is another area where SBRT and brachytherapy, we know brachytherapy has been used for a pretty long period of time. We have data from two major studies which have evaluated the use of interstitial brachytherapy. Polgar et al. And the GECS2 study, both of them showed interstitial brachytherapy, multi-catheter interstitial brachytherapy was associated with excellent to good cosmesis and was associated with nearly similar recurrence rates. What is important to remember is that I have not put in the NACBB 39 results. Now, why didn't I put it? Because nearly 80% of the patients were treated by a suboptimal brachytherapy technique, which basically was driven by the fact that it has to be put in by a surgeon rather than a radiation oncologist. So, what we understand is that, again, in breast cancer also, APBI results with brachytherapy are actually excellent. Unfortunately, SBRT is being increasingly used in this area also. Although we know, dosimetrically speaking, there is no reason to adopt it. This is a paper by Major T, who actually works with Dr. Polgar. And what they have done is that they have evaluated CyberKnife plans on HDR brachytherapy target volumes. And what they showed is that there was better coverage of the target tissue with brachytherapy, there was lower dose to non-target breast tissue with SBRT, and there was increased dose to skin, ipsilateral lung, ribs with CyberKnife. This, to a seasoned radiation oncologist, is logical. And why is it logical? Because of the inverse square law. There is no reason why SBRT can be superior to brachytherapy in this respect. For some reason, this slide is coming up. Anyway, next I come to cervical cancer. Okay, so cervical cancer is unfortunately a disease where we are foregoing brachytherapy in larger numbers without actual any clinical justification. And this is something that our discipline will review in the coming years. This is basically falling rates of brachytherapy utilization across countries, and we can see there, even in the most developed countries, except for Spain probably, the brachytherapy utilization rate in gynecological malignancy is much lower than what it should be. And this is despite the fact that there is such a strong evidence for brachytherapy in gynecological malignancy. People have actually attempted to deliver SBRT doses to gynecological brachytherapy HDR plans. Now, this is a paper that was done from AIMS. I must congratulate Dr. D.N. Sharma, who has actually done 2 papers on this and has shown conclusively that SBRT cannot replace brachytherapy in this scenario. This is something, again, we knew, but we have to show. So, there. So, for the residents, it may seem that these color washes seem to be nearly similar, right? They are normalized to deliver a dose of 9 gray to point A. They are delivering dose of 9 gray to point A. What is important to remember is that with your SBRT or IMRT or whatever you call it, this core is basically, this orange colored core is around 200% of the prescribed dose. Here, the 200% is actually represented by the blue. Now, please remember, for residents, it is extremely important to understand that gynecological brachytherapy does not cure by delivering 7 gray to point A. It cures by delivering the hyperdose sleeve to the gross disease. And that's why it's extremely important to remember that it cannot be replaced. But unfortunately, radiation oncologists have tried to do this. And in USA, there has been a progressive fall in brachytherapy utilization rate, and this is something that should probably come as a sort of morale for us, a sort of warning for us that this is what is going to happen if we keep aping the US healthcare system to us also. And we can see over a period of time, there are now 3 or probably more than 3 studies. This is something that I picked up over 1 week, so probably if I did a more thorough review, we could pick up more. The utilization rates of brachytherapy have dropped drastically, and they have been accompanied with dramatic drops in overall survival. In some scenarios, the OS benefit that patients derive from brachytherapy is actually superior to what they derive from concurrent chemotherapy. There is a trial also from University of Texas Southwest. It's a phase 2 study. This is by Timmerman's group actually. And although they planned for 21 patients, they had to stop before only after 15 patients because of toxicity. Now, those of us who have taken Firoza ma'am's lecture will remember this figure of 20% fistula. From a trial which was done in Punjab, I forgot the name of the place, madam, where they had, Ludhiana. Yes, thank you, sir. So where they had used a horrible dose fractionation regimen without correcting for it. And I believe this was the rate of fistula they got. So, yeah. So you see, if you sort of like unjustifiably adopt technologies which are probably not something that you need to adopt, you get out with these kind of outcomes. So coming to probably my penultimate slide, are the results with brachytherapy surprising? No, they are not. Simple. Physical doses with brachytherapy will be superior because the inverse square law cannot be circumvented. A highly heterogeneous dose can obtained around the source with a steep dose follow-up with brachytherapy, which cannot be done with SBRT. Most importantly for brachytherapy, perhaps, the errors associated with movements and deformations are less likely to impact the dose delivered, particularly when you're using HDR brachytherapy. There is definitely reduced requirements for giving safety margins. Transit doses to normal tissue is therefore completely avoided. And the biggest shortcoming of brachytherapy, as I see it today, is also related to these advantages. It's primarily the fact that you require expertise for its placement, and this expertise is slowly disappearing over a period of time. There is requirement for an invasive procedure with an accessible target. Now, why I put the accessible target in quotes? Because accessibility, the definition of accessibility keeps changing. What we think was inaccessible a few years ago can become accessible over a period of time. And who has taught us that? Our interventional radiology colleagues, who are now able to take biopsies from sites which were considered inaccessible just a couple of decades ago. So what we know is brachytherapy utilization is reducing in US. Reimbursement and expertise is probably the driving trend for that. I believe it's time that radiation oncologists integrate the knowledge that we have gained from the interventional radiologists to actually expand the utilization of brachytherapy. And I think one of the slides got missed here where I had shown data on liver brachytherapy. So Has et al. Have got the largest series of brachytherapy done for hepatic tumors. Hepatic tumors are traditionally a tumor where you would consider SBRT rules because the fact that it is non-invasive. They have shown that brachytherapy actually is superior with respect to centrally placed tumors, with respect to larger tumors, with respect to surrounding organ doses. So all of those situations, brachytherapy is superior. The only problem is expertise is very limited. So clinical trials are definitely required for modality comparisons, and this is something we as a discipline must do, where we have an established technology which actually gives us good clinical results. Adopting a new technology without running a clinical trial actually damages us. We need advocacy, we need expertise, and we need funding for performing these clinical trials. Stereotactic radiotherapy definitely has its uses. There are situations where brachytherapy cannot be done, but at this stage, at this era, we cannot say that it can replace brachytherapy. Thank you.
Thank you, Shantam. I think I'm very happy because the way the topic was written was alternative to brachytherapy. And I was actually quite against that because I feel it may be required for certain, I'm talking about cervix, in which case it may be required for certain patients in which you cannot do brachytherapy. But as a sort of underlying thing, it cannot be an alternative to brachytherapy. Because for the residents, this is very important. The dose that you can give locally with brachytherapy is something that you cannot give with any form of external radiation. When we say 35 gray to point A, we are not bothered about that point A. It is that local dose which is so much higher which is important. And that high dose cannot be given by any form of external beam radiation is what I believe. And I strongly feel that all residents must do brachytherapy. Unfortunately, we are giving it up in head and neck. We are giving it up in breast. We have started giving it up in prostate. Because like Shantam says, in America, they are giving it up because they don't have the expertise to do it. If you see, most of the brachytherapy work that is reported in America is done by non-Americans, mostly by Indians. Syed, Nouri, all these people have been basically with Indians who have been doing brachytherapy, and they have taken it up. The Americans themselves are not in favor of doing brachytherapy. They will take an easy way out.
There is also reimbursement, madam.
Yeah, that is another important thing. Reimbursement is another important thing. Because you do brachytherapy, you will have to get the anesthetist, you will have to get the other people involved. You do an external beam radiotherapy, all the money is coming to you as a radiation oncologist. So therefore, I think this is a very important topic that Shantam has discussed, and I now open it up for any questions or comments that the audience has. Yes, Teji.
As you know, Dr. Sushovan Banerjee with me, he's a person who does a lot of brachytherapy, and he also does the interstitial. So we did a presentation for our house there, and then we found that there's a Spanish study where they have compared the two, and there's a 23% decrease in the local control rate beyond 3 years when you do SBRT versus brachytherapy. Yes. So I don't think we should be, even discussing this matter, because there is no way the cervical dose can be replaced by SBRT.
I completely agree, madam.
Doctor?
But what do you say that if the hospital doesn't provide you a brachytherapy machine, what will you do? So the question is that in today's era, a hospital, modern hospital, not having a brachytherapy machine is unimaginable. I worked there and in Apollo, Delhi. And for 9.5 years I worked there. They said it is not financially viable. It was a very attractive thing. You see, I could have done SBRT, earned more money, because the private sector is about money. But because I was trained in a center like PGI, I understood the importance of brachytherapy. So wherever I thought brachytherapy is required, I would refer the patients outside. But you look at the management, Apollo in 96 had a dedicated machine for SRT and SRS. I started doing SRS in 96 at Apollo. And you see the other end, brachytherapy costing 1.5 crores for such a proton. So it is very difficult for, to make them understand. But wherever you have this situation, never, do SBRT as a replacement, send it to another center.
Yes.
They must not be wanting to buy brachytherapy knowingly, because if they buy the brachytherapy, then your stereotaxy will not work. They won't be able to earn money from that.
Teji wants to make a point.
So, I also face the same problem with my management and my supply chain, because it's a recurring cost to purchase the source. So every time the source cost comes up, they'll ask me how many patients have been treated. So then I always tell them that these are the patients who are completing their treatment with me. They are not standalone patients. They have had their external beam, they've had their chemotherapy here, and now they're coming for the completion of the treatment. And now, after having that kind of a response from me here, the other centers, they're agreeing straight away. They go in for brachytherapy. They're not saying that they'll only put up the Linux.
Madam, I think it is also actually at some extent our fault also, because we don't take money for brachytherapy. It means I will tell my center's experience. This is something we charge around 10 times more for external as compared to brachytherapy. And brachytherapy machine is actually almost like how much? Probably like 30% of the cost of an external beam machine.
Yeah. So can I?
Less than that,
yeah.
I think.
Yeah. Can I make a comment? I think Dr. Huku said it is not cost effective. It's agreed. But I think I feel there are two major points why brachytherapy on decline. Number one, I have seen many residents coming from various centers of India. They have not seen brachytherapy. What they have seen is intracavitary brachytherapy. And I think if you just believe that your microselectron will do only intracavitary, it is going to be non-viable. They have not seen interstitial brachytherapy, intraluminal brachytherapy, and all those procedures. And therefore, and many of the residents, number two, many of the residents are very shy of surgical procedures. We do MUPIT very often because CSR is very advanced, and we know that routine intracavity doesn't work for them in 30-40% of patients. And you ask, you have done MUPIT? No. So it's so uncommon. So I think there's a lack of training, there's a shyness to surgery, there's a shyness to enter operation theater. They can't drape very well, they can't stitch very well, they stitch like this, and you find out that they have never stitched a simple stitch, they have never done. I think all this combines, and therefore, if brachytherapy machine has to be cost effective, it has to be all modalities of brachytherapy to be used, not only intracavitary.
I have a point. I think for all, of course, everyone here is trained in PGI, so that's a different thing. For all other institutes where brachytherapy is not available, the residents should be sent to a training center where brachytherapy is done so that they get an exposure to it. And of course, like somebody mentioned that, Huku mentioned, we don't have the machine. Of course, it's mandatory to have it, but if you don't have it, rather than doing some form of external radiation, please refer the patient somewhere where brachytherapy can be done for them.
When All India Institute was undergoing renovation, he and Dr. Harish, they came to me in RGCI for their brachytherapy training. That's how I got introduced to him.
If there are no more questions, thank you.
One more point I will, if there are entrepreneurs in the audience. When I started my center after Apollo in BLK, brachytherapy machine we got. I knew that in private sector, interstitial work, the brachytherapy work as a whole is less. So we opened machine for patients in Safdarjung Hospital, which did not have, and Maulana Azad, which did not have brachytherapy working at that time. But because it was my center, I charged them 2,500 rupees per session. Whereas in our hospital, we were charging 25,000 rupees. In other setups, probably the management will not allow you to, but in that way, we did, 10 times the number of patients, 2,500 per patient, we earned money, and, the source cost, we, were able to benefit the patients.
Thank you very much. I'd like to thank the organizers, and I now hand over to the organizers for the next session.
Thank you.
Thank you, sir. Thank you, ma'am. The next session is on gains and pitfalls of IMRT in head and neck cancer. I invite Dr. A.K. Anand to speak on the topic. And I invite Dr. Sushmita Ghoshal and Dr. S. Huku to kindly chair the session, please.
Good afternoon. So now, of course, we are entering into an area which is all of us are doing day and night. And Dr. Anand is a very nice exponent of this technology. And Dr. Anand doesn't need any introduction, and I would request him to speak on gains and pitfalls of IMRT in head and neck cancer.
Good afternoon, everybody, and I'm really thrilled that we could ultimately have this alumni meet, and we have met all of us during the tea time. नहीं दिया हुआ ऊपर अरे भैया उन्होंने किया होगा ये हाँ ये कहाँ चला गया Yeah. So before I come to my topic, uh, you get so much emotionally attached when you come to PGI, because PGI, I feel, changed my life and must be life of many people, as Jalali was also mentioning. Uh, I had actually joined MD Medicine in my college, and when I came here, one of the senior residents, I can name Dr. Grover, he said, "Why you are joining medicine? Why don't you come to radiation oncology?" I said, "I don't know what is radiation, and I have never heard of it." So he said, "Come, come मेरे साथ आओ," ऐसे बोलते थे वो. He took me and took to the department and showed me, "This is the machine." I said, "This is not a clinical branch." He said, "Why not?" Means they see doctors are sitting, Dr. Ayagiri was sitting, Dr. Firoza was examining patient and writing prescription. So I said, "Oh, it is a clinical branch." And then I went back, not fully convinced that I will join radiation oncology, because my father wrote a telegram saying, "Don't join radiation, join medicine," and all family members. And when I went to my professor there, L.S. Chawla, who was our dean and head of department of medicine, and he said, "Kaka, you will be one of few in radiation oncology, while you will be one of many in medicine. So this is your opportunity." And despite strong opposition from my family, I joined radiation oncology, not because of this subject, I must confess, but because of the aura of PGI. The day I saw the building, the lecture theaters, and the aura, the professors, the people, I was overwhelmed, and I decided to come here. So this is not the end. Even till today, I feel PGI comes to our rescue at many places. And I went to England after completing 6 years here and saw training over there and education, and I was talking to myself that what is lacking in PGI? Nothing. We were doing almost the same thing as you would do in a hospital in England. And throughout this life, I could see that wherever you go and you say you are from PGI, you get a different attention. And I think everybody must be knowing, and the residents who are passing out, it's a message to them that conduct yourself like you are from PGI. So now I will come to my topic, and third thing, sorry, I forgot to mention about the mentors. These days, many residents come and say, "Doctor साहब, आपसे एक बात करनी है, कि आपसे राय लेनी है कि आगे क्या करें, बताइए." So they have practically come to say that we are leaving and joining some other hospital. We couldn't do that in our times. We were looking up to our mentor, and I must name few: Dr. B.D. Gupta, Dr. Ayagiri, Dr. Sharma, Mrs. Sharma, and we thought that we want to become like them, and therefore we stayed. But nowadays, I don't know whether this mentorship is still existing. The people who look up to somebody to guide their career. Coming to the topic of gains and pitfalls of IMRT, it's a very, very important topic in the sense that we are all practicing IMRT. We started in the year 2012. Now it is 10 years. And you can see many of us must have seen the benefits, and many of us must have seen the pitfalls, some of the, I would say, accidents out of IMRT. So I will be discussing these under these heads, some of the clinical issues like delineation, which we all know is one of the most important aspects, radiation planning considerations, tumor dose, dosimetry requirements, setup errors, motion, etc. So you can see there are so many issues, and it is very, very cost intensive as well as manpower intensive. You need much more staff. You need much more people to run this program, and therefore, in many centers of India, it may not be possible to do. The technical advances we have seen in the last decade and a half, I'm going to talk only in head and neck cancer, and it has made a distinct difference in our long-term morbidity, especially in xerostomia and dysphagia. And randomized clinical trials have demonstrated a superiority. That we know that IMRT is superior to conventional radiation in some forms. So coming to the loco-regional control. So if you see here, the loco-regional control from most of the series, as you can see here, is in the range of 90%, 80 to 90%, and etc. And you can see now how much the incidence of xerostomia has gone down. Just about 12 to 30%, while if you treat locally advanced head and neck cancer, almost everybody used to get xerostomia. So this incidence is around 12 to 30% depending on the location of primary and the lymph nodes, etc. Our own series we published in 2008. We had also a loco-regional control of 77% and xerostomia and chronic dysphagia rates as mentioned here. So it is a major advantage as far as long-term morbidity is concerned. Quality of life is concerned, as we were talking in the morning, that quality of life of the survivors, whether they can eat in public or in social function, they can interact, it makes a huge difference. So we know that day in and day out we are doing this. You can save the parotid glands. And somewhat better, you can all have a better technology and you can do some more. For example, the parotid sparing becomes even better when you employed VMAT or rapid arc to these patients, and the treatment time is also shorter compared to the 7-field IMRT or dynamic IMRT. It's also very important, maybe for the benefit of residents, that we must do a lot. We must spend a lot of time on the contouring. And one of the structures I have seen often not put attention to is the dysphagia-related structures. So everybody talks of xerostomia, but dysphagia is also, I would say, more troubling than xerostomia. Patient can't swallow. The roll is dangling in the oropharynx, not going down, not maybe because of xerostomia, but because of dysphagia. And it can be spared with IMRT. So this is our publication, which I mentioned, the favorable impact of IMRT on chronic dysphagia. And you can see here the rates at 6 months that grade 2 chronic dysphagia only in about 12 to 12.3%, and the xerostomia grades were around 7 to 10%. So this is a major advantage of IMRT over conventional radiation, which was our bread and butter for many, many years. So not only that we we do this benefit, but we save so many of these structures. And why it is so important? If you are not able to save these structures, you won't be able to deliver a high dose. You won't be able to deliver a tumoricidal dose, which is now anything between 66 to 70 gray, especially structures like nasopharynx, paranasal sinuses. You can't cure them if you are unable to reach constraints to these. And I've seen some of the long-term survivors of nasopharynx treated 15, 20 years back in my old hospital, Batra, etc. And you actually sometimes repent that why you delivered such a high dose. They have, one of the patients I saw, he had all the complications described in the book, right from the loss of vision, the hormonal deficiencies, you name it, and they have a thin neck, mandible problems. So this is very, very important that we, at present with IMRT, we can save life and we can maintain quality of life. This is one of our long-term survivors. Show a few more pictures. So although this was clicked in, she treated in 2003, clicked in 2005, but still surviving. She has gone much older now. But you see the health of the teeth, the wetness of the mouth, and good quality swallowing. And that is the gratification you get, that the patient is well and leading a good quality life. So when we have to balance out gains and pitfalls, there are two major problems or two major factors which we must keep in mind. One is the delineation, because we have to imagine the tumor in 3 dimensions. And sometimes you have CT scan, sometimes you have MRI, sometimes you have PET scan, sometimes you have only CT. And many of the mistakes are made in the craniocaudal direction, I can tell you. And whenever I check contours of my residents, most of the mistakes are in craniocaudal direction, because actually you are just going, and ultimately when you see in the sagittal or coronal section, you find, oh, superior margin is inadequate or the inferior margin is inadequate. Second important thing is day-to-day variation. In IMRT, we are giving very narrow margins, so therefore these variations become much more important compared to conventional radiation. There, we used to have two parallel opposed, a single anterior field, and everything used to come in between. But here, you will not treat a structure if you have not marked, and you will not save a structure if you have not marked as an OAR. So both ways, you have to be extremely cautious. And sitting in the TPS, I keep reminding people that it is like an operation theater. Surgeons sometimes talk, but many times they are concentrating on what they are doing. But if in contouring we are talking to each other, having a cup of tea and contouring, we can miss many things. So I think this is a word of caution for IMRT. The task is much more complicated, much more labor intensive for us. Our eyes get tired by the evening. So it is possible to be precise, and also precisely inaccurate. And we can, this is not this is actually Chris Nutting saying, I just forgot to mention here. And if you are not precise, you can miss tumor. The greatest risk is missing the tumor, or sometimes giving unintended dose to a critical structure. So therefore, IMRT is, so when you are looking at IMRT, highly conformal dose distribution, and some of the advanced tumors of, as I mentioned, nasopharynx, sinonasal, beside other tumors of the head and neck, you gain a lot by delivering a high dose, by saving normal structures. But the pitfall, beside others which I mentioned, is also a learning curve. It's not a sharp learning curve, it is a broad. And it depends on where you have been trained, how much time you have put, how much attention you have put to clinical details, to the radiological features seen in the CT scan, MRI. Have you gone to the radiologist? Because we are not radiology experts like Dr. Ayagiri. We have not done MD radiology. So we have to get it confirmed from the radiologist to verify our target volumes, or at least the tumor should be verified with them. So it requires, as I said, very careful delineation. And if we are not careful, there are some recurrences which are peculiar to IMRT, which I will point out, but there may be several others. And these are related to our desire to spare the parotid gland, and can lead to relapse at skull base and periparotid failures. For example, this is an example quoted here, and you can see this patient was treated with IMRT, and you can see here parotid sparing done on both sides, and a recurrence occurred right here at the root of the parotid gland or base of the parotid gland, and this is as a result of careless parotid sparing. So what I feel, and many of the authors, that please don't try to spare parotid gland on the side if there is a bulky lymph node, or if it's a big oropharyngeal primary. Don't save the other side. Save the other side, because one parotid gland may be enough, while a recurrence is unacceptable. So this patient had a recurrence 15 months later after completion of radiotherapy. So this is another one. This is a marginal recurrence in the retropharyngeal lymph nodes. So epicenter of this is cranial. Normally we will take C1, C2 junction, but this is at top of the C1, right, quite high on the C1. This is because of the bulky lymph nodes down below in the neck, and you have not taken your contours right up to the tip of the stylet process. So if you miss that, and the cranial limit, as I said, craniocaudal inaccuracies are a lot in the clinics, you can see these retropharyngeal recurrences as seen in this example. And even on the contralateral side, extensive recurrence in the retropharyngeal space on the contralateral side also. So this is the patterns of recurrence. So whenever you get a recurrence in your clinic, please go back and see why this recurrence occurred. If it is in field, which is 80%, is probably not your mistake. It's not our mistake. It is inherent failure. But if it is a marginal recurrence or the recurrence which I described at the base of skull, then it's something to do with us. We have not done the job properly. So this was Laura Dawson. This is Ishbrook. He also saw this was the most frequent level 2 high jugular-digastric nodes, marginal recurrences in 4. So these are not uncommon. And we should always study our patterns of recurrence in our department because our patterns can be different from theirs. So therefore, the suggested superior margin here is right here, where the tip of the styloid process, ipsilateral to the primary tumor, and if there are bulky lymph nodes, especially in the neck. So, as we said, target delineation considerations, I'm putting a lot of emphasis, and you should have access to a good, maybe your own CT simulator in your department, and PGI has, I think, 2. And so 3 millimeter sections, excellent image. We should have actually better images than radiology department because they used to send us monitors which were actually not medical grade. And I checked with them. In radiology, they will get medical grade monitors, and to us, they give ordinary monitors. And when we bought the medical grade, you can see a distinct difference. Then there are certain protocols of transferring images from CT scan to your planning system. And there are various methods by which you should transfer the head and neck, the brain, thoracic, abdominal. Everything is different, how you transfer the images. Because once you see images in the radiology and come back to your monitor, you say image is not good enough. You don't see platysma here, you see platysma in radiology department, same patient. So I think this, so when we were installing our CT simulator, so we sat with them and we made sure that we transfer the images from the CT simulator to our planning system in the right way. And we should all select our window, etc., for better visualization. Because if you don't visualize subtle findings, you will miss it. Again, another gain of IMRT is it can deliver adequate doses to difficult anatomic locations like base of skull, like in nasopharynx or in these patients with perineural invasion or PNS or PNI. So you have to cover then all these foramina, and there's no way you can cover this with the conventional 2D radiotherapy because all these structures are around and IMRT comes to the rescue and you can do a good job. This is a suggested contouring for PNI, perineural invasion positive patients, where you have to contour, as I said, base of skull according to the route of spread, and you have to put a bolus. We have published a paper also on PNI. You put a bolus all here. Now, why we should put a bolus in a PNI patients? It is because of the antegrade spread. So we have covered the retrograde spread going to the base of skull, but antegrade spread finishes in the subcutaneous tissue. So that's why PNI positive patients have higher chances of a dermal recurrence. And if we cover with bolus, we can rescue, we can do a much better job. Again, now, when we are coming to the contouring, other aspects are, we have some guidelines for GTV, we have some guidelines for CTV, 1.2 centimeter, 1.5, etc. Come off this airspace, come out of bone, etc., etc. But what about in head and neck, deep spaces of head and neck? And there are so many multiple spaces, and we don't know. For example, for CA alveolus, patient has say a 2 centimeter lesion, but with bad pathological features, poorly differentiated, PNI positive, LVI positive, multiple nodes. So what are the deep spaces you have to cover, because local spread is the predominant spread. While we put a lot of attention on neck node, this level, what about the local tumor? So these are the potential routes of spread of parotid space, masticator space, submandibular space, parapharyngeal space, carotid space, retropharyngeal space, perivertebral space. So these, and if you see very good, 2-3 good papers from France, and they are describing for each site what and how much deep space you have to take for a particular subsite of head and neck, or rather oral cancers. So these things are kind of fuzzy in IMRT contouring at present. Another thing which keeps coming every time is, for example, this is a supraglottic piriform sinus, and you have taken this GTV and you have taken CTV around it, whether we should treat the entire larynx, hypopharynx, or we should treat this GTV with CTV and little less dose to the contralateral part of the larynx. So there's no clarity. Some people, we do it this way most of the time according to Chow, but if you see the other recommendation, they will take the whole and various other. So there is a lot of dissimilarity in target delineation and therefore the uncertainty. Now, for neck nodes also, there is no single atlas which you will follow. There are various atlases, especially for N0 neck. Which one will you follow? And whether your colleague is following one atlas, you are following another one, a new resident comes, he joins another one, then there is no homogeneity in the department. So we don't know whether we are faring well. So other thing is we should have a departmental protocol that we will do this and nothing else, not a new recommendation come and we implement tomorrow. So we should have a comprehensive knowledge of lymph nodes because, as you see, things become more and more complicated as the regions like nasopharynx and locally advanced head and neck cancer. You can see number of lymph nodes and their delineation. You can miss some. So therefore, the surgical report, the radiological report, the clinical examination, they all become very, very important because you enroll a patient today and you start contouring maybe third day and most of the things we forget. So you have to have a file in front of you and every other thing. Another gain of IMRT is that it can deliver variable dose to variable volumes. For example, here one can see simultaneous integrated boost. You can, hypoxic component, you can deliver 70, 72 gray. Then subclinical disease, you can give maybe 66, then 54, neck node so, and while parotid sparing. So this is a big gain of IMRT. What is the role of MRI? Initially, publication came and say a good quality CT scan is good enough. But I don't think so. Because so many things which we can't see on a CT scan. For example, these spaces, they're quite fuzzy on CT scan. MRI is so clear, especially 3 Tesla MRI. It's a treat to do contouring with a fusion, but fusion has its own problem of co-registration and things like that, and mismatch of registration. So all those things also, there's a pitfall that you co-register and then there are errors. Then bone marrow invasion, sometimes you see mandible is positive, but pathology report says that the marrow was also positive. Then you have to take a wider margin. People have not noted and patient can have a recurrence. So marrow you can see very clearly on the MRI. And then boundaries, especially craniocaudal. MRI typically gives you sagittal coronal reconstruction and you can avoid many of the errors in the craniocaudal direction. You can also, so this is the GTV marked on MRI on the CT. Uncertainty brings out a bigger volume. And when you see, and sometimes I ask my resident, bhai itna bada bana diya, to fir parallel oppose hi kar do. Then what is the need? So this is because of many things, but CT also contributes to enlarging. Yahan pe bhi thoda hai, yahan pe bhi hai. So MRI brings that down, and therefore fusion wherever possible should be done with MRI, not too much with PET scan. PET scan other thing, but PET scan doesn't help in this because its resolution is as good as CT scan. Then sometime when we are combining with chemotherapy, especially Erbitux, you see sudden unexpected skin reactions. Then why it should happen? It should happen because this was our age-old parallel opposed fields, oral cavities out. So, and therefore, we used to get very little anterior lip and oral reactions. But with IMRT now you see, you are firing from all sides and you can get higher incidence of acute mucositis, especially with Erbitux. We are quite scared of the mucositis as well as skin reactions with the IMRT. And therefore, what should we do? The reasons are multiple tangential fields, bolus effect due to cast, especially in the lower neck, and if you have to cover superficial node, inverse planning system, the system doesn't know whether it is sensitive or not. It will bring in more intensity on the skin to cover it if you have covered it all in your PTV. There has to be a gap, we all know, but sometimes you draw a PTV and it covers all. So whatever labor you have done on CTV, PTV covers all and it spoils the show. So there you have to hug the PTV to CTV. Contour neck as sensitive structures. If you feel there are some sensitive area, contour it and you can avoid. And you stretch the cast to reduce its thickness in the lower neck. This is the, so we saw this way back in our Rajiv Gandhi, and I talked to Mr. Negi, so why this kind of, this is actually published, but we saw a similar reaction. And he came out with publication next day. And since then, I'm quoting this everywhere. This is patient base of tongue, and you can see this kind of reaction because of the reasons mentioned. Similar things will happen. You have a bulky level 2 lymph node. What to do now? And so whether you have to put a bolus. If you put a bolus, what will happen to the skin dose? And patient receiving chemotherapy. You have to be careful, and you need individualized considerations for every patient, and maybe planning and replanning. Coming on some of the margins, basically these are the other, beyond contouring now, this is the other physical problems which we have. There are some motions happening, respiratory movement in the oral cavity, or sorry, in the head and neck also, but pharyngorectum in prostate, for example. And then there are setup uncertainties. So everybody should know what are setup uncertainty in our department. It is not same as we have in, say, in my neighboring hospital. It may be more here than in a, so it depends on how good is your immobilization, how good is your imaging, how often you do the imaging, and how good is the machine stability, etc. There are certain formulas, and they say that you have to make a balance that it should not miss CTV and it should not have more complication. Therefore, you should pick your PTV according to the need, and it is not uniform for all patients. So here you can see that displacement uncertainties of 2 to 6 millimeters are generally observed. And what you can see here is that this is, I was talking of swallowing. You can see here when the patient swallows, it rises up, and therefore your margin will reduce. So this is the kind of motion you see in the oral, in the larynx hypopharynx area. And many times we tell patients, most of the larynx hypopharynx, we tell not to swallow during treatment. We don't have any control over this, but we teach them and tell them, we put into them that please don't swallow during radiation, if whatever is possible. So this will also, this another uncertainty. On day 9 itself, the cast has become loose. Many reasons are there. Sometimes shoulder, you put, first day patient is tense, he keeps his shoulder tough, next day he relaxes. When he comes on day 9, is more relaxed in the department, or sometimes he loses weight towards the end of the treatment, so you have to change the cast. Then if you do all this, another pitfall is how often you will do image guidance. Will you do daily? Will you do first 5 days and then you decide what are the setup errors and what is the random and systematic errors, calculate, and then do twice or thrice a week according to that patient. So these are all very, very, so what it all says, that it's a much bigger task than it actually looks. Give IMRT is a very big task. Adaptive radiotherapy, because it is so uncertain, now let us come on to the adaptation. A simple adaptation most of us are doing. We repeat CT scan once, we will do a simple replanning, we'll keep the initial constraints, and it is usually offline. So when patient loses weight, we readjust the cast or make a new cast, rescan, and then we replan, and then we see the residual dose, and then we try to do it. More complex is you do daily CT scan or MRI. We are now having a MR LINAC, daily CT scan or daily MRI, functional imaging. Then we have to have a deformable registration because you are now co-registering with the previous days. Now these are the co-registrations happening. Then you have to have a deformable registration. You have to calculate dose accumulating over the days. then you have to replan daily. You will replan daily on the machine, and you will change the constraints according to what parotid has received and what it's going to receive, because it is shrunk. Parotid gland also shrinks during treatment. And online, it will be, everything is done online, then patient is lying on the table, how many things you will do online. But most of these complex features are there in MR Linac. Most of these. And it is not daily CT scan, it is daily MRI. It doesn't allow you to do treatment without doing an MRI. So this is MR Linac. Fortunately, unfortunately, we are going to have one another year. And it will have a superior image guidance and adaptive planning, where it is done daily. You read sometime, you say, okay, there's not much of change, but MRI has to be done, then you push it. If you have to do, then you have to do reaccumulation of dose, all those things. And this is another way of technology which is growing. This is the MR Linac which we will have. It is under process. So these are some of the results of our patients treated many, many years back. It's quite gratifying, I must say, barring the recurrences. So we have to know where are the recurrences happening. But patient who survives will have a very good outcome. Therefore, we should work on more and more survival and more quality. This is the same lady. The same, another patient, nasopharynx, this also was treated way back in Rajiv Gandhi when we started. Actually, that time we were doing compensator-based IMRT with Mr. Negi, we wanted to express my gratitude to him because he allowed so many compensators to be made. Dr. Kataria is here, 7, 9 compensators going on a trolley for treatment. This was very tough, and 2 to 3 sets of compensators were made in a day. It was so intensive and a lot of lead coming out of the whole place. And so this is nasopharynx, but you see hair grow back, the saliva and the dysphagia, and dental health is so much maintained because of good saliva. Actually, the caries happens because of bad saliva. If saliva is maintained, dental caries will be much less. So take-home message is that IMRT has substantial advantages in the long-term morbidity with improved local control, especially not in so much in early head and neck cancer, but in locally advanced, because we can give 66 to 70 gray even in locally advanced head and neck cancer, which is difficult with conventional radiation. It is technically more demanding due to uncertainties, as we have discussed. Some of them, they are not all, many are also there. And in many aspects of its implementation, it has a long and wide learning curve. And despite 6, 8, 10 years experience, and sometimes we say interpersonal, intrapersonal variation. You contour at 5 p.m. and the next day morning you say, oh, I missed this. So this happens because you're 5 p.m., you're very tired and you just contour and go, and then maybe a resident points out, Doctor Sahab, isko bhi dekh lijiye. So I think it's a big learning. You should have more people in the department, and at least 2 people should check contours before we send it to physics. And should be practiced in a well-equipped department with good quality control. We have no shortcut here. Radiation oncologists, medical physicists, and technologists should be well aligned. It should be I would say, a good atmosphere where everybody listens to each other, and not that I am doctor and you are physicist and technologist. So it has to be a very good atmosphere where a team approach can be made to obtain optimum results. Thank you very much.
Thank you, Dr. Anand, for discussing the advantages and pitfalls. And a lot of water has flown under the bridge over the last 2 decades. You mentioned about compensators. I remember year was 2000. I was in Istanbul attending an ISRO conference. IMRT was coming up at that time, and I had seen SRT and SRS. I was fascinated. Rajiv Gandhi had a Siemens accelerator, no multi-leaf collimator. In that ISRO meeting, I saw a manual multi-leaf collimator. So very fascinating. I came back. The cost was not very much. I discussed with the management, and they agreed. But the best part was that Mr. Negi agreed to make compensators, because you had to make a shape and then one compensator, step and shoot, and then number of compensators for a particular field. And that is when at Rajiv Gandhi, IMRT started. And, when we did a few patients and we saw how the rectal and the bladder dose went down, and one of our associates, Dr. Shekhar Haldar, presented that at Takahashi Memorial meeting in Kyoto, in Nagoya, and was awarded a gold medal for that. And it was really fascinating.
Very nice.
And we, then came on to dynamic multileaf and, a lot of things. So really fascinating.
Yes.
Any comment or question to Dr. Anand? Thank you very much.
Okay, thank you.
Thank you, sir, for the immense insight on IMRT and head and neck cancer. Now we have another session of SBRT, but pertaining to lung cancer. I invite Dr. Tejinder Kataria to speak on the topic. And I request Dr. R.K. Seem and Dr. Josie Tom to chair the session, please.
Good afternoon, everybody. I should thank the organizers, first thing, for giving me the opportunity to chair a session in PGI Chandigarh, which I have never done earlier, in front of my teachers and my seniors. This is the first time I am chairing a session in PGI Chandigarh. Second, I should congratulate the team for selecting the speakers. One, we just had the talk by Dr. Anand. As Dr. Huku said, 20 years back, I went to Rajiv Gandhi Institute for a short training in brachytherapy, where Anand and Kataria were there. And Dr. Negi also was there, Professor Negi also was there. And he told me, last year we completed 250 cases of IMRT. That year I went to Apollo Chennai, and they said they have completed 10 cases of IMRT. So these are people, pioneers in IMRT in the country. And I should say, Tejinder is the right person to speak on SBRT in lung cancers. Please.
Respected chairpersons, dear teachers, friends, colleagues, peers, I have a lot of excitement because I was coming to PGI, I was coming to Chandigarh to meet all of you. But like Dr. Jalali said, that you still feel like you're a resident. So standing here on this podium, my first delivery was on a staff's CPC, which Dr. Obidi Gupta had handed over to me to do for him. So from that day, the feelings have not changed. So please pardon me in case there are any slips or if there are some things which I miss, and especially Anushil is here who knows and does a lot of lung cancer. So I'll be deliberating in the next 20-25 minutes on SBRT, or SABR as it is known as now, in lung cancer, and how it is different from the conventional fractionation is where we have a homogeneous dose distribution within the target and slow fall off outside the target. In SBRT or SABR, we have very high doses within the target, which are inhomogeneous, and there's a sharp dose fall off outside the CTV or the PTV. So the commissioning and accreditation of SBRT and SABR have come a long way from the time when we started in 2008, and the world literature started populating in early 2000 and late 99. There are AAPM guidelines, 9A for SRS SBRT published in June 2007, which is a good compilation for anybody who's wishing to start the center for SBRT. Then there is an ICRU report 91 for prescribing, reporting, and recording of the stereotactic treatments for small photon beams, because the small photon beam dosimetry is entirely a different ballgame. And then there is the task group 76 from AAPM, which is for the respiratory management in radiation oncology. And then there are the radiation oncologist guidelines for contouring, prescription, prescribing, verification, and delivery, which are from Estro and Estro, both which were published in 2017. In between, there have been a lot of papers which have come through on which we learned, and we learned from our seniors and peers when we started this program. So why is it important for us to discuss conventional fractionation versus SBRT? Why does it make a difference in lung cancer? Cox et al. Collated RTOG trials, 3 of them, where 1,244 patients were taken, and out of those, 397 patients experienced delays. And in 70 patients, the treatment gap was of more than 5 days. The 3-year survival was 17% without delays and 1% in the patients who experienced the delays. And median delay of 11 days led to a median actuarial loss of 19% control at 3 years at the rate of 1.7% per day, which is almost equivalent to what a head and neck cancer study shows us at 1.66 gray per day. So this data and other data from University of Michigan was plotted by Martel et al., where they calculated and escalated the dose to 103 gray over 10 weeks for lung cancers in increments of 3 patients. And it was found that only 50% recurrence-free survival at 30 months was achieved at 84 gray. That is when they were not accounting for the reproliferation. But if reproliferation is occurring, then the loss is much higher and the control rates are poorer. But if we do not account for the reproliferation or the accelerated repopulation, and the doubling time we take as 3 days or the repopulation starting at 28 days, then we get a better control rate. But we know that the hypoxia cell will come back into the circulation, but at the same time, we'll lose the control over a long term. And this data was then plotted by Jack Fowler et al. And published in 2005, where the conventional fractionation 2 data sets were compared to the already practiced SBRT data sets. Because the SBRT, you are able to complete the treatment within 1 to 1.5 weeks. So the repopulation and the doubling times of the tumor cells are much lesser. And that does not kick in. So the control rates were normalized at 2 gray per fraction, and the BED was found to be much higher for the SBRT protocols, between 3 to 4 fractions, with estimated progression-free survival of 30 months, assuming there is no hypoxia during the SBRT, were in the tune of 95 to 99%. These were actual data sets plotted and published, which were already published and were plotted by Jack Fowler et al. So does that happen in real world also? Because we are working in the real database, in the real world. So the biologically effective dose of SBRT and survival in early stage non-small cell lung cancer was published by Moreno et al. When they queried the National Cancer Database from America over a 10-year period. And the patients who were in stage T1, T2A, N0, M0, it was seen that the patients who received a low biologically effective dose between 100 to 129 gray, there were 59% of the patients, and the high biologically effective dose of more than 130 gray, there were 283 patients. This is 28%, sorry. And the 5-year overall survival rate were 26% for low BED versus 34% for high BED. So we may think that SBRT is going to convert all patients into cure, but maybe that does not happen. Now what's happening there? So we'll just go through a little bit of information and then we'll compile at the end as to whether we should go for SBRT or whether we should not go for SBRT. I'll leave it to the House. So this is a phase 3 trial, and from Australia and New Zealand, 11 centers participated in this. Over 101 patients, 66 patients were offered SABR, and 35 patients were receiving conventional fractionation. And we find that over 35 months, the control rates, both the freedom from local recurrence and overall survival, are much better in the SABR arm. And the fractionation schedules were 66 gray over 33 fractions, or 50 gray mildly hypofractionated, depending upon the center choice. And for the SABR, between 48 to 54 gray. They were all inoperable FDG PET stage cases. So the data does show that there is an advantage to receiving SABR for well-staged, early-stage lung cancers. Now, what are the indications which have come through in the last 2 decades? Medically inoperable or patient refuses surgery. For a T1, T2, N0, M0 non-small cell lung cancer, which could be an adenocarcinoma or a squamous cell carcinoma. Very select T3, more than 5 centimeters, but not more than 6 centimeters tumors. So this is an emerging area. Then recurrent non-small lung cancers. So re-radiation should be considered for patients who are, again, not operable or at a high risk of further progression and only locally recurrent, but with very, very select parameters. Very few oligometastatic disease sites, like a single brain met or a single bone met with adenocarcinoma with either EGFR or ALK mutation positive. So these patients can be offered SBRT. And then, of course, to the lung, we have other metastatic sites from different primaries, which also come up for SBRT. So these were the first phase 2 trials published by Timmerman et al., the first one in 2010, and the second one in 2000 and I think it's 2000 one is 2010 and the other one is later 2017, I think. And this is the data from 0236, where they have shown that there was 3-year primary tumor control of 97.6%, and involved lobe control was over 90.6% when the patients were treated with SBRT. 60 gray in 3 fractions was given. And an updated data of the study from RTOG 0618 has been recently published, where they did include T3 tumors. Only 1 patient was T3, most of them were T1, T2, and the 2-year primary failure was only 7.7%. But the 2-year progression-free survival, although it was 65.4%, the overall survival was 84.4%. So where are these patients failing? They were failing distantly or nodal. And if they are ALK mutated or EGFR mutated, then they can go on either TKIs or immunotherapy, and their control rates can increase. So that is an area where the explorations are happening. So what happens with SBRT? So immediately after radiation, a number of cytokines are produced and maintained for a period of hours. It's only a few hours, but the effect starts working and continues for a month. That is when the acute shutdown of the early inflammatory phase occurs and the breakdown of the tumor cells occurs, is picked up by the histocompatibility complex and the reticular formation through the lymph nodes and brought back into the T cell modification for mounting the immune attack by the body. That is one pathway. The second is that over long term, over a year or so, there are some stem cells which proliferate, mature, and the stromal cells then shut down, and the vascular machinery which has already shut down stops the supply. So this is where the mechanism of SBRT occurs. And later on, there is collagen accumulation because of the chronic inflammatory cytokines, which can result in fibrosis, strictures, and we may also see in the lung cancers, especially if they are ultracentral tumors, in tracheoesophageal fistulae. So that is the catastrophic situation which should always be avoided. These are the RTOG proposed radiation tolerances for thoracic normal tissues for a dose of 60 gray. These were pertaining to the previous 2 trials which I have alluded to, and they were given only as any point dose. But over time, the task group 101 has given an elaborate data set for each site. I've just written down here for the lung and the thoracic area for treatment, where a point dose of Dmax in a fraction of 3 fractions, because this is what I was looking at, but you also have it for 5 fractions, and you have it for 1 fraction also. So for lung, I have not practiced single fraction. For liver, we've done only 1. For brain, we do single fraction, and for bone, we've done 2 fractions. So you have to look at what is the organ at risk close by. Like what Dr. Anand said, organs at risk in IMRT are much wider. Here, there are close, very tight margins, but still you have organs at risk. So bronchus, Dmax 23, but then there is a 0.5 cc. So second constraint is always a slightly lax constraint. So if you're not able to achieve the point dose, then maybe you look at the second constraint, but try to always meet the first constraint. Great vessels, esophagus, total lung, rib, trachea, stomach, brachial plexus, and spinal cord. So these are already available and published, and it's also available for other body sites. Now the RTOG phase 2 studies, which we alluded to, only looked at the peripheral tumors. They excluded the central tumors, which are within 2 centimeters of the proximal bronchial tree, because of the risk of higher toxicity due to the esophagitis, bronchial strictures, and consequent atelectasis and collapse of the distal segments of the lung, as well as a tracheoesophageal fistulae. But then RTOG 0813 was a dose-finding study for the central tumors. And also some cases for ultracentral tumors. We are getting really, very exciting zone here, but then it's very strict area where you must be very paranoid as to what you're going to do should not harm the patient. If you're going into the ultracentral area, which is where your PTV, that is 5 millimeter margin to the GTV, is abutting or overlapping the critical structure, like a great vessel, the bronchus, trachea, or the esophagus. And in other case, when I'll show you, we look at the brachial plexus, but there was a patient who had a phrenic nerve passing through the tumor, and we ended up having a diaphragmatic palsy because the phrenic nerve was not respected tolerance. The tolerance was not respected. So the recommended definition of central lesion is a tumor within 2 centimeters in all directions of any mediastinal critical structure, including bronchial tree, esophagus, heart, brachial plexus, major vessels, spinal cord, phrenic nerve, and recurrent laryngeal nerve. Because otherwise you might end up having patients with stridor or aspirations in case the recurrent laryngeal nerve goes. So there were different dose levels at increments of 0.5 from 8 gray to 12 gray, and a total dose of 40 gray to 60 gray was delivered over 1.5 to 2 weeks. And 120 patients from 2009 to 2013 were accrued. 2-year local control in these centrally located tumors was 89% for 11 gray and 87% for 12 gray per fraction. And the maximally tolerated dose was 12 times 5 with a 7.2% of dose-limiting toxicity. And this dose-limiting toxicity was esophageal ulcer and a fistula, and in 1 patient, a bronchopulmonary hemorrhage. 4 patients went on to have dose-limiting toxicity, and hence the upper limit was defined as 12 gray, but preferably between 10 to 11 gray per fraction should not be exceeded for the central tumors. So the tumors invading the bronchial tree or the mediastinum, although physically central, are not considered safe targets for SBRT programs. And these are the different dose protocols where peripheral tumors, which are 1 centimeter away, which have almost 1 centimeter of pulmonary tissue around them, central tumors, and ultracentral tumors. But invasion of central structures is the big no. That is a total no-fly zone for SABR cases. So this is the outcomes of stereotactic ablative therapy for central lung tumors, a systematic review. And we have moved from absolute no-fly zone to fly with abundant caution in the central zone. But in the ultracentral, where there's an overlap, please do not step in. So this was a study published for ultracentral. This is a study protocol published 4 years ago, for a phase 1 study for T1 to T3 non-small cell ultracentral tumors. And the dose level is starting from 60 gray in 8 fractions. So what the authors are planning is that they'll reduce the dose per fraction, which is as per the Dutch guidelines. That was the first study for central tumors, but here they have started for the ultracentral tumors, but the study is not yet mature. This is the only study protocol yet available, and tumors are to be below 6 centimeters in size. Now, what is the effect of the prescription isodose? I mentioned that we do not use homogeneous dose distribution here. So we always have a lower isodose covering the periphery of the tumor, creating a hot spot almost 125 to 130% within the center or the core of the tumor. That is where the hypoxic cells lie, and that is what cures these tumors. And non-uniform dose distribution throughout the volume of the tumor with the highest dose delivered to the central portion is what cures or is responsible for the local control of these tumors besides the short time of treatment. And this is pictorially shown that if you prescribe a 20 gray dose to 50% isodose, you can achieve a 40 gray dose to the central of the target. And whereas if you prescribe to 20 gray to 80% isodose, you'll only get around 25 gray. So the prescription doses here are very different from what we do for conventional fractionation and for IMRT also. So how do you evaluate the stereotactic body radiation dosimetry? It includes scrutiny of 3 categories. That is target coverage, high dose spillage, and low dose spillage. For target coverage, normalize the dose to the center of the mass of the planning target volume. With such normalization, the edge of the PTV is usually encompassed by the 80%. That is for our peripheral lung tumors, but for the central lung tumors and ultracentral, it is 65% isodose. And the prescription dose is given to the isodose encompassing at least 95% of the PTV volume, and it is required that 99% of the PTV volume should get at least 90% of the prescription dose. Unlike the IMRT, where you have the range from 93 to 105%, so here our range is very wide. So we start from 90% coverage, and we go down to and the 99% volume to get at least 90% of the dose, and not the 93 and 105%. And any dose greater than 105% of the prescription isodose should occur within the PTV. If at all there is some dose spillage, especially for the central or ultracentral tumor, when we are sitting very close to the main bronchus or the segmental bronchus, or very close to the esophagus when the tumor is ultracentral, in those cases, then the 105% of the prescription dose should not be more than 10% of the PTV volume. So this has to be diligently followed. There are other confirmation numbers or confirmation indices which we follow. And this is the best where your PTV is, or your volume of reference is covering the target completely. And it should be kept between 1.2 to 1.3. The dosimetry considerations again are that the pulmonary tumors are partially or completely surrounded by the low density tissue, where the density is 0.1 to 0.3 gram per ml. And the secondary charge particle equilibrium is violated at the tumor-lung interface. Significant reductions of the dose at the tumor edge of up to 25 to 30% can occur depending upon the photon energy, the target volume, and the location with respect to the inhomogeneity. So hence, you should go in for point kernel-based superposition convolution algorithms or Monte Carlo approach rather than the pencil beam scanning, because you cannot get that kind of a distribution, and if you have not corrected for the density of the air to the soft tissue interface. There can be large respiratory movements, especially for the inferior and the peripheral tumors. So in the expiration and inspiration, you see here at the periphery, there is a mismatch. And in the expiration, sometimes the diaphragm can move up almost 5 to 6 centimeters. So for our patients in whom we have to have peripheral tumors or the ones which are located close to the diaphragm, I never go in for a cyberknife treatment planning, because there the interplay is just about 5 to 7 millimeter. So we go in for deep inspiratory breath hold for these cases. So there are ways which all of you know how to manage the respiratory motion. Gold spheres came long time ago, and a few centers still use them in the intrabronchial space, but because of coughing and breathing, they can get displaced. So we do not use any fiducial markers. We do a deep inspiratory breath hold when the lung is static, and we take the scans in the end inspiratory, end expiratory, and free breathing. Create an ITV, then create a PTV, and then treat them. And for the cyberknife, we have a lung optimization treatment protocol, whereby we have the 2 cameras inside the room with which we can map out where the tumor is seen. And depending upon the 1 view, 2 view, or 0 view, that is when the cameras can see or cannot see the tumor, we give the ITV and then treat these patients again with 3 scans being done for each case. So these are a few of the motion management strategies: external breath control, gating with RPM, tracking with the CyberKnife, and deep inspiratory breath flow. So this was the first time which we used in 2008 for a sarcoma, a renal cell sarcoma. That was the first case for SBRT, Dr. Jose, which I did. And she was a doctor. She had had a metastatectomy for her lung renal cell sarcoma done in Bombay and recurred within 3 months. And she walked into the clinic, and I had just come back from UPMC. And I was a convert to SBRT after having seen Steve Burton's data. He had done 800 cases, and the results that he showed were absolutely breathtaking. So she walked into the clinic, referred by a medical oncologist, and asked, "Doctor, can you treat me?" So renal cell sarcoma is supposed to be a highly radioresistant tumor. So I said, "Yes, ma'am," because I had the equipment. We put her up, trained her, and I was so afraid of giving her 12 gray per fraction dose that I treated her once a week. I didn't know what's going to happen. But by the 3rd week, her bronchus had started opening up. She was left low main bronchus touching tumor. And 2008, it's 14 years. She's doing fine, no chemotherapy. So that was our learning. That is where we started. And here we know that in case the patient is not trained well, you can have a mismatch in the 2 inspiratory breath hold scans or the expiratory scans also. So you have to adequately train them, because here you see there is a difference. If there's an inadequate training, you may not get the scan in the same position, because you do the scans on day 1 and then you treat them over the next 5 days. And your target volume may be matched to this, whereas you're having a geographic miss in the case the patient is not breathing at that point. And then you have to have an adequate training. Also, there are studies which are published to show that despite the best motion management, there are uncertainties and gaps ranging from 3 millimeters to 10 millimeters in anteroposterior, lateral, and longitudinal direction. So you need to account for them, and that is why you need to continue to treat these with the PTV margin, which we don't do in the brain tumors. We don't do any PTV there. We just treat the GTV. And contouring of the tumor on the CT scan is highly depending upon your window width and the window leveling. So you have to mark the spicules in the lung window. Do not mark that in the soft tissue or the mediastinal window, because you'll miss the disease. But do not keep changing your window leveling, because if you do that, then you may over or under mark the tumor. And the soft tissue window should be towards the chest wall, not the lung window, when you're marking the tumors which are peripherally touching the ribs. PET-based automatic segmentation is now available, but then you need to decide which SUV you're going to follow and what fall off, whether it's a 20% isodose cutoff, a 20% SUV cutoff, or a 50% isodose SUV cutoff. So we do a manual marking, and we take the help of our nuclear medicine specialist to sit down and mark along with the radiologist. So there's no CTV in the SBRT, but PTV is based upon your institutional data, your setup uncertainties, the fixity of the tumor to the adjoining structures, and the location of the tumor. So you have to keep these in mind when you're marking. For our DIBH, we give 7 mm craniocaudal and 5 mm radial margin. But in the CyberKnife cases, because we have the ITB, which is already generated, internal target volume, then we try to keep the margins to 5 millimeter craniocaudal, and sometimes I'm very tight at 3 millimeters in the radial margins in case it's a 2-camera view, because the machine can tell me where the patient is breathing. So these are the CTC criteria for adverse events, which we all know. The earlier authors did not report much complications, and with a large number of data sets, that's almost 200 plus cases, less than 5% grade 3 toxicity was reported, because they were very selective in picking up these cases, and they were all peripheral tumors. But we are walking into the areas of no man's zone now. So what are the complications that can happen? Rib fractures, when the tumor is very close or overlapping over the rib, 9 to 17%. 10 to 12% pneumonitis, esophagitis, GI bleed because if the tumor is close to the esophagus, close to the GI junction, gastroesophageal junction, and to the stomach, you may end up having a GI bleed because the target may be moving, and the stomach may also be expanding and contracting, depending upon the level of fasting of the patient. So you have to be very careful about that. Then mediastinal hilar oligometastasis, UPMC were very, very brave, and they went in that area, and they picked up 7.5% 3 to 5, grade 3 to 5 toxicity. So anybody who's going in there, please be very, very careful. And also these patients then go on to receive VEGF inhibitors or immune checkpoint inhibitors, so the complications may multiply. So we ask our patients not to take their medical oncology drugs while they are on treatment. And they have to wait for at least 10 days to 2 weeks before restarting their medications. So this is the patient I was talking about. It was a pancreas tumor sitting very close to the vertebra, and the patient went on to develop a diaphragmatic palsy on the left side. The immune-mediated mechanisms can be abscopal effects, and they can work for the metastatic sites for liver. And this is not from our data, it is from another slide from outside. So you treat the lung, and the bone metastasis disappears, or the liver metastasis disappears. So these kind of abscopal effects are reported. Now what happens is, and why the tracheoesophageal fistulae occur? Because these are anatomically and embryologically two different structures. So the stem cells are different, and they are organized in parallel and series differently. So the stem cells do not cross over and repopulate. So that is why you need to have a very strict compartment here. So this is what the cartoon shows. And this is the data from different authors for early stage SBRT with good control from 2 to 3 years. A few patients were included in a couple of studies for T3 tumors or for recurrent disease. This is one of our star patients who was a CRPF retired swimmer born in 1939. Central tumor, coronary artery disease. What do you do? And the limiting factor was this node here, sitting in the pretracheal space, and an ultracentral tumor. So we hypofractionated. We did SBRT, which we normally don't do, because I think, and I see the results that beyond less than 8 grade dose, the control rates are very poor for SBRT. So here we went at hypofractionation, 66 grade 10 fractions to the primary, and 50 grade 10 fractions to the pretracheal lymph node. And pre-SBRT 2019, November 2019, the tumor has started shrinking, disappearing. This is May 2020. Patient is NED, February 2021. He's doing fine. He is, of course, on pembrolizumab because of the nodal status initially upfront, which he is tolerating well. Another patient where there was a pseudo progression within 3 months after 60 grade 10 fractions delivered in the central tumor, but the patient is NED a year later. So you also have to be aware of what is the evolution of your CT findings. If there is increased fibrosis or reticulation that's appearing, or there's a soft tissue mass that comes up post-SBRT, that's not always disease. These are the radiological changes because of the fibrosis and because of the alveolar resetting there. If you're not very careful, then sometimes there can be a segmental or a subsegmental collapse, and bronchoscopy may show that there is injury to the mucosa, or there's a stricture, and the patient may be more hypoxic because these patients are already having COPD before you treat them also. So this is a small audit, which I could do in 10 days, Dr. Rakesh, for 26 cases of only lung cancer. And we've treated, there was only one patient, the one I showed you for the pancreas tumor T4. Rest of them were T1, T2. And we delivered a dose. Most commonly practiced protocol is 60 gray in 5 fractions. And some of the patients we've given the dose that I've shown you. 5 central patients, 12 peripheral, and 9 patients were touching the chest wall. But then I underdose. We underdose, we create a small underdose, about 5% of the target gets underdosed in that area. respecting the tolerances. So this is a paper by Tithi Biswas. She's one of the co-authors on how to report the local control after SBRT for stage 1 non-small cell lung cancer. And these are the large studies which have been published for comparison of SBRT to surgery. This is the ILCAP study. And SBRT had 90% lung cancer specific survival compared to surgery, although the patients in the SBRT arm had more comorbidities. And this is a long follow-up. So with this, I'd like to bring to an end my conversation, and thank you very much.
Any comments or questions from the audience?
Thank you so much, madam. I think in a short span you have given all your experience. So I'd like to know from you, with this experience of 15 gray per fraction growth,
Mike, can you please use the mic?
I said she already has a good experience with 15 gray per fraction. So would you like to increase to 20 or more than that?
I've shown you 15 gray. I do 20 gray 3 fractions. Shika's smiling there. We started with 12 gray. Then I increase it, and for the liver tumors, I started with 8, went to 9, go up to 18 gray. So depending upon the size of the tumor, depending upon the proximity to the normal structures, depending upon, like in the liver, if it's close to the duodenum or close to the portal vein, because we treat portal vein tumors. So if it's close to the IVC or it's close to the duodenum or stomach, then we would not go to those high doses. But otherwise, 18 to 20 gray. Preferably 18 to 20. That is what brings the control. In pancreas, I was always wary, so would not go beyond 7 gray. But of late, if we have a good tissue around the tumor and the tumor is well encapsulated within the pancreas but close to the SMB or SMA, then we target it beyond 10 gray also now. So 5 fractions. Prostate, we are doing 7 fractions, but we go at 6 and 7 gray per fraction there. That's our radical SBRT program. And we've treated, and I think we published also, we've done almost 80 cases on that. They are all intermediate and high risk. With 95% 5-year control, we're following them up.
So thank you, Dr. Tejit.
Thank you.
Thank you.
And I stand here because of all the teaching and the training that I received at the hands of Dr. B.D. Gupta, Dr. Ayagiri, Dr. Firoza Patel. She told me she would take away my MBBS degree because I could not palpate a lymph node in a dysgerminoma case on first day because I didn't like gynae at all. So she did give me the MD, and I stand here very humbly to acknowledge that to Professor Sharma and to Professor Negi. I put in those physics and the dosimetry aspects because I thought that would make him happy. He thinks that I do not know radiobiology, so which is very humbling. Thank you so much.
Thank you, ma'am. Thank you, sir. It's almost 1:30. We shall now disperse for lunch and join back in 45 for the post-lunch session. All senior faculties are requested to have lunch within the campus.
The senior faculty, because of paucity of space, will have lunch in the area which is just inside, that is for ground floor, and it is vaccine area, covered area. Yeah, we'll have it at 3:30, ma'am. All, because Jalali has gone for a session, and so all will be together. After finishing, we will go for a photograph. And rest of the department people, please, all the departmental colleagues, they can go for lunch outside. Thank you.
Good afternoon. I welcome you all to the post-lunch session. I request Dr. Firoza ma'am to please take her seat as the chair for the next session. And I invite Dr. Indranil Malik to please deliver his talk.
First one.
Last time डॉक्टर शर्मा ने कौन सा साल में करी थी? आपने भी तो एक alumni करी थी कौन सा साल में? 2013.
Sir, point.
Now, उस time I think Dr. Indranil was managing things. Yeah.
No, no. I had come, sir, but I graduated in 2005.
तो उससे पहले कुछ था जिसमें स्लाइडें खराब हो गई थी फिर ये भाग के सब
तो 2001 में कॉन्फ्रेंस की होगी।
कोविड में जो था 2001 वो तो बहुत पुरानी हो तो मे बी
2001 में तो कोविड थी ना यार भाई
नहीं यार नहीं यही भाषण हो रहे थे फिर नीचे डिपार्टमेंट में स्लाइडें किसी की
यार भाई तो
Shall we start? Okay. Welcome after the lunch, everyone. Indranil needs no introduction for everyone sitting over here. His topic is radiobiology of ultra-hypofractionated radiation therapy. Indranil, please.
Thank you, ma'am. Thank you to all my teachers, my seniors, my colleagues and juniors. It's an indescribable privilege to work here and to be standing here to talk. And no matter what we are outside, when we are here, we are students of PGI. So I will just introduce myself as the batch of 2005. I passed out in December 2005. When Dr. Kapoor called me about this topic, I felt like a resident again because this was a topic I really don't have much of an idea about. But I thought that like I used to learn as a resident, it would be a good opportunity for me to learn again. And I have to admit that I'm not an expert. I'm not a radiobiologist. And I'll put up some pictures. Please forgive me for the memes. So this is my Royal Enfield bullet. This photograph is about 18 years old. It's not an Enfield bullet, but at 2 minutes to 8, it would ride as fast as an Enfield bullet to reach the department on time. So one of the biggest lessons I learned here is that 8 o'clock means 8 o'clock. So I'm going to ask these questions from an oncologist's perspective. How do the 5 hours of radiotherapy apply to stereotactic treatment for the tumor and for the healthy tissues? Is the linear quadratic model sufficient to explain the effects of high doses per fraction? How does one use radiobiology for an individual patient's treatment plan? And are there other mechanisms at play at higher doses per fraction? Now let's start with the basics. The 5 hours of radiotherapy, of fractionated radiotherapy, which is very important because when we are dealing with ultra-hypofractionated radiotherapy, you're not delivering a very high number of fractions. So if we look at the biology of cancer treatment and how we model it, we are generally focused on the cancer cell and the DNA inside it. And the models of radiotherapy are focused on DNA damage. So we first start with the DNA itself. So what happens and how does ultra-hypofractionated radiotherapy differ from standard conventional radiotherapy? So if we look at the hours of radiotherapy, let's start with reoxygenation. When we are delivering a large number of fractions, we assume that in conventional fractionation, hypoxic tumors are likely to benefit from a gradual reduction in surviving clonogens in size so that the blood supply to the remaining cells increase, their hypoxia decreases, and they become more sensitive to radiotherapy. But in ultra-hypofractionated radiotherapy, when you're delivering 1 fraction or 2 fractions or 3 fractions, hypoxic cells may pose a problem because you may not be giving enough time for the hypoxic cells to become oxic again. And in clinical studies, it has been seen that the tumor size may be a surrogate for acute or chronic hypoxia. And many studies show that despite the same dose fractionation, Larger tumors have a higher chance of failure, which is basically showing that they possibly are hypoxic. And it has been shown that single fraction radiotherapy, if you want to circumvent the effect of hypoxia, you have to deliver higher doses per fraction. So beyond a certain dose, the hypoxia does not matter so much. But below a certain BED, it starts having an effect. So bigger tumors have worse outcomes than smaller tumors with the same dose. What about redistribution within the same cell cycle? Conventional fractionation allows the tumors to come back to the G2M phase, which is the most radiosensitive phase. But again, if you're using a single fraction radiotherapy, you can't expect that. So again, there could be a theoretical disadvantage of ultra-hyperfractionated radiotherapy. Unfortunately, there's no clinical study or analysis looking at this issue specifically. What about repopulation? We know that if you drag on radiotherapy for a while, there is accelerated repopulation. And in conventional fractionation, it's likely when the OTT is around 3 to 5 weeks more, and there's a term called the TK, which is the kickoff time, and that is important. In ultra-hyperfractionation, you're unlikely to have an OTT more than 4 weeks. TK is not that important to incorporate in your models. But if you look at the clinical outcomes, you will see that in some tumors, the OTT may remain a factor even in the shorter time interval period. And in large studies of lung SBRT, it was seen that OTTs as low as more than 11 days, when split into 2 groups, are associated with higher 2-year local failure, 14% versus 4%. And again, it was shown that this was probably dose dependent. And again, just like hypoxia, if you go beyond a certain dose, then the OTT may stop being important. Now, the fourth R is the repair of the sublethal damage in normal tissues. Now, in conventional fractionation, it is assumed that a component of sublethal damage to late responding tissues is repaired in the interfraction interval. If you're giving daily fractions, you're repairing the normal tissue damage. But in ultra-hyperfractionation with a higher dose per fraction, it is possible that you're causing more damage to normal tissues, and maybe 24 hours is not enough as an interfraction interval. Now, we don't have very good evidence for it, but from prostate studies, it is known that if you give daily treatments when we are giving SBRT or ultra-hyperfractionated radiotherapy for prostate cancer, clinical outcomes show that the late side effects, especially in the rectum, are a bit higher. So there is a possibility that the sublethal damage in normal tissue repair takes a bit longer when you're giving higher doses per fraction. But what about tumors? There could be sublethal damage repair in the tumors as well. Again, in conventional fractionation, we are assuming that there is the modeling of conventional fractionation is such that you're assuming that there is no intrafraction repair. Most common tumors repair sublethal damage by 24-hour interfraction interval. But in ultra-hyperfractionated radiotherapy, when you're prolonging the treatment time of one fraction beyond a certain time, there could be an intrafraction repair. So there's prolonged delivery of a single fraction likely to allow some intrafraction repair. And there are some old papers by Fowler and by other centers which show that a higher single fraction time may be associated with slightly worse outcomes. Now we come to the most important R over here, the fifth R, and whether the models of radiobiology really stand beyond a certain dose per fraction. So how do we model intrinsic radiosensitivity of tumor at high doses per fraction? Now, there is a school of thought which feels that the LQ model holds at any dose, but there are other schools of thought. And one school of thought feels that the LQ model overestimates the damage to the tumor beyond around 10 gray per fraction. Okay, so if you look at this sorry, I'll just use the Okay, yeah, I'm pressing the wrong button. So the LQ model is a continuously curved model, and it may overestimate the tumor kill, whereas this is the actual survival curve. So the calculated BED, if you see, it's calculating over here, but it's actually going there. So there's a BED overestimation in the LQ model, and this is one concept that some radiobiologists seem to prefer. So the real question is that does the LQ model hold? And we have two schools of thought. One, that the LQ model falls flat, and the other, that the LQ model keeps going strong. This is a party in my room, again, about 18, 19 years ago. So you can see some familiar faces who are in the audience. And there are several models that have been developed to try to explain the straightening of the curve in the higher dose per fraction. So the most commonly discussed model is the universal survival curve. There are other models which use the universal survival curve, use a different concept of cell killing or multi-target hypothesis. The Kavanagh-Newman model also does that. And there are certain derivatives or generalizations of the LQ model known as the LQL model and the Pade linear quadratic model, which are also used to try to explain the straightening of the curve later on. Now I'm going to spend a little bit of time discussing the concept of the universal survival curve. And this was proposed by Park and colleagues, basically from University of Texas Southwestern, where Dr. Timmerman also works. I'm sure all of you are aware of him. And what does this model do? Don't get worried about all the calculations. Basically, what it says is that after a certain dose per fraction, it's not the usual two-hit hypothesis, but it's a multi-target model. And it concentrates on determining what is known as the transition dose, a dose below which you assume that the LQ model holds, a dose beyond which you assume that it's a multi-target cell killing. And this DT is calculated with the use of the usual parameters. So you have the D0, which is the usual slope, the D1, which is the initial slope, the DQ, which is the threshold dose. And this is, and so below DT, below the threshold dose, you use the regular LQ model. Above the DT, you use a different formula, and you calculate the surviving fraction. Now, they found that this universal survival curve model had a better fit in the H460 cell line. I'll just go back one slide, and they use a single fraction equivalent dose. This is the last equation over there to calculate it, just so that you can compare different dose fractionations. So they had this universal survival curve model had a better fit with the H460 cell line, one of the most commonly used cell lines. And this is, you see that this is what the LQ predicts. This is what the USC predicts, and it matches more commonly with better with the observed doses. And they also, showed that if you use the single fraction equivalent dose, then they are slightly calculated at slightly less than the BED that is calculated with the LQ model. Now, what about other models? I'm not going to go into them in detail. This is not really a forum. I'm not a radiobiologist. But if you see one study from Karolinska Institute, which compared the different models in about, I think, 5 or 6 types of cell lines, they found that different models worked with different cell lines. The ones in bold are the ones which have the lowest chi-square value, which is kind of a descriptor of how well it's explaining the situation. And it shows that some of the models, for example, the universal survival curve and the PLQ model and the LQL model, are somewhat better than the other models over here. And the LQ model only works for 2 types of cell lines. Now, but these are all experimental cell line derived estimates. In defense of the LQ model, Brenner describe that, this straightening of the curve can be explained, or can the fitting of the observed model with the LQ model can be explained simply by looking at, and most of these studies have been done with lung SBRT, that if you assume that the alpha beta ratio of lung is higher than what we conventionally calculate, then the LQ model will fit just as well. Now, but the proof of the pudding is really in the eating. So what is the real world data show? What does the real world data show? And Mehta and colleagues assembled a multi-institutional database of lung cancer SBRT. These were nearly 2,700 patients treated in many centers with different dose fractionations, including 3D CRT and SBRT. And they had a certain summary value of BEDs, etc. And they found that if you look at the BED LQ, it actually does fit the observed data. So the real world data of outcomes, the BED model holds more or less quite well. And if you compare the BED versus the universal survival curve, the curves are slightly different. The solid line is the BED, the LQ BED. The dashed line is the USC BED, and they are slightly different, but they both fit the data, and there's no real advantage or disadvantage of one particular type of dose calculation. So the real world data actually shows that the explainability of the data, of survival data or tumor control probability data is no different from between the LQ model and the USC model, no matter what your dose per fraction is and your total BED is. So if we can summarize by saying that there are several types of models, but there's no clear advantage of one model over the other when it comes to real world data. Can we use radiobiological modeling at the individual level? For example, if I wanted to plan patient A versus patient B, how are we going to decide whether someone is suitable for SBRT or not? What is the optimal dose fractionation? Can we personalize the dose fractionation for these patients? Now, for that, we cannot use the LQ model, or we cannot use the LQ model just by itself, because the LQ model just tells you about a type of tumor, not about the volume and the proximity and the exact normal tissues close to it. So for that, we have to use the TCP and the NTCP modeling. I'm not going to go into that detail, but mainly we're concerned about normal tissue toxicity. So this is the NTCP modeling formula. And I just want to point out that they are, sorry. I just want to point out that they are looking at certain parameters, and one of the most important parameters is this parameter N, which tells us how parallel the normal tissue is. Okay, so if you've got a spinal cord or a brainstem, it's 0. And if you've got the lung, which is considered the most parallel organ, it is 1. Okay, so using this formula, you can determine how parallel a tissue is, and then you use the NTCP modeling for non-uniform doses, which is used with the EUD formula. So you basically use the differential DVH and you calculate the NTCP dose using these parameters. And if you use these parameters, you will see that this is one patient, one non-small cell lung cancer patient. This is one non-small cell lung cancer patient. And you will see that for isotoxic regimens, if you keep the NTCP the same, the TCP reduces drastically as the number of fractions reduce. Another non-small cell lung cancer patient, there is practically no difference, and even at 2 fractions or 3 fractions, the TCP is very high. Now, how does this happen? This happens because of the volumes of the TCP, the NTCP, and their proximity to each other, and the type of radiotherapy that you're using. If you're using, protons, if you're using conformal radiotherapy, the curve will be different. If you're using, less conformal radiotherapy, the curve will be different, and therefore the balance between the TCP and the NTCP will change. So you can use these formalisms to actually determine what kind of dose fractionation you use. And another group from Clatterbridge and actually from Marsden and Clatterbridge, Alan Nahum and colleagues, they devised the concept of the effective alpha beta of a normal tissue, which is based on the N value. So if the N value is close to 1, the effective alpha beta actually rises, and you can give a higher dose because the difference between the alpha beta is what makes a balance between whether you can give SBRT or you can't. So these are same patient treated with two different models, two different techniques. So if you see the 3D CRT, bigger fields, etc., you can't go beyond, reduce the number of fractions or give a very high dose per fraction. But if you use IMRT or proton therapy, you can give a higher dose per fraction. So coming to the next issue about, do we really need to move out of the DNA-centric approach and look at other cellular parameters? Is the DNA the only important thing when we are giving high doses per fraction? Or what about the blood vessels? What about the other cells, like the immune cells? So are they important? Now, this is SRS and SBRT, and these are all the mechanistic models, the LQ model and the PDL model and the USC model competing, standing at the top. But SRS-ST, Dil Mange more, so it's looking at vascular damage and it's looking at immune effects. Okay, it's not happy enough to be satisfied. It's not satisfied with only the mechanistic models. So first we come to the vascular endothelium. Okay, so we know that in tumors, the vascular endothelium is fragile. So these are electron microscopic pictures which show that this is the vascular endothelium in normal tissues, this is the vascular endothelium in tumors, and so these are fragile. And if you treat them with radiotherapy, they suffer damage. So there is a concept, there is a thing about radiation-induced vascular damage in tumors and the implication in ablative hyperfractionated radiotherapy. So it has been seen that when we give conventional fractionation, the functional vascularity in human tumors remains unchanged or improves slightly during the early period, but gradually diminishes during the latter part of treatment. Whereas in ultra-hyperfractionation, irradiation with doses higher than 10 gray causes more severe vascular damage, leading to indirect death of tumor cells. Now, colleagues from certain centers, they have modeled this approach, and they show that when we are giving very high doses per fraction, the vascular volume diminishes a few days after the first dose compared to lower doses per fraction. And the extravasation of plasma proteins has a spike on the first or second day after treatment, correlating with vascular damage. And they also say that if the vascular endothelium is, the ends of the vascular endothelium into the tissues, if you damage the ends of this endothelium, then the cells around this area will die. The tumor cells around this area will die, which is one of the mechanisms of action. And biologically, they feel that the high doses of radiation could basically be generating ceramide, and which generates acid sphingomyelin mediated generation of ceramide, which causes apoptosis of the vascular endothelial cells. But does vascular damage play a role in real life? Actually, in vitro data is interesting, but it is not conflicting. It is not, there have not been a lot of validation of some of these studies. One study demonstrated that the increased radiosensitivity of the tumor cells played a much greater role than the radiosensitivity of the endothelial cells. And there exists much controversy in the literature about the existence of indirect cell death and how much it really contributes to the outcomes. Now we come to the immune effects of radiotherapy. Now in a cancer cell, there are mechanisms to evade immune damage. We all know that. But radiation has some effects that may promote immune damage theoretically. We know that the DNA and RNA of damaged cells come out into the cytosol and cause interferon release. We know that the tumor-associated antigens get released. We know that there's things called the DAMPs, or the damage-associated molecular patterns, which act via receptors. And there's a translocation of calreticulin, which promotes receptor-mediated phagocytosis. So these are the molecular mechanisms behind radiation-induced immune changes. And taking advantage of that by irradiating the immune cells, and I'm sure Vijay will talk about it, there is an upregulation of several mechanisms, VCAM1 and ICAM1. There's chemokines get released, translocation of calreticulin increase the sensitivity to the cytotoxic effects of the T lymphocytes. And we can use several drugs to check whether this actually has an effect or not. And does fraction size play an effect? Yes, it seems theoretically that higher doses per fraction can cause greater release of these proteins and potentially improve the outcomes. And there have been some small studies of dose fractionation and immune response, and they seem to be showing some positive response. I won't go into the details. And there are several studies going on. Vijay, I'm sure, will talk about it. But we are yet to see very concrete clinical evidence of benefits of radiation and immunotherapy in many cancers. And we know that the Javelin study and the Calais study are negative. These are conventional fractionation treatments. So we are awaiting a study which shows to check whether very high dose per fraction and immune therapy actually have an effect. So I'll summarize by saying that the classical 4 Rs of fractionated radiotherapy suggest that there could be advantages and disadvantages of ultra hypofractionation. There are different schools of thought on radiobiological modeling and the validity of the LQ model at dose per fraction more than 10 gray, but in vivo data does not show clinically meaningful differences. An individual level biological optimization for isotoxic treatments can be tried within a TCP-NTCP framework, but again, this has to be validated with clinical evidence, whether we can personalize dose fractionation or not. And vascular endothelial damage and immune activation are other potential cellular level effects, but again, needs to be validated with clinical outcomes. Thank you very much. So this is what I am looking at Dr. Sharma and Dr. Patel and wondering what they feel, and I'm happy that I've already graduated. So.
That we didn't keep you back. Thank you, Indranil. I'm sure for the students and for all of us, this has been a very new sort of topic. And Indranil has tried to make it as simple as possible for us. If there are any comments that anybody would, Teji, would you like to say something? Since you in your lecture also were referring to some of these points.
So I'd just like to add on, not a comment, but just to add on.
Okay, Mike, can you have the mic?
You touched about the vascular damage and the cellular and the DNA.
One sec, Teji, one sec, just take the mic. They're bringing it.
Thank you, ma'am. Indranil, it's not a comment, but just an add-on, because you've very lucidly taken us through what is the radiobiology of ultra-hyperfractionation. You've touched upon the intracellular and the organelle level, because the downstream signaling starts inside the cytosol, right? The MAP kinases, the tyrosine kinases, right, they all kick in, right? And that's where the other, like whatever the tyrosine kinase inhibitors are doing, radiation does. And radiation does it in a global way. And this is a very good article published in 2002, Seminars in Radiation Oncology. I'll share it with you. You can go through it. And it's very beautifully shown as to what all receptors get engaged when such high doses of radiation are given. So that is one part. Second is, besides the vascular damage, in the vascular damage, 2 things are occurring. One is the endothelium is not as robust as a normal tissue. Also, after the radiation, with such high doses, there is proliferation, which occurs at the cellular level, and there are clot formations. So there is thrombosis, which further impedes the blood flow, right? Like you have a thrombus which goes into and causes a stroke or a heart attack or something like that. So similarly, in the tumor, there is a tumor machinery shutdown. The third thing is the stroma. So intermitotic death occurs within the cell and in the stroma, because the stroma is not dividing. It's supporting the tumor, but it's not dividing. So there is intermitotic death. So that is the third mechanism which comes into it. So all these 3 factors then work for creating the results that we see of SBRT. So we have a long way to go and then clinically validate these.
Yes.
And then maybe
yes.
build them into our 4 hours go to 5 hours, or maybe ABCs also. I don't know, because I'm not a radiobiologist. So we have to work on the molecular biology side and then bring it here. So what we are talking or understanding is empirical. LQ model was also derived, TDF, CRE, everything what we studied was all empirical mathematical modeling. But now we have the data coming from the lab. So that needs to be collated.
Thank you very much, Dr.
Thank you.
Thank you.
Anybody else wants to make a comment? Vijay, you're sitting there. Do you want to make a comment or wait for your lecture? Okay. Yes, please.
We all know that bigger tumor needs higher dose. But in SBRT, it is often not possible to deliver. So you do SBRT, I hope?
Yes, sir.
So what do you do? Means we have to make a compromise. We tend to give higher dose to smaller tumors because it is achievable. But bigger tumors needs more dose, and oftentimes we are unable to achieve. So we fractionate and all that. So what is the impact of which formula should we use when, BD when, LQ model when? Because that is a question comes daily.
Yes, I think this is an important question. In clinical practice, there is no guidance on using a different formula for larger tumors. But what all of this, learning for the seminar has taught me is that instead of saying that only for this size, you basically have to use what I would call a biological optimization and try to bring in, a more calculate the TCP, NTCP, see what your regular TCP, NTCP is, and see whether you can use that to generate a dose fractionation. But that is not, again, clinically validated. So what I meant was that we have to do studies where for high doses per fraction, we have to see that for an individual cancer. So even if you have a big tumor inside the lung, you could potentially give a higher dose inside it if the tumor is located in such a way that your normal tissue doses are, within a certain range. So if you are exceeding normal tissue doses, then of course you can't do anything. You have to fractionate. There are studies which will look at how to combine SBRT with some types of systemic therapy or immunotherapy, and that may actually provide some other guidance, or maybe some new adjuvant immunotherapy, etc. will come in, and these are things in process.
Teji, you want to make a point?
So to again add on to what Indranil just now said, in the lung, we have seen that the studies have shown there are dose-limiting toxicities beyond 12 gray. Although all of us have practiced, and we continue to practice 15 gray and 20 gray also for smaller tumors, albeit. But for the liver, there's a very good study for dose-response curve for SBRT of the liver tumors. And it's been shown that when we go beyond 48 or 50 gray in 5 fractions, then the gains are not much. So your tumor control probability falls. So just increasing the dose per se may not be the answer. So we may have to add on.
Even in lung cancer, there's a plateauing of dose. If you see the curve.
No, there is a plateauing, but what I am alluding to is that there is a dose response curve which we need to take on the SBRT only and then bring it out. So this is modeling.
Yeah, so it shows that if you don't need to go beyond 53 gray or 54 gray in 3 fractions in lung cancer according to the models. So BD is 156 if I'm not. So 159. TCP 90 is achieved with a BD of 159. You don't need to go beyond 159. If it doesn't really accrue into much higher benefits, you're just causing more normal tissue damage.
Okay.
Ma'am, so far I know there is one device reduction method is there. That is the model of the Ghoshal model is there. So that can be used for the change in the dose with respect to the size of the tumors. Device reduction method is there. Ghoshal model.
For the NTCP, the Lima-Ghoshal model is for the NTCP calculation. And the TCP calculation is the Marsden model. The most common model is the Marsden TCP model. So they basically, we are trying to do isotoxic treatment. So we calculate the NTCP and see that to keep the NTCP the same, how much dose can we give to the treatment. So isotoxic treatment regimens have to be tried in clinical trials. So every patient will get a different fractionation schedule based on the same NTCP.
Okay. Thank you. Thank you. I think we should now go on to the next topic. So I will request the organizers to take over, please. Thank you, Indrani, once again.
Thank you, ma'am. Thank you, sir. I now request Dr. Jayan Sastry to please take his seat for the next chair. And I invite Dr. Vijay Patil to deliver his talk. Thank you.
Thank you very much. It's a great privilege to be here again to my alma mater. So, continuing from what Indranil has talked about, I think Vijay is going to take it forward. He's going to talk about immune therapy and radiation. Is the marriage made in heaven? So you're going to prove whether the marriage is made in heaven or not. So the onus is on you, Vijay.
Okay. Thank you. Nowadays, very hardly times I get this feeling that my palms start sweating or I start getting palpitations. It has been a decade since I got these feelings, but suddenly I have started having it. So thank you for the invitation. What I'm going to talk today is about how the local milieu of the tumor, which is the soil, impacts the cancer treatment. Up till now, the whole focus was on the seed, that is the cancer cell. We must understand that both the seed and the soil are important. The soil is as important as is the seed. We have many times seen that we operate sarcomas, but after that the dissemination happens. It happens via blood, but somehow the homing capacity of the cells is such that they come and get deposited on the scar tissue itself. So there is much more than looking only at the cell, but we need to look at the soil also. When we talk about immunotherapy and radiotherapy, both these branches are pretty ancient and both have their own strengths. Immunotherapy actually didn't pick up so much. Initial Cooley's experiments and BCG cytokines hardly did anything. And the whole discussion why we are having is because now we have checkpoint inhibitors and which have started giving good controls in at least 15 to 20% of the patients. It must be noted that we don't get controls in all patients. Somehow immunotherapy works in around 1/3 to 1/4 of the patients, but these controls are sustained for a long time. And how does, if you want to say that you want to combine radiation and immunotherapy, how would this combination happen? This combination would happen in the same way as would for any systemic therapy. It could be a spatial cooperation, a temporal modulation, a biological cooperation, a cytotoxics enhancement, and it would also help you to give normal tissue protection. But the issue is immunotherapy today dominates the number of trials which are done worldwide. Look at this bar diagram, a pie chart, which shows you the phase 3 intervention clinical trials which are going on. You would see most of immunotherapy dominates around 1/5 of the trial across all branches. Around 3 to 4% of them are with radiotherapy. Unfortunately, what Dr. Indranil said is perfectly correct. Up till now, we have not been able to get the results in concurrent setting of combination of immunotherapy with radiation. The major trials have been negative. I work at Tata and I mainly focus on head and neck cancer and CNS, and that is my area of expertise and domain, and I would be restricting my talk towards these two areas only. And we would try to understand how this combination can help us in the concurrent setting, in the curative setting, and the palliative setting. And I would start with the palliative setting. Keynote 048, this was a study presented by Barbara Brutness in which patients who had recurrent or metastatic head and neck cancers got randomized to pembrolizumab monotherapy, pembrolizumab with chemotherapy, or the extreme regimen of the cetuximab. The whole trial was to see whether addition of pembrolizumab leads to a survival advantage or not. It's a very complicated trial. And I'm showing you a part of the results which were for CPS 20. And for the students, what is CPS 20? We look at the PDL1 expression. We look at the PDL expression on the tumor, that is called as TPS. We also look at the PDL1 expression on the local milieu around the tumor. The combination of this expression on the milieu and the TPS makes what is called as CPS. So if you get a TPS score of 50, the CPS is at least going to be 50 or more, because CPS is an addition of TPS plus what is the expression in the local milieu. Things get complicated here because every antibody which has come of immunotherapy has come with their own IHC expression, like DACO kit. There have been Ventana kits. The kits are different for every expression, and intercorrelation between them is not that well studied up till now. So most of the time you would say that pembrolizumab with 22C3 DACO kit. So this kind of things make more treatment difficult. What is important here is that for the first time in recurrent and metastatic head and neck cancers, you saw that the median survival went up around 15 months. It's not important of what is at 15 months. What is important is this tail, which goes for around 20 to 30% of patients going beyond 24 months. If what we have seen in lung cancer and melanoma is true, what we have seen in lung cancer is that patients who do not fail till 2 years, they sustain that till 5 years. Same way in melanoma, those who don't fail in 2 to 3 years, they sustain till 8 to 10 years. If that is true, we are surely in an exciting time to go ahead. This is just to put a perspective. This is our own study from TMH called OCAT, in which locally advanced head and neck cancers were randomized to either RT, a 6-day RT or CTRT. I've just put you to show that locally advanced oral cancers T4 and T4N+, their median survival also is 18 months. So there is much scope of improvement even in this situation. And what I wanted to show is that in a recurrent metastatic setting, when you get similar type of outcomes with an immunotherapy drugs, these are something which you don't discount for. Issue is most of us don't use cisplatin 5 backbone, which was used in Keynote 048. At Tata, we use paclitaxel carboplatin backbone along with pembrolizumab. This is a study that just got published and would come in the April issue of Oral Oncology. We have published our experience of pembrolizumab with paclitaxel and carboplatin. Now, why am I showing you these studies? The reason why I'm showing you this study is that something which came up in lung cancer a few years back. Oligometastatic lung cancers, or lung cancers which did very well after systemic therapy, when we were given local therapy, they had much improvement in outcomes. I'm hoping that in future, if immunotherapy gives us such kind of improvement in outcomes, of long-term outcomes, we would definitely need to explore these options of whether we could add local therapy and get much more improvement in outcomes. Do we do that today? At my center, yes. When we plan patients of recurrent metastatic setting, and if we see that 6 or 7 months down the line, they're doing well, we actually take it to our MDT and request our surgical colleagues if they can do surgery, or our radiation colleagues if they can give radical RT in such situation. I actually would be showing one of such cases. The problem is, this does not solve the problem of my country. Cetuximab, with the cost it costs, can be afforded by less than 1% of my patients. Immunotherapy, this is a 15,000 plot analysis, and my student Ravi will be presenting this as ASCO this year. You could see these numbers. The percentage of patients who could afford immunotherapy, this is less than 10%. And mind you, Tata, 40% of the patients, or merely 50% of registration, are private patients. This is in spite of having this mix that this is. So we may be gung-ho about that immunotherapy may change things. We may be gung-ho about that targeted therapy may change things. The fact of the matter remains that these therapies are going to be inaccessible, and these are going to be inaccessible for a long period of time. And then what do we do? What do we offer these patients? This is a analysis which I did in TMH, in which I actually asked the patient, made a pro forma, validated it, what are the expectations and preferences of head and neck cancers patients. Surprisingly, in spite of knowing their outcome, 75% of the patients wanted an improvement in survival. Issue is they don't want to spend time at hospital. Most of the head and neck cancers, unfortunately, which I see, are laborers. They cannot even afford to lose their daily wage and come daily for 3 weekly regimen to the hospital. Then what do you do? At this time, my mentor, Professor Banauli, used to run a clinic, and this was in interiors of Maharashtra, in the district of Derwan, where he used to give them methotrexate and celecoxib in low doses. The results there were too good. And I used to get, after I went from PG, I got posted there for some time, I saw the results were good. Problem was, the results were good, but this was not published anywhere. So I did the first data collection as a group. We did this was published in Clinical Oncology. We saw that with this 2 drugs, which are oral, which are given with many less dose, the cost used to be less than 500 rupees per month. The patients can do much better. As a part of my DM thesis, I took up this challenge to see that whether this regimen could benefit our patients against intravenous regimen. And the results were exciting. I presented these results at 2014 ASCO. Metronomic not only has less side effects, was more cost effective, it actually led to improvement in PFS and OS over intravenous cisplatin. So this was an important result which didn't stop here. We went ahead and did a 450 patient randomized study to see whether metronomic chemotherapy against intravenous cisplatin, whether it could lead to an improvement in outcomes. We presented these results at ASCO, and subsequently this got published in Lancet. For the first time in 3 decades, after cetuximab and Keynote 048, this is the only regimen which has shown that we can improve outcomes with an improvement in quality of life, less side effects. The point I'm making is, many times the solutions are there, and we need to be observant about solutions. Running behind molecules which are costly, running behind molecules which are just coming new may not be the solution for a country like us, and we need to be much more innovative with this. The problem was, we did this work with metronomic, which is that I've just explained how metronomic works for the sake of resident. I just assume that most of the people know how metronomic works. Metronomic term was coined by a person called Mr. Hannon, and the reason why this was coined because it seems to the metronome of music. There is very low frequency music which is going on. When you give chemotherapy at these low doses, it actually targets the endothelial cell of the vessel which supplies the tumor. Now, the endothelial cell of the vessel is genotypically a safe population, in the sense it does not undergo mutations at the same rate at what the tumor undergoes. And if you cut off the blood supply, the tumor needs to shrink or gets killed completely. The issue was, how do you find that a drug would have a metronomic action? You have so many drugs. How do you know that this metronomic action? So this was challenge number 1. Second challenge was, how do you know that what is the dose when you give, you would get this metronomic kind of action? At that time, I was in Malabar Cancer Center, and I was with this very intelligent statistician, Dr. Atanu Bhattacharya ji, and he helped me to develop the first algorithm to define a dose of a drug which will identify the metronomic dose. We did a phase 1, phase 2 study, which subsequently got published in JCO, and in which we optimized the dose of methotrexate, brought it down from 15 milligram per meter square to 9 milligram per meter square. How exactly we did it? So this is just for explanation. This is where is your maximum tolerable dose. That's the routine dose. When the dose decreases, there is this called anti-androgenic window where you would start getting the metronomic dose, which would wave off after that. You are interested in knowing what is called OBD, that is optimal biological dose, which will give you the maximum metronomic action of the drug. Now, how do you know that? Circulating endothelial cells are very good markers. If your circulating endothelial cells in the blood are decreasing, which means your metronomic action is good. So we made a model, this complicated model, which looked at now also response and the decrease in circulating endothelial cells. On the basis of this, we optimized the dose of methotrexate. What we got, this is platinum refractory head and neck cancer. Immunotherapy gives a response rate of 13%, and for which we asked the patient to take this. We got a response rate of around 45% in the study, with good outcomes along with that. So much so that this got incorporated into the UpToDate. And in fact, Dr. Posner had sent me an email that he would be incorporating this therapy in UpToDate because it's an important game. Just to give a visual impression, this patient was treated with triple metronomic, and you could see how good it responds. Important thing, the patient doesn't get much side effect. The doses are less. It is very easy for the patient to take. He can take it orally at home. He doesn't have to spend much bucks for this kind of treatment. Now, the problem was, immunotherapy sustains those 15 to 20%. My metronomic couldn't sustain. 5 or 6 months and the disease is to come back. The challenge for me after that was how to make this metronomic regimen more sustainable. How could I give that long-term benefit to the patients? I did quite a bit of literature search, and I worked with Dr. Gota, who is a pharmacologist, and we did the pharmacokinetic modeling of nivolumab. What we also saw was the receptor saturation of nivolumab. For the nivolumab to work, it inhibits the T cell. For the T cell to be inhibited, 70% of the receptors need to be occupied by the nivolumab. The good thing is 70% of the occupancy actually happens at a dose of 0.1 to 0.3 milligram per kg. You don't have to go to the dose of 3 milligram per kg, which the company recommends. thus giving a theoretical possibility that this drug may be active at a lower doses. And we actually started giving lower doses in patients who couldn't afford EA. And we presented this in ESMO 2020, where we saw that yes, in refractory setting, around 15% of patients, which would be the case with the normal dose, would start benefiting with the low dose. And then actually looked at what is the profile of head and neck cancers with respect to PD-L1 expression. This is mainly data of 500 patients of oral cancers. What we saw at Tata data set is a overwhelming large amount of our patients have PD-L1 expression. I don't know whether it has to do with the tobacco habit or something of that sort, but thankfully our patients express more amount of PD-L1 than that has been reported in the Western population. And hence, we did this study, and this will be presented at ASCO this year. And this is a randomized study of metronomic versus metronomic plus low-dose immunotherapy. The study had to be stopped after the phase 2. I couldn't disclose anything further. The rest will be presented in ASCO this year about whether we can have a new standard of care in this setting. So the study had to be stopped after 151 patients itself. So an original sample was around 200, but the nominal p-value was met at that. Yeah, it was a planned interim analysis, which was to be done after 75 events of death had to be happen. What does it would do? This is the cost of 1 year of keynote regimen cost. This is 61 lakhs. This is the cost of extreme 1 year, that is 35 lakhs. If this treatment becomes successful, 3,30,000 with the cost of 1 year of treatment. That would be the cost which would be brought down by development of this. This is one of the cases which has been treated with low doses of immunotherapy. You could see that you had a very fungating tumor. Patient responded beautifully to low doses. His TPS score was 80 to 90%. Actually took to MDT. Patient has got operated, after that received radiation, and has been doing well since last 18 months. Are we stopping there? No, we don't stop there. At Tata, we don't stop. We continue on improving on the results. This is a study called Phoenix, in which we are going to see whether we can combine maximum tolerated doses of chemotherapy with metronomic dosing as a next step to our next protocol. Problem is, up till now, whatever research we did was unicentric. And my senior resident, Dr. Shabab, always told to me that, which it would be our generation which would be starting multicentric studies in India. With that idea, we made a group of TMH alumni and started a Cancer Research Statistics Foundation. One of my friends leads the foundation. And I'm happy to say that this is a phase 3 study which is running across India, in which physician treatment choice has been compared against triple metronomic chemotherapy. It's already recruiting at 22 centers, and we have finished half of the recruitment. We feel that by next year ASCO, we would have the results of this study. Understand that other branches are equally important. You need to have palliative care. This was a phase 3 study which we did at Tata Hospital, in which we show that addition of early palliative care to palliative chemotherapy helps to the patients. We are not going to psychologist. We are not going to get that many patients. It's our job to speak to the patient. It's our job to see that the distress of the patient comes down. This is another approach which we showed in Tata, that if the patient has a high distress, if the physician removes time and talks with the patient for 10 to 15 minutes, it brings down the stress of the patient in most of the setting. Let's change the tone to concurrent setting. And this is what Dr. Indranil alluded to. Thank God this came negative. I was very happy when this negative. If it didn't come negative, multiple studies of Tata, the standard arm won't have remained the standard arm. So this was a locally advanced head and neck cancer study in which you would have patients of cisplatin receiving cisplatin versus cisplatin plus avelumab with maintenance of avelumab. What this study shows is, and this is my comment for the study, is that it actually shows it's double negative. It was not only that it failed to improve the outcomes, the outcomes were slightly inferior than what was seen with the placebo. And that's important. These drugs we have not complete. See, the development of immunotherapy has been very fast. This is one branch where we are getting clinical results first, and then we are following with biological rationally. And hence, we actually don't know completely how these drugs are going to act. And so it's important that we take steps which are baby steps, and we take it on the basis of evidence rather than saying, if it works in metastatic, it's going to work in concurrent. I don't think that is the policy which you need to follow. Another study called GOTEC REACH, which again tried using avelumab, was failed in both arms. Interestingly, this study also talked about cisplatin unfit patients. Normally, we don't talk much about cisplatin unfit patients, and if you see in the OPD in the concurrent setting, around 3 out of 10 patients are cisplatin unfit. Then what do you give them? Wait for this ASCO. We would be giving you this example. A 350 randomized study has just got this accrual was finished way back. The number of events were made. This analysis has been submitted to ASCO for this year. Radiation versus radiation plus docetaxel. Maybe docetaxel may give you an answer in this setting. What about cisplatin fit patients? We did a study of addition of nimotuzumab in this setting. Improved the PFS, improved the local lesion control, did not improve the overall survival. This year in the ASMO, we will be presenting the long-term overall survival data for these patients. But in one subset of patients, it also improved overall survival. That was HPV negative oropharyngeal cancers. In this subset, you see the addition of nimotuzumab not only improved PFS, but also improved overall survival. This was published in Oncotargets. The study was actually killed by one of our own studies. We had used a dose of 30 milligram per meter square, and most of the head and neck would say that that's a low dose. And we only killed it with a publication 1 year before, in which Dr. Narona, my senior colleague, did show that in adjuvant setting, a dose of 30 is inferior. Local regional controls are much better with a dose of 100. We now have a data from Japan, which says that 40 may be as good as 100, so that 10 mg dose would have been difficult. But we all know that giving 100 milligram per meter square of cisplatin is difficult. Cisplatin leads to late long-term side effects, more of metabolic syndromes, and quite a few patients do lose their life to these metabolic syndromes. In the RTOG 911, 30% of deaths were unknown, and we don't know why this did happen. Maybe aspiration, maybe metabolic syndromes. And hence, this concept of this study called CVD, cisplatin versus docetaxel, believe that docetaxel may not have those amount of long-term side effects, and a head-to-head comparison is going on. 1/4 of the recruitment of the study is over. Let's talk about maintenance. We did the work of metronomic in palliative. Obviously, it was of interest whether we could give this in the upfront curative setting. There were 4 studies which are going on in Tata. And the first study is an interesting study. Patients of recurrent head and neck cancer who undergo salvage surgery, but they're not eligible for irradiation. We all know that patients who undergo salvage surgery, we would give irradiation. But what if they're not eligible for irradiation? We know that the recurrences are high in this situation. The design was very simple, whether you keep them on observation or you keep them oral metronomic chemotherapy. Unfortunately, oral metronomic chemotherapy is also not a panacea. This was a double negative results. Patients who received metronomic chemotherapy actually did worse than patients who were on observation. Again, saying that even if the drugs have less amount of side effects when you're giving in curative setting, it's better that we have that evidence and then only give it. MACE CTRT, patients who have undergone radical CTRT, who are in CR, we randomized them to OMCT plus observation, a 1,000-patient study. This will be presented at ASCO 2022 by my junior colleague, Dr. Ajay Singh. This study of patients who undergone surgery is ongoing. This is a famous study of Dr. Pai, my senior colleague from Tata is leading this study. The recruitment is finished, and we say that by next year we would have these results, whether oral metronomic chemotherapy can be given as a neoadjuvant till the surgery happens, and then a maintenance for 18 months. This is something which Dr. Andrani alluded to, that is giving neoadjuvant immunotherapy to the patients. Now, it's important that we understand what are our outcomes at this stage. If we look at Dr. De Cruz's paper on N0 study, that if you look at the survival at 48 months, this is around 80% and this is around 70%, which means that T1, T2, N0 patients also will lose within 5 years, and it's 20% patients will lose. If you look at locally advanced oral cancers, you see that by the end of 10 years, only less than 25% are alive, and early stage, less than 40% are alive. Which means, though we are happy that early stage and locally advanced oral cancers do well, we need to do more if we want these patients to live. And how would we do more? One of the answers was given by a person called Ravi Upalluri, in which he gave neoadjuvant immunotherapy to these patients. Two studies he had done. Cohort 1 was a study which he presented in ASCO of 2017, in which a single dose of pembrolizumab was given. Cohort 2 was a study in which he had given 2 doses of pembrolizumab. Let's have a look what he did. It's a small study, but it gives you an insight into future, what we may be able to achieve with giving neoadjuvant immunotherapy in this situation. The PTR2, that is a pathological response rates, which is called a major response rates, was seen in 42.9% when the patient had received 2 doses of pembrolizumab. The important thing is, this were the survival curves in that study. You could see that there was no drop which we saw in the early stage in the N0 study. What does this mean? That maybe in future we may have studies of immunotherapy in neoadjuvant setting which may bring down the necessity of surgery. It may well collaborate with the radiation and surgery to improve the outcomes in this patient, but that's for the future. Published our neoadjuvant data in which, like we do laryngeal preservation, we did mandibular preservation. Nearly 50% of the mandibles in this randomized study could be preserved, and we waited for the long-term data to come for 5 years before venturing into publishing this data. We had a tough time while we were publishing this data because every reviewer was on to us asking us why not immunotherapy in this situation. And I think that in the future, with the development of immunotherapy, TPF-like regimen, which are 3-drug regimen, are too difficult to be given. We may have more options of doing such things. And by the way, when I talk about TPF, we do give TPF in borderline resectable cancers, which are like such. We have developed the criteria for that. And stay tuned for this ASCO. You might just be seeing the first phase 3 study in borderline resectable cancers in which DCF has been compared to DC. It's a 496 patient study recruited 2 years back. The number of events are done, and we would going ahead with the study. We have proposed a study in which we are trying to do low dose immunotherapy in neoadjuvant setting. Unfortunately, our IC 3 years back was not convinced that's an important topic and rejected the project. Thankfully, now they itself have asked for the project to be revived, seeing that this might be an important option. Jalali sir is here. I can't go without talking on glioma. So this was a study. Could it be that nivolumab or immunotherapy make it in recurrent glioblastoma? Unfortunately, no. The results were negative. Could they do it in concurrent setting, that is along with radiation? Unfortunately, again, the results were negative both in MGMT and MGMT non-methylated situation. For glioma, hence immunotherapy still remains an enigma how we are going to use it. And I just introduced you to this study called Delhi. This is development of low-dose immunotherapy in India. This is a 1,000-patient randomized study, recruited around 300 patients, which is looking at development of low dose of immunotherapy versus physician choice therapy in any kind of solid tumors. Dr. Badwe is the PI of the study and is leading this study. But there is one situation in which neoadjuvant immunotherapy has shown to be of maybe useful and maybe what we are looking in the future. And this situation is neoadjuvant situation. Giving neoadjuvant pembrolizumab did help the patients. And why would this be? The reason is when you operate the patient, there is no local milieu for the drug to act. And that is one of the reasons which has been given, that when the tumor is in situ, the local milieu is there, and probably that's why immunotherapy works better. But again, even if they develop, this won't be of any helpful. I need to thank Jalali sir for this. We repurposed mebendazole, and I won't take much time. We did a phase 1 of mebendazole. This got published in Cancer Medicine, and we are going to present the results of mebendazole phase 2 study at this ASCO 2022. The paper has got accepted in one of the Lancet group of journals and would be out in public domain in the 2 months. We all give bevacizumab in glioma. The question is, can the bevacizumab needs to be given at full dose, or you can give it a dose of 1 milligram per kg? These are retrospective data from Tata itself, which shows that low dose can be of help. Whether you use generic or biosimilar, it doesn't matter. And we have this study called VAMNA, which is a phase 2 single arm study. We have just been happy that Dr. Badwe has given us the bevacizumab required for this study. And the first 2 patients got recruited last week, in which we are trying to develop low dose bevacizumab with this. Lot of time I told you ASCO, this is just the list of the phase 3 studies and phase 2 studies, which all will be presented from medical oncology, our group at this year's ASCO. Please stay tuned for them because some of them will be treatment defining. So to conclude, IO is going to be the nexus platinum, but which IO, at what indication, and where is something which we need to wait and see. IO plus RT combination are definitely going to come. How we are going to use them in curative setting will be defined. But the interesting thing for me that they might come up even in the palliative setting with the long-term controls which have been seen with them. IO are going to be inaccessible and are going to be financially difficult for us. We need to decide how we are going to develop our alternatives for immunotherapies which need to be used. We need to develop altered schedules, and there is no rocket science to tell that, or else we will be falling way behind in this race against cancer. Metronomic and repurposing of drugs are important. They also target the local milieu, and these drugs are far cheaper. Can we imagine that if we develop a repurposing drug, there is no inheritance, no hindrance to use it tomorrow. It can be used in clinic from tomorrow itself, and it's important to develop this drug. I need to thank a lot of funding agencies. Quite a few people have given me fundings. All these funding agencies for the work which I've shown. I need to thank Dr. Kumar Prabhash, who's my head of the department, my senior colleagues, all the residents, the coordinators who worked with me. I need to thank Jalali sir and the whole Neuro DMG for the support. It's in very few institutes you would see that a person comes and starts medical oncology, and within a span of 4 or 5 years, he would have developed things in, and that's all thanks to Jalali sir, the support he gave me, and my junior consultant, Dr. Nandini. I need to thank my lab partners, also my statistician, and over and above. I need to thank my teachers, both from GS Medical College, sir, madam, Sushmita ma'am, Kapoor sir, for giving that confidence. And remember when I came in PGI, I was just telling to Dr. Shabab, I used to turn myself that way and give my talks. And from there to come and give here a talk, I've come a long way. I need to thank many of my teachers for TMC. I need to thank Dr. Shantam. He was the person who impressed me to join radiation oncology and was with me for most of the part of my oncological journey. Thank you. I hope it would have been some use.
Thank you, Vijay, for that talk which you gave. You moved away from immunotherapy, and I'm happy about it. Vijay is one of the few radiation oncologists who switched over to medical oncology, but he still has the brains of a radiation oncologist, I have to tell you that. And it's because many of the medical oncologists, the present-day contemporary medical oncologists, would give immunotherapy at the drop of the hat because they have the belief in it. But really, there are lots of challenges to giving this immunotherapy. And the way Vijay has presented, moved away from immunotherapy to OMCT, just tells the confidence in what he has in conventional chemotherapeutic regimens rather than just dwelling on immunotherapy. Thank you very much, Vijay, on that. However, one question, it has to be with radiation, okay? The title was with radiation. So what challenges do you think you might face while giving immunotherapy along with that of radiation?
So I'll take that question with respect to the different sites will come up with different challenges in this. First of all, that when you combine immunotherapy and would you combine with the chemotherapy agents and with radiation, let's take that you do it in lung, you are going to have trouble with pneumonitis. When you do it in head and neck cancers, you are going to have troubles with hypothyroidism, thyroiditis. The problem is, Jayant, we assume that radiation and systemic therapy do not cause immune suppression. There's good data that even radiation when given leads to a decrease in lymphocyte count. So I fail to understand that if the lymphocyte count are going to go down, we are going to give an enhancer, how is going to act? So it doesn't come as a surprise to me that immunotherapy studies in neoadjuvant setting are showing promise. In adjuvant also in some setting are showing promise. They're not shown that promise in concurrent per se. We have development of durvalumab, which is post CTRT in lung cancer, but that is post.
That's the Pacific trial.
Yeah, Pacific trial. Yeah. But we don't have in concurrent setting.
Yeah, so in the Pacific trial also they mentioned about the timing of giving that immunotherapy.
Yes.
They showed that if you give it within 14 days of completion of chemoradiation, the survival is much better than that.
So I won't agree with that, Jayant. I have given a lot of durvalumab. A patient of lung cancer who has completed a CTRT to start a systemic therapy agent within 14 days is difficult. In fact, specific, if you see the whole paper, they themselves amended the protocol to include patients for another four weeks. It's very difficult. A patient who has just finished cis-eto with RT or paclitaxel with RT, that within 15 days you start them on another regimen. Very few people tolerate. In fact, I would make one more Comment on specific. If you see the subgroup analysis of specific, and that's what NICE has also done, the benefit is largely restricted to patients with a PDL1 score of 1 or more. For patients who had a PDL1 score of 1 or less, that the benefit was not much. And that's why the NICE, the way NICE has put it, NICE recommends it only for the patients with a PDL1 score of 1 or more.
Dr. Jalali has got one question to ask you. In fact, congratulations for so many studies which you have done.
It feels
I'm really happy about
with
it.
a lot of pride that you have presented so much. Well, the combination, we discussed so many times. Jyoti and I worked on it. We published that paper also in BMC. The lymphopenia is a very important topic for us, radiation therapy, because I think Dr. Anand, I think 5-6 years ago when you gave a talk on SBRT, you presented the data on the lymphopenia. I remember very well in the 2016 TMC conference. But now there are a number of trials, and one trial got published. I'm talking from the particle beam therapy again because of that. So there is an increasing mounting evidence, and 3 or 4 sites I can tell you. Esophagus, already JCO paper from MD Anderson shows signals of improved survival. And because the proton beam therapy can reduce the doses of circulating lymphocytes because the normal tissue is less, so the lymphopenia will be lesser and independently can act as an immunomodulator. The question is then, how do you combine with the combinatorial approach? And that is the challenge. The second site is glioma, actually. The BN001 study is examining at the moment in glioblastomas, looking at, there's beautiful data from Hopkins, that lymphocytes count is directly correlating. We always thought it was temozolomide, actually. But eventually we realized it's a radiation therapy, and that could be. And the third is a paraiotic radiation. So paraiotic radiation also very large field. So if you can limit with a proton or high quality photon also, then they could have an impact. But the question I want to ask you is, I was in advisory board meetings also recently, there is quite a bit data that you don't need so much dose of Pembro and Nivo. And very low doses can do the trick. You have such a strong medical oncology fraternity throughout the world. Why can't we impress upon 2 or 3 companies to make formulations which are more scientifically relevant and of course financially relevant?
So sir, the problem is that pharmaceutical companies are here to sell their medicine and not to reduce the dose to reduce the profits. That's the frank answer. So what I'll tell you is there is already a good movement in that direction that immunotherapy doses need not be worsened. There is a formation of an optimal care alliance under the leadership of Dr. Ian Tannock. We also are a part of that, and the first meeting is going to happen in May, where people are been impressed upon that they need to develop schedules of immunotherapy which do not need to give such high doses. See, the issue is when they developed immunotherapy, they used the traditional 3+3 model, which says that you keep increasing the dose until you get those side effects. And the idea is that like in systemic chemotherapy, you will get somewhere down to like 33% of the patient would get side effect, and you'll say, okay, this dose is my maximum tolerable. You never reach those maximum tolerable doses in the immunotherapy. And by the time they reach those doses, in fact, to be fair with BMS had given a lot of patients 10 milligram per kg initially. And they then, looking at some pharmacokinetic modeling, decided to use 3 milligram per kg. But frankly, when you see the data, I think a dose of around 0.3, that's what Dr. Tannock recommends. He recommends 0.6 milligram per kg, and he recommends pembrolizumab at a dose of 1 milligram per kg.
You know, this flat dose formulation has to be immediately rectified.
Sir, the flat dose formulation, even if we, in the standard doses, like for example, Pembro flat dose versus 2 milligram per kg, or nivolumab 3 milligram per kg versus 240 mg flat dose, even if we go to the standard weight dose, you can reduce the pricing for the patient quite a bit.
The challenge I see is Ian is a Canadian. You need an American guy. Otherwise it won't work still.
So Americans won't come. Okay, that's a good question. So we used a dose of 20 mg, and what we did is when we so the 40 mg vial, we initially used to split the vial between 2 patients. So we used to give it only at two days and split the vial between 2 patients. But thankfully, there is now data which has come from 2 different groups, one from Japanese and one from American, that the nivolumab vial, once open, is active for 28 days. So you can keep it between 2 to 8 degrees for 28 days and doesn't lose its potency. So Indranil, I'll tell you what we did. So what we did is we actually started not only with this immunotherapy, started that vial sharing is important. I'll give an example, pemetrexed. The common dose comes around 600 mg. If you buy a vial of 500 and 200 mg, it is more costlier than buying a vial of 500 mg to 500 mg. So what we started initially doing is that all patients who are credit and or on government schemes, we actually start ordering 500 mg vials and started saving vials so that the last patient may not have to buy a vial. So we started with that as a small project. At the same time, when we were successful with chemotherapy, we did it for cisplat, we did it for pemetrexed, we did it for paclitaxel, then we started with nivolumab. Once we showed to our admin administration that we can save so much money of the taxpayers, our admin is now ready to bill per mg. So not on vial, it is ready to bill per mg. So we have started the system of billing per mg. So nivolumab vials will be kept in the daycare and the patient pays only for 20 mg.
PEM also?
Huh? PEM also, sir. Yes. So BEV, the problem is sir, BEV CNS में use करते हैं कम ही use करते हैं sir. BEV का usage हमारा lung में बहुत कम है.
So my question to you is regarding the gliomas, for the GBMs mainly. So you've used metronomic you are proposing, right? And then what about the metronomic temozolomide along with the
So that is one situation where there's a good evidence that metronomic does not work. So in temozolomide specifically.
I'm saying that in combination.
So what we have used is
you're starting with the CCNU, but you're not looking at the temozolomide.
So the study which I showed you actually has both arms. It has temozolomide RT plus mebendazole arm also, has a CCNU plus mebendazole arm also, and has a temozolomide plus mebendazole arm also. No, not with bevacizumab anywhere.
Okay, Dr. Anand has got one question, then we'll, I think.
I think if we are talking of integration of radiation with the immunotherapy, what literature recommendations are that radiation has to be, number one, dose per fraction has to be high, so it has to be SBRT kind of treatment. And there are keystroke trial and there are one or two more trials are there where they have combined SBRT, which itself has immune modulation effect, and combining with immunotherapy. So I think those are and especially in oligometastatic disease. And we have seen kind of results ourselves also. Sometimes we do SBRT alone and patient survives for long. We have one patient from Shimla, he got SBRT in one paratic node after multiple recurrences, surviving 6, 7, 8 years now without any further therapy. So I think there's something to combine high dose radiation. So if you're talking of concurrent chemo radiation with immunotherapy, that has a conventional fractionation, prolonged therapy, it may not work. I think the work has to be around SBRT and immunotherapy.
So with that sequencer, actually 2 papers came in JAMA Oncology in 2020, but unfortunately both studies didn't fail to impress upon that it improves outcome. That's why I told you that the problem is nivolumab works differently, pembrolizumab works differently, atezolizumab works. Each of them has a different pattern of working. And the way the companies are driving it at present and the way it is increasing, the biology has not been able to keep pace with it.
There are 10, 12 trials of SBRT plus immunotherapy.
Right, thank you very much. So bottom line is that if you have to use immunotherapy with radiation, it has to be with ultra hypofractionated doses. Thank you very much. Yeah.
Thank you, sir. For the next session, I request Dr. Huku to please chair the session, and I invite Dr. Anushil Munshi to please deliver his talk.
So the man of the future and the last batsman, I think this is also going to be an interesting topic. And as immunotherapy is coming in the systemic treatment, I think artificial intelligence will change the face of radiotherapy, and let us hear from Anushil what it is all about. So, please.
Thank you, sir.
And once again, a privilege to be standing here in LT1 and giving a talk. And again, extending my deepest gratitude to all the senior faculty members, many of whom have been instrumental in shaping my career, led by Dr. Sharma, of course, and then so many in the hall. And technologists, physicists, I think each one of them have really contributed to the development of my career and shaping it. Just when I got the call for talking about something new, so that was the start of this. So the one thing that came to my mind was speaking about artificial intelligence, and there were many hurdles, including just 5 minutes ago when Jayant cautioned me again, saying that what credentials I had to deliver this talk. And what was the connect between AI and Anushil Munshi. So I still mustered some courage, and here I am. So in the next 15 to 20 minutes, I would be talking about artificial intelligence in radiation oncology, some preliminary thoughts, and where we are likely to go in near, medium, and distant future. So I did a search on 24th of March 2022 with the key terms artificial intelligence, radiation oncology. In 2021, we had almost nearly 600 publications. Compare that with 2000, when there were just 2 or 3 publications related to artificial intelligence. So such a quantum jump in publications and interest in artificial intelligence in radiation oncology. There are varied definitions about artificial intelligence. For example, they could go like intelligence demonstrated by machines as opposed to natural intelligence displayed by humans or animals, or the science and engineering of making intelligent machines, especially intelligent computer programs, or machines that mimic the cognitive functions that humans associate with our minds. Now, whether we like it or not, AI has already impacted us. Whether it is the speech recognition, which we use in mobile devices, the Siri or the Alexa, whether it's the customer care, where there are online chatbots replacing human agents, and often on WhatsApp and this thing, we have this thing, or online also. Whether it's the conversion of digital images or videos into something more meaningful, and it has application in social media, radiology, imaging, medicine. Whether it is recommendation engines, where we use past consumption behavior data of consumers, and then the AI algorithms use this to develop more effective cross-selling strategies. Or then even the stock market, where billions and billions of dollars, they are traded without human intervention at all. So as coming to radiation oncology, we know we have moved from 2D to 3D, IMRT, IGRT, 4D, and then probably we'll be soon having AI-assisted, or who knows, fully AI treatment. Now, some basic terms. The umbrella term is artificial intelligence. And artificial intelligence means any algorithm where we have defined that this is the input we give, the algorithm, set algorithm will be used, and this is the output we are going to get, period. Very deterministic kind of a thing. Then inside that is machine learning. Now in machine learning, you have a set of variables. You have given the variables to the system, and then you are asking it to generate an output. And that is what machine learning will do it for you. And then you go to further inside that is deep learning. You don't prescribe any variables at all. No variables are given at all to the system. And you ask the system, give me the output, look for variables on your own. Do that work on your own. Train and retrain yourself on your own. There may be hiccups, there may be mistakes, but you train yourself and then give me this output. And it is self-learning ability, the deep learning component of artificial intelligence. Of course, you can also have a model where you stop deep learning at a particular checkpoint or a particular, you put a lock there after you have trained your model to a specific level, stop and ask it not to train itself anymore, and then use it for clinical use, passing it through regulatory bodies and approvals and so on and so forth. Because often regulatory bodies are very keen that there should be a fixed output for a fixed input, and it should not do some things on your own. So there are ways and means to alter the deep learning part as well. Again, the fitness of models, and this is often talked about. There could be an underfit model, which has high bias. There could be an overfit model, which has high variance, and there is an optimal kind of a model which has low training error, low test error. Another term which is commonly used is neural networks. This is a subset of machine learning. It's actually the core of deep learning algorithm. It's composed of node layers, which means there is an input layer, there are several hidden layers, and there is an output layer. Each node is connected to the other, has an associated weight, has a threshold, and there are ways by which whenever something is above the specified threshold value, the node is activated, it sends data to the other layer, otherwise no data is sent. So this is an example of a deep neural network. There's an input layer. Yeah. So this is the input layer, then you have multiple hidden layers here, and the other green is the output layer. Now, just to give you an example of what is input, middle layer, and the output. So, and this is one of the first things that came into artificial intelligence, the imaging part. So you have medical images, radiographic images, and these form the input layer. This is pixel information. These go into the middle layer, then you don't know what's happening there. But then the ultimate outcome is the output layer where, for example, just one example, the tumor is malignant or benign. Or for example, in mammography, microcalcifications are there or microcalcifications are not there. Now, these are the various steps or various time points or various positions that we experience in radiation oncology. The physician's intent, and the pink lines indicate the kind of variability we encounter when we are at a particular area or a particular zone or a particular time point. Physician intent, should I be treating radically, palliatively, dose, things like that. Simulation, image registration, contouring. You can see the big pink lines up and down. Again, a lot of variability. Contour approval, planning, beam placements, full arcs, half arcs, multiple beams, planning review, approval, physics checks, treatment, ongoing quality assurance, and then completion. So modern AI methods, this is about the modern AI methods and their application in radiation oncology, not fully there in the market, but this is where the world of radiation oncology seems to be going. So convolutional neural network, for example, can predict rectal toxicities related to radiotherapy for cervical cancers. Variational autoencoders can predict radiation pneumonitis in patients with non-small cell lung cancers. And then you have generative adversarial networks, or GAN, where the system kind of generates data, real and synthetic, which is fed to a discriminator, and the discriminator is challenged again and again and again. And this system is used for generating synthetic CT images. Now, this is a current flow of the responsibilities in radiation oncology. The blue dots, the radiation oncologists, the red, medical physicists, and the yellow is the technologists. Right from evaluation of patient, preparation, treatment, completion. That's fine. Now, where does AI come into picture in each of these now? At the treatment decision stage, there could be decision support tools that combine clinical, genomic, imaging data to support the precision oncology practices. In imaging, reducing the exposure. For example, the length of CT that we are taking at the time of simulation. Is it needed? Are we taking more? Are we exposing the patients more to unnecessary radiation? Position of the patient. Based on the diagnostic images, what is the ideal position, for example, for cervical esophagus. Should, in this particular patient, the arms be up, down? So the AI system could potentially foretell you the beam placement also that are likely to cause problems if your arms are up or down in a particular case. So that's why it could think in future about what's going to happen, and it could help you beforehand as well. Automated tumor and organ segmentation, and this has already come now. Automated tumors, organ segmentation, optimal dose prediction, promising again to streamline the planning process. AI tools may help expedite the quality assurance process and detect also, for example, in routine everyday treatment or treatment planning, there could be errors which are missed by the humans. Those errors, and we have example of this if you Google or see the literature, and AI could actually have a potential in detecting these errors, which could be very, very important in clinical practice, radiotherapy delivery, again, then in follow-up prediction of the complications, side effects, and so on. Now, just to give you example and flavor of some specific scenarios. Synthetic CT used to generate, now we all know that we have always been saying, no, we need the CT data set, it gives us electron density information, we cannot do without electron density information, it is a must for us, whatever you have done, and we certainly need. We have been telling all that for a number of years. But synthetic CT is now coming up, and it's used to generate images from the MRI images. So a patient could perhaps only get an MRI done, and you could generate the CT from it as well, and then plan the patient accordingly, and mandatory CT emulation could be done away with. Initial treatment decision making. So currently we base our decision based on symptoms, age, performance status, imaging, pathology, but there is a limit to the data that we can understand or interpret or use for calculations, and AI can again help in clinical actionable features which can prognosticate, predict, and so on and so forth. Organ segmentation. One of the speakers in the morning was saying the time it takes for contouring, segmentation, and so on and so forth, and AI platform is there to expedite the process and perhaps reduce it by 50 to 60%. And there are certainly evolving systems for organ segmentation available, including Birinda, RayStation, Ethos, which actually claims that it can not only do the segmentation, it can also online do replanning of the patients live while the patient has changed its shape. It will immediately do the replanning. We'll have to, I don't have my personal experience with this, but then this is what they are claiming. And then you have a very interesting tool from MD Anderson. They say, no issues, you just send us the set of images, we will contour them, we'll send them back to you. Contoured images will be given free. Back to you, you just have to go to this online site, you send this data set of images to us, and especially for the lower middle income countries, this service is totally free. It's not actually active. I tried doing that, but it's not actually yet, but it is going to happen in very near future. Treatment planning. So again, knowledge-based planning. So based on the previous plannings that have been done in your center, 25, 30, 40 plannings for that particular site, for those particular patients, you could actually have spare around 70 to 80% of the physicist's time by doing knowledge-based planning. Intra-treatment, while the treatment is going on, decision-making, for example, a patient of non-small cell lung cancer or esophageal cancer, undergoing radiation, based on imaging, we could probably come to know whether this patient is likely to respond to radiation, say after 20 fractions, we could do an assessment so that we can proceed for radiation or stop there and take this patient for surgery. Even simple things. For example, we did a small study at our center, a 4-year audit of consecutive patients. The overall time spent in the department was around 52 minutes, plus minus 33 minutes. Now, AI can actually pitch in here as well, knowing the status of the machine, sending messages, keeping the patient updated as to what the status is of his or her treatment in the queue today, so that everyone spends their time wisely and judiciously. There are so many modalities now in radiation therapy. The cross-modality learning and cross-modality talking is such an important thing. Radiographic images, radiation dose maps, hardware calibration log files, maintenance record, all need to talk to each other, and this can be achieved by AI as well. So what will happen to us? That's a very important question. So what will happen to radiation oncologists, physicists, technologists? How will we be impacted by this? So there is something called front of the house and then back of the house. So front of the house means patient interaction and things like that, and back of the house means, okay, you are sitting and working on computers. So both radiation oncologists and medical physicists are likely to move more to front of the house. So more and more time you're likely to be in front of, with the patients, likely to focus on high-level decision making and spend more time with them. Physicists, again, more time for research and things like that. And whatever, there is a set of things that are routine for us right now, and there are some things which are non-routine. So the blue one represents the routine things. The routine things are likely to go down, and the non-routine things are likely to go up. But likely not going to impact our job because of one or two reasons. One, because of the likely nature of the supervision part that needs to be done. Second is because of the likely rise in cancer cases that is likely to require personnel all the time. The other question, okay, AI, is it costly? Is it going to cost extra resources for nothing? Or is it going to be resource sparing in the longer run? How can it be resource sparing? It could be resource sparing by one at a general level, non-oncology level, in the sense identifying area of need, connecting funds. There is a giver here, there's a requirement of funds, and connecting the two together. Suggesting the right technology for the right patient, delivering treatment efficiently, reducing over-treatment, reducing under-treatment, assessing response early, reducing unnecessary patient burden, cost of ineffective therapies. We were talking about ineffective therapies, reducing their cost. For each and every technology in this world, be it radiation oncology machines, be it molecules, be it anything, there is a hype curve. There is an innovation trigger, this steep. So this is the expected expectations. This is the y-axis is the expectations, how much our expectations are. And this is the time on the x-axis. So for anything in this world that comes up new, whether it's a technology, molecule, anything, so there is a curve of, this is called the innovation trigger. Everyone is excited that this is going to be it now. And then you have a peak of inflated expectations. So this is at the peak now. You think that this is then you land in the trough of disillusionment. This blue thing is the trough of disillusionment. Funding has stopped. People think that this is a useless technology. Nothing is going to happen. And then you have some slope of enlightenment. And then finally, you have a productivity plateau here. Most of the technology. So in radiation oncology, for example, which are the two things that have really made a mark? One is Monte Carlo algorithm, really has been impressive. And second is inverse optimization, IMRT. These two things have really done something credible for radiation oncology, and each of these two have suffered with this curve, suffered from this curve. And artificial intelligence, again, is no exception. So, we will probably land up here somewhere with moderate level of expectations soon. One more issue with AI is the black box issue. It is a challenge of AI, which means that AI has given us an answer, but AI doesn't tell us that why did it generate that answer? What did it use to generate that answer? What are the studies or the trial or the data that it used to give us that particular answer that it is giving us now? And that is again a big problem. And then there is a translational gap. So you have a model development, you have its clinical impact, but between them there is a gap. Validity, usability, utility, It's only then it's going to have some clinical impact. And there's no harm if we take lessons from other fields. For example, there have been similarities which have been drawn between Rolls-Royce engines and linear accelerators. Both are leaders in their respective domains. Public is frequently the end user for both. Both need public to trust their decision-making, quality products and services. Around 3,000 engines of Rolls-Royce at any point of time right now would be in the air. And Rolls-Royce is continuously generating data for each parameter of these engines all the time, non-stop, 24/7. Imagine the amount of data. They have even gone to create Alethea, which is a model for robustness for the AI, including issues such as ethical issues, social issues, and things like that. And there are similar needs, I would say, for radiation oncology as well. Ensuring precise dose, accurate delivery, minimize LA downtime, treatment interruptions, patient throughput to be ensured, and so on and so forth, and monitoring and feedback of data. This is my final slide, and this is this SWOT analysis of what I feel about AI in radiation oncology. Yeah. Okay, strengths, weaknesses, opportunities, threats. Strengths. Use in almost every sphere of radiation oncology. Almost every sphere. That's a very important strength. Faster growth, we know about Monte Carlo, IMRT. AI appears to have even faster growth trajectory compared to Monte Carlo, compared to IMRT. Capable of handling infinite amount of data, capable of analyzing infinite amount of data. And then standardization of process. Today we have this center doing this fractionation, that center doing that fractionation, this center doing prescribing this OAR as the dose constraint for this. We can have standardization when we use something like an AI. What are the weaknesses? Variable accessibility to users. Not all users get to use AI or probably cannot afford. Need of robust web-based solutions. Dependence on high-performance computing hardware. Explainability, as I was alluding to. Why did the AI do like this? Need for validating deep learning tools. Training of users, that has to be done. Generalization. Now, generalization is an important thing. Human beings and AI have one similarity, one common drawback. Both don't know everything. Humans don't know everything about radiation oncology and what all has been done. And even AI doesn't know. AI knows only what has been fed into the engine making. And these are limitations for even AI as well. And that is why what AI gives you cannot be generalized to the entire population, perhaps. Opportunities, potentially practice transforming. AI healthcare market likely to grow from $2 billion in 2018 to $36 billion in 2025. Opportunity is reduction of failures through automated second checks. You have done something and AI is there to again check it, whether you have done it properly or not. What are the threats for AI? Product fails in an unexpected manner. Misuse by operators can happen. Mitigation to expected failure has not been adequate. You have not done much to mitigate the expected failure. How to preserve innovation, creativity, and patient safety. Ethical issues. Who takes the ethical responsibility? Regulation of devices. And the hesitance on the part of clinician and other personnel to lose control. So if you don't want to lose your control, it is potentially a threat for AI. You won't allow AI to grow. Now with those words, thank you all very much. And indeed, this is the topic for this year's Astro as well. Artificial intelligence and emotional intelligence for the patient in a wireless world. Thank you all very much.
Thank you, Anushil. I think the topic is going to go for a few years. There are some areas where there is immense amount of data, as you said. Every day new papers are published, and as human beings we cannot assimilate all the knowledge. We have things like up-to-date and things like that, but there it can help. Then, as Anand said, in a monitor we cannot see something. They can guide you, oh, come on, you are missing these things, and, it can give you a better perception of things which you are seeing. It can help very much in quality assurance, the errors and things can, time management. So there are so many things. But with all this, is the cost going to go up or down for the patient? That is another important thing.
So maybe initially it's going to go up and later maybe go down. So again, there have been talks about the cost and there have been talks about pay models for doctors also.
And can it be like a driverless car?
So
rather than doctorless radiation?
So rather than fee for service, they are saying fee for value, which means how much value you are contributing to the robustness of the entire treatment.
You will not be there. Your driverless car, doctorless radiation oncologist treatment.
But that's a long way to go, but it might happen.
I think that was very real.
Which state?
What will be the future of radiotherapy department PGI?
Hesitancy to lose control.
What about
if you not lose control, then AI is gone, finished.
What is the future of radiotherapy department PGI? Front office managers?
No, that will remain.
Yeah, I had shown
I'll
that
tell you
diagram.
something interesting. Yesterday, we had a IT workshop in Apollo. All the Apollo people, they happened in the Proton Cancer Center. And Dr. Sangeeta Reddy was there, so I was moderating one of the sessions. So same thing they said, actually. So Tesla is there, face recognition is there. So Apollo is going to launch a program in the next, I think June or July, they will start. They have estimated 35% of the patients are second or third timers across all healthcare. Cardiology, apparently very good model in AI. I think you may be knowing. Oncology is actually 70 to 80%, they keep on coming. So the model is as soon as the patient enters the door, the face recognition will be there. By the time they reach the clinic, every single thing will be there on that. So that is a small example. But as you rightly said, medical oncology, there was a lot of excitement. So IBM Watson was a spectacular failure. So much investment, so much thought process, so much,
Correct.
You have the targeted therapy, mutation, and you go it, and same situation should not happen in radiation oncology. So one has to be very careful. So I wanted to ask you, among all the things, Dr. Huku already mentioned QA and all that, I was thinking maybe adaptive it will help. Because the CTV, PTV margin, what are the likely changes depending upon the data that you have. The auto segmentation is already happening to some extent. Where are the other areas you think which we can readily, very cautiously adopt it such that it should not fail otherwise, like IBM Watson?
So I think it's already one vendor is already providing that auto deformation and auto calculation while the patient is there for the session. So things like that, yeah, on the go. So these things are happening. But I feel that additions such as synthetic CT probably are, if they are tested well, maybe a safe addition to begin with.
What is the big deal with doing a CT scan? You are doing cone beam every day.
Yes, yes. See, engines are, no, hold on. Engines are made by, engines are not always by Rolls-Royce. Rolls-Royce is the maximum, followed by GE, and there is then one more company. There are 3 companies that are making engines. So I don't know whether it was a Rolls.
It's not safe.
So it is said that when a clinician is analyzing a particular case, it has, the clinician has 6 or 7 variables in the mind. Not more than that. You may be the most brilliant guy in the universe, but you will not be having more than 6 or 7 variables in your mind when you're making a decision for a particular patient. That seems very little, but that is what it is. and compare that with AI. So it has to be done cautiously, but then without losing our jobs. It'll happen overnight then.
So it's pertaining to imaging. I have a question for you there. You know, there are studies which have shown that on certain X-ray patterns or early CT changes, you can pick up and predict the malignancy or predict an infection or whatever. So my question to you is regarding our treatment. Are there certain changes which can be predicted on imaging, which can say that a patient will fail, will get controlled, or will have a complication?
Yes.
So maybe that is where I'm looking at that AI could assist the human mind, you know, that on a follow-up, something that we are not able to pick up right now. So but AI could help us.
Yeah, so not actually, I think the process should start intra-treatment only while the treatment is going on. So that we are cautious either in withholding and subjecting this patient to some other treatment or giving an extra dose of radiation to the area where we find, and radiomics is actually coming up in a big way towards that end. I think, Jayant, you have done some work? Huh? Yeah.
Pertain to that of basically how changes happen in following during the radiation treatment. So mostly I've done work mostly on baseline scans using machine learning tools, especially random forest models and SVM modeling, to classify brain tumors into certain molecular patterns, especially with medulloblastoma. This just got published in PGR, wherein we classify using radiomic patterns, both first order as well as higher order texture features, to classify medulloblastomas into various molecular classification. But having said that, yes, there are certain papers, the evidence is now coming up regarding using radiomics and texture features, using machine learning classifying tools to also predict whether the given person will have a better local control or fail, or will have toxicity. Yeah, or will have toxicity.
So, you know, it's especially true for a 7 Tesla or an 11 Tesla MR in the research that besides the texture, the vascular changes and the white matter changes and the cellular changes, they can tell us. I don't know much, Madhab, I just read a little bit about it, but I'm interested in knowing if somebody knows.
So here it is. As you rightly said, the vascular changes and the cellular changes, the surrogate, some of the radiomic features are the surrogates for these cellular changes, the hypoxic changes and the angiogenic changes. And this has been very well depicted in some of the papers that first order statistics such as entropy, standard deviation, kurtosis, uniformity, energy, and all those things, they are surrogates of these biological changes. And then using these texture features, you have classification models. You basically, you will have multiple features where you basically use radiomic tools to reduce these features and then classify using these models to come to a particular endpoint which is of interest to you.
But Jayant, the issue is, for example, the processing of these images depends on where you are processing these, the site where you are processing these images. The same images, if you process at a different engine or a different site, will give you a different kind of a result.
Yes, this is the basic problem for radiomics. This is the basic problem in radiomics.
Inconsistency that happens there.
Yeah.
That is the problem. That is the crux of the problem.
So there are certain tools where you basically this is a real world scenario. You will have clinical images which are heterogeneous. I mean, an MR image from Tata Memorial Hospital will not follow the same protocol as for in PGI. So you'll have imaging heterogeneity.
Because your acquisition has been different.
Yeah, absolutely. So
you have used different MA, different PV and everything. So your output is likely to be different.
Right. So there are certain tools wherein you have to pre-process those images and normalize them to have as much uniformity as possible.
Correct.
So that's the first thing which you have to do. So, I mean, these are the limitations of radiomics and AI, but you have to deal with that beforehand, before you can actually do the actual processing and go with the radiomics workflow.
That's why AI is called still artificial. So anyway, nice talk, Anushil, and I think very soon we will see at Indira Gandhi Airport Terminal 3 a mural of artificial intelligence, a machine hand and a human hand. This mural is being opened very soon. So maybe it is opened. Maybe it is opened. So this is maybe next time we have alumni meeting, we will, Anushil, will have much more data for Jayant and everybody will feel that, no, Jayant, ask him about his ability to talk on artificial intelligence, so he will have some personal data. So thank you very much.
Thank you.
And this was the last talk, I think, and over to organizers. And thank you very much for giving us this opportunity to be at Chandigarh today.
Thank you, everyone. With this, we come to the end of the scientific session. I request everyone to please proceed to front of the Carom block for a group photo.